Yes, good afternoon, everybody. I would like to welcome you all on behalf of the organizing committee, the second day of the update in the respiratory and the critical care medicine. This talk is on the updates in the occupational lung disease, and it will be taken by a very eminent speaker, Dr. Subrata Moitro. Today, I have the honor of introducing Dr. Moitro to all those who haven't and who doesn't know him, but I think it's a privilege for me. Dr. Subrata Moitro is a senior researcher at the Division of Pulmonary Medicine of the University of Alberta, Canada. He obtained his master's degree in physiology from the erstwhile Presidency College, Kolkata, and his PhD from the University of Kolani, West Bengal. He has been a postdoctoral researcher at Lund University in Sweden and Barcelona Institute for Global Health. He has received several awards and accolades and has many publications in his credit, including the very prestigious European Respiratory Society Research Fellowship. He is a member of the Assembly of Occupational Lung Diseases of the European Respiratory Society. His primary research interest is in the field of epidemiology, although he is equally interested in respiratory physiology and the chronobiology of respiratory diseases. For his extensive impact and impactful research on public health and occupational medicine, he has been elected Fellow of the Royal Society for Public Health. So now I welcome Dr. Subrata Moitro.
Thank you
And
very much, Dr. Moitra. It's
Moitro,
really
the stage is yours.
a privilege to be invited for this meeting. Although I'm not a physician, but I take pride in that. Despite being a physiologist, I work with clinicians, so that's a pride. Anyway, I'll just start with my topic, which is updates in occupational lung disease. So. So to start with, I have some disclosure, financial interest with European Respiratory Society, Synergy Respiratory and Cardiac Care, Elsevier, Barcelona Respiratory Network, and Apollo Clinicals, and I have also received non-financial support from Oxford Publications. So occupational lung disease is a very demanding topic, and because of its global prevalence, occupational lung diseases are a global issue, and although the magnitude of this problem in different parts of the world is difficult to estimate because of the different type of exposure that we can observe in different parts of the world, different type of etiology, and also geographical locations and other demographic characteristics of that participants, the diseases could be different, and this topic has been neglected so far compared to any other environmental issues like air pollution. Although we know that it affects a large group of people every year, almost 2 million people die each year from any occupational disease or occupational accidents. And nearly 30% of them are due to lung ailments. And we know that from the Bhopal gas tragedy that has killed more than 15,000 people and has paralyzed almost 500,000 and left them to suffer for innumerable decades. So although we supposed to think that occupational diseases are mostly prevalent in the developing countries, but this scenario is not very true. We see a lot of new exposures and new types of occupational lung disease in the first world country, and particularly because of the new types of exposures that are being introduced in different kind of industries. And also there are some old exposures, as we say, old wine in a new bottle. There are a few old exposures that were reappeared in the 21st century in a new form. For example, silica that has appeared in a new form in the 21st century. I'll come on this topic later. So recently I wrote a large-scale narrative review on new exposures of the 21st century, and we have highlighted several new exposures. So because of this time limitation, I'll just touch the base of only two particular exposures that are of particular interest. One is the artificial stone. So artificial stone is, or we know them as a reconstituted stone or quartz conglomerate, is basically an alternative to conventional marble. And although we rarely see these things in India or any other LMIC countries, but this thing is very much prevalent in the first world country, as the kitchen tabletops or bathroom fittings are often made up of this uh, particular thing, artificial stone. It contains a very large amount of silica, more than 90%, or even sometimes fully 100%, far more than natural, far more than the silica constituents in the natural marble, which is roughly 3%. So that means that the exposure from silica is even higher from dealing with artificial stone than in case of, if the worker is dealing with marble or granite. And during the cutting of these stone slabs, a very large amount of ultrafine silica, sometimes in nanometer scale, that are produced, and they remain in the breathing zone of the workers and are readily inhaled by the workers, because of the particular size of these fibers that are so small that the conventional masks or any other personal protective equipments are not able to restrain those particles from entering into the respiratory tract. And there have been several publications on this particular topic, mostly from Israel and Turkey, that have shown that artificial stone was found to be associated with lower pulmonary function, higher neutrophilic inflammation, and increased pro-inflammatory markers and silicosis. So I'll just try to show you this HRCT picture over here that is published recently in 2020 in the Journal of Medical Imaging and Radiation Oncology. And has shown that this is a case of an artificial stone exposed worker, and there is a progressive massive fibrosis mostly in the upper part of the lung, which is a little bit different from the conventional silicosis cases that we see, mostly the mid and lower part. And that's also been highlighted as one of the most important findings, that the HRCT findings in these cases often differ from the classical silicosis, with progressive etiology, atypical signs of ground glass opacity, and nodal enlargement. That means that this type of exposure may induce some sort of idiopathic changes in the lungs, not really known what they are, which are different from silicosis and very difficult to diagnose at the first instance, because sometimes the occurrence can happen in a very short time, within 2-3 years after the exposure, or sometimes they have a long latency period, like for 10 to 15 years, and after that the disease is diagnosed and there is nothing to do at that moment. The patient died in a very short time. So this is one particular exposure that we do not see in India, although we really don't know whether in a conventional marble cutting or stone cutting is actually impacting the lungs, how much the impact is, and if it is different from the artificial stone. We really have no good data from India so far. Another important aspect is ITO, or indium tin oxide. So indium tin oxide was introduced some 60 years ago as a fundamental element for semiconductor production. Although later they mixed indium oxide with tin oxide and gave it the name indium tin oxide, and that has a larger use so far, like the dental alloys, batteries, thin film, infrared reflectors, LED and plasma, flat screen displays, etc. So first case of indium lung disease was found in a worker engaged in wet surface polishing. So that was some 30 years ago that the patient was diagnosed with a sign of interstitial pneumonitis. And then after 2000, Christine Cummings from the National Institute of Occupational Safety and Health of the United States, and her group has published several landmark publications on this particular topic, and they've shown that the ILD was the most predominant disease etiology in this type of workers. And also, it was associated with the production of pulmonary alveolar proteinosis, as you can see over here. The red pigments has been the protein deposition, and also fibrosis and cholesterol clefts. So as you can see over here, this white small needle-like structures of the cholesterol clefts that appear to be inside the lungs of this kind of workers. Not only this, the respirable indium was found to be associated with some very important and rare lung diseases, such as, and that also with biomarkers of those diseases, like this Krebs-Mondon-Lingon 6, and that is also associated with the higher level of autoantibodies to the granulocyte monocyte colony stimulating factor. So these are primarily two very important topics in the world scenario that we are now observing, and the number of cases are increasing. Although there are several regulatory authorities and workers' compensation plan and benefits and health insurance and so forth. Now I would just like to touch the base of one particular sector that has remained undermined in Indian scenario, which is the welding. So in welding, cadmium toxicity is very much common, and cadmium is, as we know, is the group 1 carcinogen denominated by the Indian Agency for Research on Cancer. And cadmium exposure can be found in our roadside welding setups, in the goldsmiths who actually produce gold ornaments, gold or silver ornaments, because they use a particular material you probably have heard of, this called KDM. So basically KDM is the marketized name of cadmium, and as you can see over here, the cadmium is melted with gold to give it a firm shape. So, and this yellow pigment over here is basically the cadmium film. So cadmium gives a yellow flame. And as the worker uses a blowpipe, so it's quite possible that some of the fumes are also inhaled through the blowpipe. And as you can see, the distance could be just merely 3 to 4 inches from the nose to the flame, the fumes. So the fumes are also inhaled readily by the workers. And cadmium can affect the kidneys, lungs, liver, bones, gonads, CNS, and whatnot. So during the welding process, cadmium fume is generated that can enter the airways of the workers. And I did some work on cadmium toxicity on the goldsmith, and we published a paper in the American Journal of Industrial Medicine some 5 years ago, and we found that the cadmium concentration in urine of the Indian goldsmiths was as high as 80 times than the recommended exposure limit that we found that was set by the Occupational Safety and Health Administration of the United States. So as you can say, the reference who were not exposed to cadmium, they had a mean urinary cadmium concentration of just 4.7 microgram per liter, whereas an exposed worker had 61.4 microgram per liter. So this is in deciliters. So I just multiplied by 10. And the range was as high as 90 microgram per liter. So that was extensively high. Now, the cadmium toxicity can cause lung function deficit. So we published a paper in Thorax back in 2013, where we used a log value of both urinary cadmium and FeV1. And you can see in the left panel, this was the cadmium concentration and FeV1 correlation of the referent workers who didn't have that much exposure to cadmium. Whereas the people who were engaged in the fabrication process and also polishing of the gold ornaments. So they were heavily exposed to cadmium and they had a reduced FEV1. Not only that, we also did dig a little bit more into the scenario, what happens in the systemic circulation. So this left panel is a single red blood cell, and we used atomic force microscopy to see what is the condition of the red blood cell, whether, because we already had seen that the red blood cells got fragile more into the exposed workers. So we saw that, you can see from this curve that the RBC had a perfectly a concave, or even actually a biconcave shape. Whereas for case of exposed workers with a high cadmium concentration in urine, the normal biconcave shape is not present anymore. And we also used a two dimension first Fourier transform, and as you can see the noise, so the noise actually indicates the roughness of the RBC membrane. So that means the RBC were more rough in the exposed workers. We also used induced sputum to see what are the different types of cells. So the upper panel is an unexposed worker. We see a lot of macrophages, a little bit of neutrophils. But in case of exposed workers, the number of alveolar macrophages dropped down markedly, whereas the number of neutrophils, percentage of neutrophils increased quite significantly. And we also tested whether there is a DNA damage of the sputum cells. So, and we also found that compared to the referent population, people who were exposed to cadmium, they had a significant higher amount of DNA damage in their sputum cells. So recently, we published another manuscript in Toxicology and Industrial Health with Dr. Moitra, and we found that in people who were exposed to welding fumes, they had a very low number of alveolar macrophage percentages, is 28% compared to around 75% of the referent population, and had significantly higher neutrophils. Not only that, we also found a very high amount of neutrophils. So it's 9%, which is way above than the recommended 3% in the sputum. So, but the amazing fact that most of these exposed workers were asymptomatic and didn't even have a cough. So we also went deep to see what is the nature of the alveolar macrophages, whether alveolar macrophages are actually able to phagocytose. So we did atomic force microscopy and also scanning electron microscopy. And this down panel is the scanning electron microscopy of an alveolar macrophage, this of a referent person. So this is a perfectly normal shaped. Whereas in case of an exposed worker, it appears to be that the alveolar macrophages are not in proper shape or has a higher membrane fragmentation that could be resulting to reduced phagocytosis capacity of those alveolar macrophages. So that could also be a possible case of some sort of pneumonia that may not be determined at the time, but could be there. So
Dr. Moitro, I think we have we crossed the time. Can you please?
Okay, so I'll just I just have 2 slides only. Yes. So the diagnosis could be made based on the classical algorithm that were published long ago, and we have republished in the Encyclopedia of Respiratory Medicine very recently. So the clinicians should follow this guideline to identify occupational asthma, for an example, and the prevention and management should be prioritized because, as per this diagram that we published in Lancet Respiratory Medicine 2 years ago. So the personal protective equipment that we actually give more consideration comes at the least prioritized area. So eliminations, substitution, engineering control, administrative control, these are all prioritized over PP. So in summary, occupational lung disease have a major problem. Globally, preventive measures can be implemented, although is not applicable to many sectors. Diagnostic inaccuracy, delayed and discontinued treatments could be some of the reasons that for the higher prevalence and incidence of occupational lung disease. And the clinicians, of course, I think they are not very interested to ask a question about occupational exposure, and this scenario is present everywhere. So with this, I just end up my presentation over here, and thank you very much for your interest.
Thank you.
Yeah, thank you very much.
Both Dr. Moitro and Dr. Both of you are Dr. Moitro. Myself, Dr. Asif. I'm the intensivist in Apollo Clinical Hospital and look after the respiratory critical care. So we are in a hurry because we have a next lecture.
Yeah.
So thank you. And the next lecture is current approach in COVID associated pulmonary aspergillus, and the speaker is our eminent sir, that is Dr. Arunalok Chakraborty. He is a Chief Director of Medical Microbiology in PGI Chandigarh, and Dr. Shubhashish Ghosh is a Senior Pulmonologist in Apollo Clinical Hospital. Sir is the chairperson. So I will request Dr. Arunalok sir, please, dais is yours. You start your presentation. Thank you, sir.
Thank you, Asif. Now, before I start, can I just have one or two words about this disease called kappa, which has caused a major problem because the mortality in those who've got ARDS with kappa or secondary infection with aspergillosis is pretty high, twice that of those who never had aspergillosis in COVID era. And we have a lot of problems, and Professor Arunalok Chakraborty is the right person to enumerate and explain. And I'll hand it over to Professor Arunalok Chakraborty. It's a great pleasure, sir, to have you as a speaker. And there are so many questions because we don't do bronchoscopic sampling. Non-bronchoscopic sampling is difficult because it's not validated. And serum galactomannan is so poor sensitivity in this group of patients, has a sensitivity as low as 20%. So diagnosis is difficult. And here, Dr. Arunalok Chakraborty is the right person to give us a brief outline. Thank you, sir.
I was trying to have the slides. I'm not able to. Oh. My problem is happening in case of slide share. Can you see my slides? That's my.
We can see the screen, but not the slides, sir.
Oh. Let me.
I can. Your screen is visible.
Oh. Good. Can you go to the next lecture, because it's getting some problem in case of this slide share.
So shall we take your lecture after the next lecture?
Yeah, just.
Asif, then let's proceed that way. Thank you, Dr. Asif, you unmute yourself. Asif, Asif, you are muted.
Yes, yes. I'm audible now.
Now you
Yeah,
are.
just carry on this particular. There is some problem in opening the slide. I'm just taking 2 minutes, but by that time you start the next lecture. I don't want to waste time.
Yes, sir. So our next topic is a panel discussion, role of ECMO in COVID ARDS. We know that there is a lot of ECMO happened in last 1 year due to the COVID pandemic, and the moderator with us, Dr. Amitavo Saha, is a senior consultant and joint director in the Department of Medicine and Critical Care in the Medica Super Specialty Hospital. Along with the other panelists, Dr. Orpon Chakraborty is a senior consultant, cardiac anesthesia and cardiac intensivist, and in charge of extracorporeal therapy. And also Dr. Thomasis Mukherjee is a consultant CTVA surgeon and in charge of ECMO services in Apollo Gleneagles Hospital. And Dr. Shoham Majumdar is a consultant critical care specialist and also in charge of ECMO services in Amri Hospital. So Amitavoda, I will request you, please moderate the session and
Thank you, Asif. This is a wonderful platform to discuss about the ECMO, which is now a theme in face of this COVID pandemic. There are a lot of patients who need the oxygens, and I have actually taken the loan for this next sentence from Orpon, that the right to oxygen. This is probably demand for days, that the right to oxygen should be our primary things also as well. So in this pandemic, in COVID situations, we have actually faced a lot of issues, especially with the hypoxia and the oxygen demand, and ultimate the ECMO probably could save a lot of patients across the world, and especially in this part of the India. And we have a very good and probably one of the best team in our city. And I am very fortunate that probably the best team of ECMO that I have worked with. And let's start. I'm just trying to put one or two cases arbitrarily, and then we will carry forward the discussions about the ECMO, what are the problems, and how we can actually utilize the ECMO in a best possible way for in this pandemic, and also any patients who will come in future as well to manage the hypoxia and meet their demand for right of oxygen. So I hope everybody can see, right? So we have panelists, the great panelists, Dr. Orpon Chakraborty, Dr. Thomasis Mukherjee from Apollo, and Dr. Shoham Majumdar from MRI. These three and the others people have actually done a good job for the city and saved a lot of patients. And we are being in the ICU, we are really relieved as when we see that the ECMO team is there, and they are there to help us and take the patients when we failed with the maximum possible uses of ventilations. So there are some case scenarios like the case one we can discuss about the 65 years old COVID positive 15 days back, diabetic and hypertensive along with the obesity of BMI of 36, was on NIV, underwent coding. It's failed. He was intubated. He is now 80 for last 6 hours. PCO2 around 16, 70, PQ around 7.3. CT severity score is around 38 out of 40. Single organ dysfunction and sepsis ruled out. Now this is one case scenario, and another case scenario is around a young chap of 35 years with the COVID positive 1 month back, was on NIV, failed. Now FIR2 of 1 for 2 days. PF issue around 50 to 60. Sepsis, all the markers are elevated. Recently, he is having a septic shock. There are early mods and CT severity score as around 40 to 40. Now, taking these scenarios in two scenarios, one, the patient is elderly with a comorbidities like diabetes and hypertension, and another scenario where the young guy who is also suffering from sepsis and ultimately without having any comorbidities develop some organ failure. So in these two different scenarios, how my colleagues will carry forward, like I'm just putting this question straight forward to my panelists. What are the indications for ECMO in COVID-19 patients? It is, if we look at it, it is the age or the PF ratio, how you choose your patient for the ECMO. Because as I understand, when we started this pandemic initially, we have taken a lot of patients for ECMO, and our outcome was not probably as good as expected, because we have actually chosen a lot of patients where we come to know in later on stage probably those are the patients who will not do better on ECMO. So at these scenarios, after having the ECMO supports for like 8 months to 10 months, so what are the take of yours, that what are the indications for ECMO patients, especially in this scenario where the COVID pneumonia is there, and all we know that the COVID ARDS is something slightly different from the ARDS that we suffer for any other situations. So can I go straight away to Arpon?
Thank you. For the indications of ECMO in COVID-19, is if you say to me that the current pandemic is going on, obviously I'll take the age as a cutoff of 65. But if as the pandemic is clearing and we are in the declining phase of pandemic, we have raised our bar of age more than 65. So age is no more a bar if it is below 70. And both the two case scenario, what we have told, one is an acute scenario, which is a 65-year-old without any second organ dysfunction. So we will like to go for all out for him for an ECMO. Second case, which is bit late, 1 month of already disease has gone and he has got intubated over there. He had some early features of MODS, and which is very much obviously to be taken care of. Obvious, frank multi-organ dysfunction with some CNS issues we used to rule out for some patients. But in COVID, we have seen that renal failure is no more a contraindication for an COVID. Obviously, liver failure, if it is only at the transaminitis level or some bilirubin rise, you can obviously you can go for a 35-year-old guy with this kind of liver issues. And third thing is the PF ratio. Obviously, PF ratio we have to watch, but what we have seen, the PF ratio, we have to check it for a prolonged time, because sometimes they respond to proning, the first proning very well, but from the second proning, the PF ratio attaining after proning is not that great. So we have seen the patients who are improving on first proning, but not that much improving on the second or third proning. Then we took PF ratio of less than 1 to discuss with the families. And till our mean PF ratio, we have given 0.7, 0.6. PCO2 is obviously a problem. Usually, this is a kind of type 1 respiratory failure most of the time. But PCO2, we have seen it has gone up very frequently in some patients because of the what you have told. This ARDS is not a clinical ARDS like H1N1. It has some component of pulmonary vascular pathology. So you have some kind of dead space ventilation which is happening because you have blocked pulmonary vessels. So that time the PCO2 can go rise, and because of the dead space ventilation. And if your pH is getting compromised, if it is less than 7.2, your PCO2 is more than 75, you need to take them on ECMO.
Okay, thank you, Arpon. Just want to, the one thing I need to mention here, that basically what most of the time what we will look for the failure for the pruning, but there are some subgroup of patients where we are facing with some problem with pruning. There may be questions whether can we go for a straightaway ECMO before pruning, like a patient is morbidly obese. There are a lot of patients they are suffering from because could not possible to give a pruning trial. So there are subgroup of patients where we can actually consider ECMO straight away without having a pruning.
Yeah. Two cases, two instances I will tell you. What you have told, one is the this hemodynamically unstable and morbidly obese who are not very good prone from the technical point of view. And the second case where we have directly gone on ECMO, like where we get a call from a retrieval from a nursing home where pruning is not possible. So we went there, we put them on ECMO, and we take them to our center
Yeah,
without.
this is a yeah. Thank you, Arpan. This is a good point. Basically, we need to remember and to practice accordingly. So I need to go to Soham. Soham, what are the contraindications for ECMO in COVID-19 patient? Where you have been referred for the ECMO for any patient who is not been doing well on even with the best effort from the ventilator side, and you have been called and you are not happy of putting this patient on ECMO.
Thank you, Amitabh, for asking. For my clinical practice in the for the COVID-19 ECMO purpose, main contraindication obviously during the pandemic situation, as Arpanda will be tell, like the age. If someone give me a call to put a patient is on ECMO and it is 75 years of age but no other problems, I should think about that. Or multi-organ involvement, I should think about that. Should I go for that or not? Because in this resource limiting situation. Apart from that, reversibility of the lung. Patient, how from when patient is get a positive, how many days patient is on a NIV or non-ventilatory supports, followed by ventilation of how much days, because of 10 12 days of 14 days of ventilation, a sudden repeat deterioration of the patient, and then the plan for the ECMO, probably that is not a good choice regarding this situation. So a good patient obviously are fulfilling all criteria, admission within 7 to 10 days, specifically mechanical ventilation within 5 7 days, and trial of the proning is absolutely done. And after that, our PF ratio is less than specifically 180 or 50, whatever. And as Arpuna says, the PCO2 level is getting high, more than 65 or 70 with pH less than 7.25. This will be a good categorized patient for this during the pandemic situation when we will prioritize to patient to put on ECMO. And for the high BMI support, BMI more than 40, regarding this pandemic situation, if other comorbidities also present, then I also think about the more than 40, not the 35 or 30, more than 40 of BMI, as also is also saying about that. But only adrenal failure should not be a contraindication with the patient.
Thank you, so taking a clue from your nicely explained the criteria. I'm just taking about the obesity, because Orpon probably will be agree with me that our experience with the obese patients are actually better than patients who are very lean and thin. So I would request Dr. Thomasis, what is your take on this point?
No, we have actually done a couple of obese patients, morbidly obese. Our results have not been all that great with obese patients. I don't know, it was a little late initiation probably, and the age was also a little high. So we did not have a great result with obese patients.
I'm just trying to put the questions in this way, that if there is any obese patient, like morbidly obese patient, like BMI of around 40, will you consider the ECMO much earlier? Will it help for that patient, or
probably yes.
A fair trial on ventilator, proning, and everything that we do normally before considering the patient on it?
No, I think we should go in early. I think we should go in for early ECMO initiation in case of morbidly obese patients, because we keep losing time with ventilation and proning, and they don't turn out to do all that great. That's from our experience.
Okay. So thank you, Thomasis. Would like to go to the next slides. There is a patient who is having 50-year-old male, COVID-19 positive around 15 days back, intubated, PF ratio around 45 for last 12 hours, all conventional measure failed, and plan to initiate ECMO. Now, what are the investigations or the things that you would like to get before initiating the ECMO, or planning for the cannulations for ECMO? Just in a very short, just 1, 2, 3, 4 points. Who will take these questions? Orpon?
Yeah, I think so. I actually don't need any special investigation before initiating the ECMO, except those.
No, would you like to have a coagulation profile before that, before cannulation?
No. The thing is, the problem is, if you have a very good coagulation profile, even on and the patient is not doing well, so I will not consider the coagulation parameters as a hindrance to my ECMO initiation, because in COVID-19 we have seen that D dimers are more than 8,000. You have a deranged rapidity, you have a deranged liver functions and all these things. But that has been corrected when you put them on ECMO, because all these are happening because of your oxygen is not reaching to your tissue level. So my thing is, if the patient is not actively bleeding internally, like some GI hemorrhage, our first referral was for a patient of chronic liver disease who had some GI bleed. Those patients I will take care of. If they're even on coagulation profile normal, those patients I will take in a control, or some kind of internal bleeding is happening, or some kind of internal hemorrhage, previous history of cerebral hemorrhage. Those patients I will initiate before initiating on ECMO. So that is the one thing I will go for. And probably as it will include some patients from in hospital and out hospital, I want to see a probable CT chest before putting them on ECMO. But that is not a very mandatory thing, because sometimes it is not possible before putting on ECMO going for a CT chest, but that is going to patient the more harm. Why I am going to tell you because or an X-ray, just to is there any feature of pneumomediastinum or pneumothorax is there or not? Because this is going to determine your outcome on ECMO in a very harder way, because these patients who have a air leak syndrome on ECMO, they don't do very much well. I got at least 10-15% of patients, and they didn't do very much well. So this is for my prognosis purpose. These two things I want to especially go for. But otherwise, there's a normal routine thing, presence of sepsis and other to rule out.
Thank you, Arpon. I am just going to Tamashish. Tamashish, there is a problem. One of our patient having a femoral vein thrombosis. Whenever they are actually, we have referred to the ECMO team, and they have found out doing USG on the femoral vein, it is being thrombosed. So how would you like to go for this patient? This patient needs ECMO. It is indicated, and you have planned to put the patient on ECMO, but this patient needs the cannulations. Now the femoral veins are being thrombosed. What do we do?
Bilateral femoral venous thrombus. Is it a bilateral venous thrombus?
Yeah, bilateral.
Then I would like to use a single cannula then on the jugular side,
Right.
Two-stage cannula.
Okay, so rest of the questions I am not putting. Almost we have been discussed about. So we may go for the next situations. Again, we have initiated
running shortage of time
on 45 years old with the COVID-19. We have initiated our own heparin infusions, and again the platelet has gone down. Now, how will you manage this patient?
Amitabh, we are running shortage of time, so answers should be pinpoint.
Yeah, sure.
Yeah.
So, yeah, you take this question.
After 5 days, obviously, if it is not hit, or if it is hit, also we have to stop the heparin infusion. That is true. And as the COVID-19 patient on ECMO, we have some bad experience with different sides bleeding, specifically on the tracheostomy sides and the GI bleedings and different bleeding. For COVID-19 patient purpose, I probably will sometimes I have to maintain with a off heparin ECMO with a high flow circuits, if it is possible. If it is not, then I can think about any other direct hormone inhibitors to give. Otherwise, initially for this patient, I have to be.
Any of our panelists have that experience of using the direct antithrombin instead of heparin in case of this hypo?
Yeah, I have an experience, but that is not in the COVID. Before the COVID, I had an experience. It was a probable documented as a hit, so that's why we have a used direct hormone inhibitor as a therapy.
Thank you. So this is a scenario. I am just going very fast that the 5 different patient on ECMO, because I have seen in our institute that there is a big room, big 2 rooms that the patient is, all the patients are on ECMO. Now you are being an ECMO specialist. How do you prioritize your rounds? Because these are pandemic situations, right? So a lot of phone calls for the retrieval, lot of patients on ECMO. There is a lot of patients relative to manage, and how you manage? How you manage these scenarios now? Okay, we are much comfortable, the patient situation and the pressure has come down. But one point of time, it is there that 11, 12, 13 patient on ECMO, and there is a lot of other calls are coming, and you are just giving rounds on the ECMO patients. So how you plan? How have you gone through for last 3-4 months? So Tamashish, take this question.
No, we have had a maximum of 2 patients on ECMO at a time.
But again, okay, even if it is a 2 patient, Because how you plan for this patient, because two patients are not probably in a good shape. Out of one patient is slightly bad, one patient is probably improving.
The one probably improving, I would give more time, and the one staying static, not improving for the last 3-4 days, would probably, I'll think of continuing.
Right. So I am just putting the question straight away. What about your cannula planning? How long you want to keep your cannula for a single patient? The patient who is on ECMO on day 10, on day 20, and even on the patient on day 30. So how you plan? Do you plan for changing the cannula if the patient is on ECMO for long? Or any protocols that you follow?
No, we haven't. We haven't changed cannulas yet, but we have changed oxygenator a couple of times. But cannulas we haven't changed yet.
So, initially there was a Chinese study which had mentioned almost every 8 to 9 days they have to change their oxygenators. So our experience is not the same. We do change our oxygenator because we measure the delta pressure, the oxygenator pressure regularly, and if it is slowly going up, there is an absolute value. If it is slowly going up and your post-oxygenator ABG showing the PO to FiO2 ratio is less than 1.5 and your CO2 is building up, so you need to change the oxygenator. If the time frame is between 14 to 21 days, but for longer ECMOs, the patient who stayed for 66 days in our unit or 48 days in our unit, average 3 changes has happened, and all the first ECMO oxygenator has been changed over a period of maybe for 21 days, but second and third oxygenator has been changed with every 14 days. Because
I'm telling you, whenever you are checking the delta P, so are you looking for the lung and the ventilator as well?
Yes, that has to be kept in very much mind, because these patients are very much oxygen dependent, your ECMO dependent.
Right.
So in the futile ARDS situation, the oxygenator change can kill your patient. So you have to be very much tactful in changing your oxygenator. All the experienced people should be there, and you should feel.
Yes, Asif, we will take another 10 minutes max.
We have to conclude the session. Next.
Yeah, thank you. Yeah.
So you have to, the oxygenator change has to be very with the experienced people.
Right. So I am going straight away to the straight away in a scenario where the patient has improved, and what are the criteria that we look for that for the ECMO in. Any particular criteria that you follow in your practice, or you have developed some new criteria for the COVID pneumonia patients, where you are actually trying to put the patient off ECMO, and you just take the same question along with what would be your ventilator strategy at the point where you are winning the ECMO.
Amitabh, we have to conclude the session.
Yeah. So should we stop here?
Yes.
Okay. So okay. So thank you very much. Basically, for the time constant, there are a few more questions and the discussions points are there. But okay, thank you, Asif, for giving us a chance to discuss on your platform for these ECMO scenarios, and which is now a point of discussions everywhere. And we need to improve this support, ECMO support across the cities and the India as well. So thank you very much, and thank you all my panelists. And we hope that we will have able to do more sessions on this in future.
Thank you, sir. Thank you.
Thank
Dr. Ornalok, you are in online now?
Yeah, I'm online.
Sir, we have a next session is Dr. Ornalok Chakraborty, that is COVID-associated pulmonary aspergillus, and after that there is another session that is role of artificial intelligence in ICU. So, sir, Dr. Ornalok, sir, please conclude your session with time, because we are running late already.
Okay, before straight away coming to this issue of current approach to COVID-associated pulmonary aspergillosis, where from this concept came. this concept came from this influenza-associated pulmonary aspergillosis, because last couple of years, what we have seen in multiple countries, that in patients who are admitted in ICU, especially with severe influenza, they have got quite high number of cases of invasive aspergillosis or pulmonary aspergillosis. So what people have started looking at, that all the viral disease, especially in case of the respiratory epithelium, when it is affected, is causing damage to this epithelial cell. And in case of COVID, especially, what we have seen, some patients develop immune suppression, and of course there is decrease in T cells and defective function. And in case of management, when we are going with the corticosteroid or anti-IL-6 antibody, that is also helping in case of fungal invasion. So if you look into this COVID patients, around 5% patients are treated in ICU. And what it had been shown that the kappa incidence varies from 3 to 33%. Especially first the China, they have published, they have not clarified whether it was invasive aspergillosis or not, but it was around 3% which were then. Then from Europe and even from Pakistan, there was a small study which had shown in case of ICU that this is the kappa patient having, in case of this ICU of the those who are treated in the ICU, so around 30%. So you can see from 19% to 33%. Then from UK and Italy also this similar picture had come out, and they have shown that the mortality in this kappa patient is much higher than compared to others. But friends, it's not the invasive aspergillosis only. This is one interesting study which I have seen in case of the Brazil, that had come out that even chronic pulmonary aspergillosis, especially after COVID in the cavity, that had developed. And this is being autopsy proven also. You see, this is one aspect of it. Another aspect which we had seen in case of influenza-associated pulmonary aspergillosis, that there are cases of tracheobronchitis. So even in kappa patient in Belgium, this report had come out of 34 patients, there are 3 patients who have got this similar presentation. But this particular study, which is just being put into online, this had compared the COVID, influenza, and pneumococcal pneumonia. What it had been found that the in case of the COVID, the number of patients who is developing this infection, that is little less than the influenza which has been there. And we generally have this infection at least later part of the period. So let's come to the diagnosis, which Dr. Subhashish was mentioning, that it's a big problem. Yes, it's a problem. Any pulmonary aspergillosis is a problem for diagnosis because of non-specific symptoms and signs. Especially in non-immunosuppressed patients, we don't see imaging shadow, which really can help. And collection of the sample, of course, is difficult. But we generally put in immunosuppressed patients the URTC MSG criteria, which cannot be validated till now in case of ICU patient. But what had happened in case of invasive aspergillosis, that when people used to do bronchoscopy, people used to do the BL sample, the galactomannan, that used to help even lung biopsy. But both are contraindicated in COVID-19 patient because it's a really chance of spreading the infection. So what we can do? Can the imaging help? I'm showing you, can you say which is of COVID only and which is of COVID with an invasive aspergillosis? Friends, it's really very difficult because focal nodule with ground glass opacity can be seen in both situations. So this is one case which is confirmed aspergillosis, another without fungal infection. So generally what we suggest is that if there is multiple pulmonary nodule, if there is lung cavitation, investigate for invasive pulmonary aspergillosis, especially if the patient is having refractory fever, or if there is new fever, or there is worsening of the respiratory status, hemoptysis, pleural rub, or chest pain which is being developed. You can see this is one case. Again, the image, especially the chest X-ray, is really very difficult to say, but this is again in autopsy very clearly shown in the lung that there is presence of invasive aspergillosis. So this is the panel or people from the 2 organizations. One is European Confederation of Medical Mycology, and from our international society, we all discuss together virtually because we cannot have the meeting online, meeting physically. So online we have this discussion and we came out with this suggestion in case of defining and management. So these are the usual microbiology sample which we generally do. Lung biopsy is very difficult here. BL sample also very difficult. So we have proposed a new process, that is the non-bronchoscopic lavage. Those who are respiratory physicians, they know, or even anesthetists know very clearly what it is. It is basically two cannula, one goes through another, and they really injects the fluid and other cannula from which it has been extracted. But it is not very clear. You are not seeing where it is reaching. So that may be sometimes non-specific. Tracheal aspirate sputum, the problem is in case of the standardization is not still validated. I will come to the serum problem also. So non-culture based diagnosis, of course, galactomannan and lateral flow assay, which are important. RT-PCR, some of the centers in India are doing for case of aspergillus, but it needs more standardization. Beta-D-glucan, which we use for candida and pneumocystis, can also be used in case of aspergillus. So in case of lung biopsy, that is the best if we can prove, but that is risky. So in case of, so also the bronchoscopy with BL sample. Here, of course, it is useful, but use restricted because of the risk of transmission. But here you can do either the galactomannan or the new technique, that is the lateral flow assay. Non-bronchoscopy lavage, which I am saying that this is the process which we have recommended. I will come to the recommendation. And in case of tracheal aspirate, already I said that it is very easy to obtain, but it cannot be validated, may represent only colonization. Serum, there is the problem in case of galactomannan in serum because in immunocompetent patient, when there is no neutropenia is there, neutrophil takes away the galactomannan, that's a problem. But as Dr. Todi and many of the people have said that you are getting a lot of serum positivity with galactomannan, where I generally feel that it should be really a good laboratory because this galactomannan and beta-D-glucan, both tests are very sensitive tests and difficult until unless being standardized. So what we have suggested is that this is in case of tracheobronchial phlegm. In case of this, of course, proven is very clear in histopathology if it is shown, whereas in case of the probable group, if there is this clinical feature of tracheobronchial ulceration, if you cannot see, at least there is a chance of it, plaque or this presence is there, and if there is the serum galactomannan is showing more than 0.5, or this is the lateral flow assay which is being positive. And if you have done the BL galactomannan, then we say cutoff should be at least 1. That should be there to qualify for probable. And if it is a pulmonary form, again, for probable group, of course, histopathology should be there. But in case of probable group, what we have thought about, first clinical features should be refractory fever, pleural rub, chest pain, or hemoptysis. And imagine there is pulmonary infiltrate or cavitating infiltrate. And here we have put a lot of those different options. One is that, as earlier, if the serum galactomannan is 0.5, more than that, if there is lateral flow assay becomes positive. In case of BL galactomannan, if it is more than 1, and if it is not possible, at least the aspergillus is being present in case of the culture, then you can think about it. Whereas in case of possible group, what we have put, that is the non-bronchoscopic lavage. If there is only one non-bronchoscopic lavage, we have looked into that if it is more than 4.5, because these are the studies which have been conducted and that had evaluated and tried to pinpoint it. And if there is at least 2 positivity more than 1, that can also be considered. And in case of therapy, what we suggested is that if the aspergillus is azole sensitive, mainly in our country, we don't have the European situation where azole resistance is quite high. Rather, we have got azole sensitivity much higher. Here you can either go for voriconazole or go for the newer drug isavuconazole. But voriconazole, if you go, you have to do the therapeutic drug monitoring. And if there is any alternative, you have to think then liposomal amphotericin B. If it is azole resistant, which is not so much in our case, then you have to possibly add echinocandin along with it or go for liposomal amphotericin B. That is our suggestion. So approach in case of diagnosis and management, summary wise, what we tried to say, consider the diagnosis in COVID patients, those who are in ICU, obtain imaging, typical or atypical sign, multiple pulmonary nodule, lung cavitation, think of kappa, tests like galactomannan, beta-glucan, lateral flow, and PCR you can do. In case of the PCR, especially needs standardization. Consider BL if possible. I'm not saying that you just venture for the diagnosis. For any reason, suppose BL sample is being collected or bronchoscopy is being done, you try to collect the BL sample. That would be very useful. Consider tissue diagnosis if possible. Otherwise, you go for empiric therapy. Voriconazole or isavuconazole is the first line therapy. Liposomal amphotericin B is alternative. Echinocandin can be given in combination in salvage situation. But consider the possibility of azole-resistant isolate. But still some of the unanswered question. Is kappa an independent risk factor for ICU mortality? Still we are not very clear. Is the corticosteroid and IL-16 inhibitor or anti-IL-6 drugs are a risk for kappa? That need to be evaluated. Now the question also a lot of people asked us whether we should go for antifungal prophylaxis, because I have told yesterday that in case of the bacteria, though we have got around 7 to 10% infection, but mostly all patients are on antibacterial therapy. I don't encourage similarly go for antifungal prophylaxis. Rather, you think about whether it can be a kappa case or not. What would be the best way of diagnostic algorithm of kappa? We have proposed this. This has been evaluated worldwide in different centers. Hopefully, we can improve that definition which you have proposed in case of kappa. At the end, I like to invite both of this conference. One is the MycoCon. Initially, we used to thought of making it physical, but now it would decided that we'll make it virtual, 26 to 28 March. Of course, next year we are having the World Congress in case of the in India. That would be in Delhi from 8 to 12 March. Thank you for your kind attention. Hope
Thank you.
I maintained in time.
Very much, sir. And I have just two questions, Dr. Chakraborty. One is, given this current scenario where we have to depend more on non-bronchoscopic sampling, shall we take the cutoff of 4.5 galactomannan for non-bronchoscopic sampling?
In case of this single sample, we suggested that 4.5. If there is at least consecutive 2 samples you could collect, then we have suggested more than 1. That is.
And one last question before this is, we know, as you mentioned, in non-neutropenic patients, the galactomannan is not that good. But here in COVID, the galactomannan, in our experience, is extremely low, 20% sensitivity or less than that. Any reason why in COVID it is lesser than in non-neutropenic patients, the positivity?
Positivity is low. I heard yesterday that every patient is coming galactomannan positive.
I don't know, because in our experience and the literature also says it's much less than non-neutropenic.
But I am saying that the opposite version from Calcutta people yesterday, that galactomannan mostly that coming positive. So see, the thing is that if it is non-neutropenic, there is neutrophil is there. Neutrophil takes away the galactomannan. It eats galactomannan. That's the reason in non-neutropenic patient will chance of having galactomannan low. That's why we have the cutoff at 0.5. Whereas in case of BL, we have put the cutoff at 1 because generally it is low. But you know that the problem in case of doing the galactomannan, and until unless you take from pre-analytical to the analytical, every step had to be very clearly monitored. It's not like that you have got the kit and do the test. That is a big problem. Yesterday I gave the example, one of the beta-glucan, one of the center of BIP in case of Haryana, I said that it came as a 600. Dr. Dhruv is here. Dr. Dhruv had called me, can you do the test? We did the test, it is less than 7. So I am saying you that this particular testing is very important. in case of this.
Thank you, sir.
Sir, very well said, Dr. Arunalika sir. Good afternoon. And it was alarming actually. And I said, now let me call him and save us. And thank you so much. I think there was suddenly a flourishing of more than 600. So means I know we are using a lot of ceftriaxone, sulbactam, or even your beta-lactams. But the way they are using, I think that probably is creating a lot of false positivity. And if it is not fitting, as sir has said it, as a clinician, I will go for a pair of tests and see whether the trend is the way it is. I hope sir will agree with that.
Just I would say that in case of the collection of the sample, each step is important. Collection of the sample, you should take as much antiseptic or spirit in your cotton as possible. Don't rub that area. Even a single fiber of cotton will give you a false positive in beta-glucan. Then when you collect the sample, it should be only in vacuum container. It should not be otherwise transferring the serum. And another important point, while collecting the blood, please don't use gloves. Wash your hand as much as possible. Clean your hand with spirit. But if you have your gloves, there is a chance of getting contaminated the blood with this latex, and that would give false positive. So all these parameters are important while collecting sample. And second thing, of course, the test had to be done in an absolutely separate laboratory. You cannot do any other test in that laboratory. That's the very important point. Biosafety hood is dedicated for beta-glucan for one of the biosafety hood, another biosafety hood dedicated for galactomannan in our center. That's the way we try to standardize the whole process.
Thank you, sir. Thank you.
Thank you. Thank you very much.
To next session. Our next session is role of artificial intelligence in ICU, because in COVID era we have seen lot of virtual and artificial things, and the eminent speaker is our beloved sir. Sir is a senior professor in PGI Rotok, Department of Pulmonology and Critical Care, and sir also the ISCCM president. And the chairperson of this session is Dr. Suresh Ramasubram. Suresh sir is a director of critical care in Apollo Gleneagles Hospital. Sir, please start the session.
Thank you. Thank you so much, Asif. And thank you, Apollo Group, for giving me a chance. And good to see Suresh also along with it. Suresh, thank you so much for being participating in it. I hope you can see my slides now.
Yes, sir.
Yes. Now, when this topic came, artificial intelligence in intensive care unit, in fact, in our university, we have been debating, and I have been telling my vice chancellor that we need to have now School of Virtual Medicine, and also need to have a center where we need to start looking at artificial intelligence in medicine in general. And if you really ask me today, and this is becoming a more and more things which we have to see it in the setting of intensive care units. In next 10-15 minutes, I shall be talking and giving an overview, because it's easy to talk about artificial intelligence or discuss about it. But when you start reading about it, looking at it, then you realize how insufficient our knowledge is. When you see today, we need to differentiate what is a human intelligence and what is an artificial intelligence. When you look at it, we tend to define in terms of IQ, etc. And what is most important, it is to think abstractly, need to use reason to solve problems, make plans, and comprehend complex ideas and learn from experience. That's what human intelligence is about. And when you learn from the experience, that is an experiential learning which you have it. And here you will start looking in terms of what you call as a native intelligence, and that's a part and parcel which comes with an experience. However, we have a relatively limited capacity of memory, and sometimes we cannot see in multidimensional things. Whereas an artificial intelligence is basically extrapolation of remembrance. In terms of it, if you really ask me, it's a science of making machines to do things that would require intelligence if it's done by man. What does we mean? It means they need to be able to solve the problems, can give you planned answers, and comprehend the complex ideas. And when we are talking, it's the computational advances which have been making it possible. And it can tell us, helping in designing a disease. And during this period, large number of people have been getting into the use of artificial intelligence or the algorithms which are there. And it is actually a combination of computational models taking us towards the AI. And one of the more important things, which is the basis of this, is called as a Moore's law. And what we are finding is it started somewhere, Moore's gave it in late 50s, and it has been proven test of the time. If you see the analytical engines, which started somewhere, which calculated per second per 1000, if you see, we have got a quantum leap today, and computing has increased more than 10 to the power of 18. And that has made us the supercomputers which have come up, which is helping us going and making these algorithms, these programs, and this is how the artificial intelligence started coming into picture. Now, the question which is being labeled, it is the machine learning. Now, when you talk in terms of machine learning, it's a subset of an artificial intelligence in which you see that the machines learn or extract knowledge from the available data. That's what I'm saying. It's a combination. This is what you train, you program the machine to extract from the data science. Therefore, when you start looking at from the artificial intelligence, you have a machine learning. And in this machine learning, it can be a supervised machine learning or it can be a unsupervised learning. When you see a supervised learning, the primary objective is that we develop an algorithm which is capable of predicting a unique output when provided with a specific input. That means this is classical if you see it in certain ventilators. When we are using a person, when we put it as an ARDS or whether we put it COPD or a head injury, what you find is the intelligent mode or the smart care in another group of ventilators. So when you're given a data inside with the ETCO2 and SPO2, along with it, it starts looking at it. It tends to modify and modulate in auto mode the ventilators, the way you can override it by going to manual. But this is a classical example. And from there also now the algorithms have come up where you can actually go and cause a weaning. So whereas the unsupervised, you don't give any obstructions onto the algorithm and on how to process the data, but from where they take it up. And the classical example of unsupervised, the clustering, which we are doing anomaly detection or dimensionality reduction. That's how we define it. But it is this clustering which is giving us a phenotype of sepsis, which is giving us a phenotype of various illnesses. So you know it, what you are dealing with. And if Dr. Anulake is there, this is how we have started looking at asthma and which we have been discussing a lot in pulmonology. Whereas when you start to supervise, you have a different regression models which have been there. I will not go into the details of it because still I'm trying to understand the complexity of it. But what is most important is that once you put a data there and you give a feedback to it, it keeps on those algorithms associated. Even your non-invasive ventilation, the way it is being delivering the breaths in this, this is also a simple practical example of deep machine of the machine learning or artificial intelligence. So supervised learning, if you really look at it, is this the primarily objective here is to learn the mapping between input data and data. That is what you have given an input. The output is coming and it matches whether it is meeting which is on another. And this is what you look at it. You can have it up, the trained predictive models, and then you can use that model. So there will be two phases on it. In one, you will create it, and second, you will validate it. And practically, we are using it today for mortality prediction. You can also use it today for prediction of sepsis or deterioration. This is one example of sepsis, which was published in intensive care medicine. You can also use it to classify arrhythmias, where sometimes you may have a difficulty whether you're dealing with an atrial fibrillation or you're dealing with the PSVT, with the emergency, or with the VT. And sometimes you may have so the pattern identifications from there, along with other mathematical modeling, you can do that. And obviously, it also is helping us in deciding in the policy and the planning, because if I am discharging a patient, what is the probability of these patients coming up? Because that's as important in an issue, which was far more highlighted in the earlier phase of COVID also. Whereas when you talk in terms of unsupervised learning, here it is you have a data structure, and from you trying to look at it, which data are meeting together. That is why data analytics is becoming a big important issue. If we don't look at these machine learnings, we probably may get drowned in that data of the EMRs which we are collecting today or the data which is coming now. So here you are looking as a model, methodology remains the same. And when you identify that there are certain subgroups are there, from the basis of that you can calculate or you can actually predict phenotypes. And that is the rationale, the basis on which today we are talking about the 4 identifiable phenotypes of sepsis. And also the same has been used in the ARDS. where the reinforcement learning is a little different. You try to learn an optimal strategy in a decision process. You are trying to put different methodologies into it, then you see which is the one which is working going to best. So it can help you in deciding some intervention doing it, whether you can optimize it or not. So when you see it today, this means, let's say we are looking at sepsis. How can we optimize the sepsis resuscitation? Where there is always a pendulum on the one side says you do a low, you do insulin, like the Vanderbilt study where we talked in terms of insulin. You use it to keep sugars levels low and you realize hypoglycemia. They never shown the advantage there. Similarly, there's another group of an example which says you keep it around 160 and all, which is better, which is an optimized way without causing a patient any problem. So that is where these reinforcement learning comes into picture. And when you start looking at the deep learning, then there are three components which are coming up. One, we are talking in terms of artificial intelligence that leads to machine learning, and then we are also having a deep machine learning, and that leads to deep learning. And most important, to begin with, it started with AI, where we started looking at engineering of making intelligent machines and programs. That's what I'm saying, the ventilators, the monitors, and now looking at it, even a hemodynamic monitoring, the data which you see it on a Philips or the Neon Codon, or even you're on a G ventilator on monitors, actually you can predict in these cases what is the cardiac output, etc. So all of these machines which are computer based now, they are using some algorithms, and practically without our realizing it, artificial intelligence is being used in day-to-day management of our patients in intensive care units. Now let's come down to machine learning. And here you do, as I've already talked, ability to learn without being explicitly programmed. You're not programming it too much. But when you do it, and when you start looking the way the neural network works together, where you have an input, you have an output, you have a processing in it, that's what we are gradually getting into the process of deep learning. And now the era which we are seeing today, starting from the AI going to machine learning to the deep learning processes. And deep learning processes far more closer to the way the human bodies think in terms of it. And now they are being trained with these algorithms to actually do the human emotions. So when you do in the machine learning, you have an input, the feature extraction from there, you try to look what you are looking for. Then you try to classify on the pattern of an algorithm which you're learning. Like in my case, it will be, I will see it today, and then you see what is the output. And whereas the deep learning is, we're combining feature extraction and classification in one way. So you do not have to go in the multiple steps. I take out a blood sample, I run around and look at the genomic structure. That, like today people are talking about in a COVID also, that you see the DNA, mitochondrial DNA, you run it out to do a prediction models. So what you are looking today, it is taking us more and more towards precision models or precision medicine. So what you do, you learn it across, like what you are doing with the next generation sequences. You take out the sample, you run it, you come to know whether it is a it is a B, it is a C. This is how we are now looking at we are looking at the data, and we are able to very accurately classify the organisms, or in these cases even the human reactions actually. So that is where the future is moving as far as the clinical medicine is concerned, and it cannot be more appropriate as than dealing in the patients of intensive care unit setting. While we are talking about AI in ICU, so you have a data, you need to analyze, and you have a knowledge. So that is what we are looking at. It's the enormous dynamic data variable responses are coming in patient. We say that this is 30%, 40%. You look at today. If I know this is the genotype which is coming up, I do a bioinformatics, I know I have to give a tocilizumab. Then I realize that we are trying to put a jack in the approach, that you need only 6 milligram dexamethasone. Can we have a phenotypes? If I can do that data, with that data, I probably can understand and actually individualize the treatment and management. And we do not have that when we are doing RCTs. It's a complex environment. No two patients are same. We are trying to put a non-linear model into a linear model. So artificial intelligence can help us customize to an extent where you do not have a strong guidelines, where you do not have a, say, because of the senior variability, as I'm already talking about, telling us which medicine, which drug, what thing we need to look into it, and also does and give us a mortality predictor. So what you are doing is become more accurate predictive models. It helps in a better decision support tools and can lead to greater personalization of care. And when you see it, we are commonly seeing, as I talked about, also sepsis prediction, mechanical ventilation. I gave you an example. And similarly, can also tell us predictive mortality, prognosis, length of stay, and readmission rate. And for that, you can also look and develop AI sensors. Today we are doing a sleep studies. Probably if you are looking at an actigraphy, it can give you an idea what is happening, where it is sometimes could be very difficult for us to find it out. So in short, what I am saying is that by use of applications of artificial intelligence and technology in the intensive care units, probably we can move towards reducing mortality, morbidity, and predicting. And that's the first question patients come and ask, doctor, what is going to happen to my patients? This is one of those critical care medicine. They predicted it, and it was able to an observational study, cohort study, where you try to use the AI sepsis or AI study. It's to predict the sepsis accurately from 4 to 12 hours before clinical recognition. That means it was able to pick up who are the patients likely to go into sepsis or complications of it nearly a day before, half a day before. Similarly, when you start looking at the data which was published from in one of the Indian studies which have done it, and they have shown that a comparison of incidence of development of clinical sepsis and predicted sepsis by the model showed nearly 74 sensitivity and 84% specificity. We need a little more accuracy of the data, but yes, it is helping us out in the confirmed cases of sepsis. Similarly, reducing patient mortality, length of stay, publishing BMJ open again has shown advantage. When I've already talked about AI in mechanical ventilation, it tells you now today we know we can actually go from automated ventilation to automated weaning. And that's the mode of which we are seeing IntelliVent or smart cares. This again, you can detect patient ventilatory asynchrony. It can tell you whether you're giving adequate amount of ventilation or not. How many of us are actually going and looking at the trends? So, but if AI is being used in this, it immediately tells you what is the percentage of AI. If it is more than 10%, then you need to look at it. And whether the trigger, whether the asynchrony, what is the type of asynchrony? Is it a reverse triggering? Is it a double trigger which is happening? Or ineffective breath? Everything you can come up, and even it can help us in identifying dynamic hyperinflation. It also can predict ICU admissions, predictive tools. You look at area under curve in the study which was published in 2019 is up to 0.9, which is which is pretty impressive. And using to predict prolonged mechanical ventilation and tracheostomy placement. Forget about the neurological cases. Other cases like in COPD and ARDS, how many time it is going to do? Again, you will see it's not bad. It's 0.8 to area under curve. And when I look at a Tobin index, which again has an area under curve is not more than 0.8. Similarly, reinforced learning approaches, same thing you are looking at time and again, similar accuracies it is looking at it. So we are optimizing the outcomes with it. It can also give us a predictive mortality. Apache was the first score along with SEPS and all. So gradually it is becoming part of it, and look at it. Practically, when you look at it, AI that was trained on physician notes with severity scores, it had area under curve of 0.8, 0.9%, and 94%, 0.6 to predict mortality rates in surgical intensive care unit. So probably it gives you an accuracy in looking at it, tells you where you channelize your resources as a policy and a planner. Similarly, it can also help you doing it. This was in a cardiac ICU, and again, when you looked at it, the Gaussian processes model, we found it was quite helpful in these cases. So readmission prediction is important. If you go to NHS, your grants actually come up how if you are getting too many admissions in emergency, especially because of readmission, you won't get, you will have a grant cut. Same we are going to see sooner or later in this country as well. And it outperformed most of the models. And what we are realizing is if we can pick up which are going to have a readmission, we can actually put our emphasis in home models or maybe delegate admissions. And this is again the sensors you need. What you need? You need activity pain level monitors, you need accelerometers, you need actigraphy, you need video monitoring system, which will look into your visions. So what you are looking at the AI sensors for it. They will look at it, the physiological signals, EHR and questionnaires. When you look and you put these sensors, it will have a vision, wearable sensors, light sensors, it will pick up. And you look at the face recognition, face AU detection, facial expression recognition. And when you combine together, probably you will have noise level light, whether it is associated with it or not. And then you will be able to make what is the level of sleep, what are the pain levels, thresholds, everything you will come to know. And that can tell you the outcomes of your interventions which you're trying to do. And similarly, people have been able to find out that in terms of cognition abnormalities and delirium, it can really pick it up beautifully. And this was again published in 2019. We're more sensitive to light, but not to noise. So looking at that, you can tell us which patient is having delirium and which is not. Similarly, it can help you in bed sores also. Cardiologists have already talked about arrhythmia, and this is the model predictions which are there. But again, technology creates its own issues. When you start looking at the large databases dealing with the issues of interoperability and incomplete, spurious, and artifactual data can create a problem. So you're getting into a ocean. You need to pick up the right data. The noise has to be taken away. If you can take that away, you pick up the right noises, right signals, then probably it is effective. Otherwise, it can have a problem. It needs a trust and buy-in by all stakeholders, and you need to have to train people in artificial intelligence and machine learning. Legal ethical issues are important. So blame in case of inappropriate interventions can be difficult. So ethical challenges as end-of-life care decisions, can we make it up on the basis because it needs to be there? Similarly, model transparencies are important, and AI models are trained on data which will not include relevant social factors. How will you take in account such as ethnicity, socioeconomic status? Already we are seeing a lot of that strife in it, whether to do it or not. I think these are the challenges which society has to take, and that is there what we need to see. So conclude, my dear friends, awareness, multitasking, flexibility, and combination are the human capabilities, which still no AI can predict or achieve. It's not only IQ you need EQ, you need SQ. From where it will come, I think that is very important. Touch still continues to be, from me as a clinician, a very important component part of dealing with my patients. It cannot substitute for, as I said, with the patient-physician relationship. Again, healthcare cannot be automatized. You need to have a human angle. An AI-driven decision support system will be embedded in the healthcare. That is all right. It should not be the master, but it should be the slave. And you use your parameters, human emotions, human intelligence, along with it, you combine together. Yes, it is important for us to look at it to improve decrease the error rate, improve the patient safety, and along with it, helping me in decision making to do that. Thank you very much.
I think Dhruv, fantastic job. Sorry, I joined a little late so because of the technical problem inside the hospital. We have, I think, the group also of Apollo with our Rajesh Chawla, me, Ramakrishnan, and Dr. Sujoy who heads our AI. We've just sent a publication on the AI analytics to BMJ Global. Let's see how that works. But I think this is the way it is, and a lot of institutions are investing a lot of money, and you're very, very well put that this is the way to. Any questions from the audience or anything else that anybody else, Dr. Sarkar or Dr. Sushil Agarwal, any comments? Ajayda, any comments?
You see, the problem which I am, Suresh, facing is that in the private sector, people are realizing they're investing in your technology. The challenges are coming in the public sector. Because you are going a step ahead and you are trying to see to it how you can improve your outcomes, as I said it. And secondly, it is equally important is how can you reduce the readmission rates, if you really look at it. Because these two things are something extremely important to gain trust and faith. And same thing we are finding it up. And I think data analytics is becoming an important, and the universities have to take a lead. Unfortunately, the health universities in our country, and I'm sorry to say, being part of it, have been still feel that they're running the institutions, the hospital running. I think that should be left to the administrators. And as a planner, if I'm working in an institution, I think we need to come up on the various aspects. And I think this is where the technology is meeting with the human interface. So we need to look at it, develop it, and move ahead. And looking at our own challenges, own problems, and how to analyze data, I think still is if you really ask me in North, what we say is Farsi to me. And I think we need to work it out. And in intensive care, if you, Suresh, remember last year, we had the gentleman who came from Manchester who talked about the data science. I think this is where we are moving, and that is the basis of actually AI and deep learning and machine learning.
Absolutely. Ajayda.
Yeah, I think he's right, but what I feel that this is some kind of highlighters, or they are giving us some important informations, but it's up to you to decide whether you will take all these data or informations into confidence, and then you have to judge according to your experience and knowledge, and that is more important. But obviously in our busy day we might miss many things. So that's why it's very important in your unit to find out what exactly it is there and what is the thing I'm missing during my ward round or during my daily activities. So it's a definitely it will guide us in what he has mentioned, that to reduce the incidence of more drawbacks and more incidents of more shortcomings in our management. So but obviously it's more important patient physician's relationship and giving time to your patient and look at it. Clinical medicine I don't think can be replaced by this artificial intelligence. Do you think so, Dr. Chaudhary?
Dr. Ajeda, good afternoon.
Good afternoon.
And if you see the number 2 and number 3 points of conclusion, AI cannot substitute for the patient physician relationship. EQ, SQ, we have to read your human emotions and can react. This is where people are trying to go a step ahead. What happens 20 years ago, we don't know. As of today, people are coming with the robots or other things which can actually act like human beings. Emotions, that's what different. And secondly, if you will see it, I've written, it will remain in the co-pilot seat. It cannot be a pilot. It can help us in improving our workflows, as you have rightly said, and more rationality into our practice. I think it will help us in practicing more evidence-based, because still now in ICUs, 30% is only evidence-based. I hope you will agree with me. Rest we go by taking a client later on trying to find out what the evidence is. That is why we are seeing that there is a huge variability and difference of opinion that creates doubts in the mind of the people leaking out to. So I think that will work at that level. But if I am an ICU guy or a clinician guy, I would like to know that anybody comes, I took out a sample, now my computer runs the bioinformatics. That is where the bioinformatics becoming important. They say, okay, this is XYZ, now this is where the drug profiling you can do. And that is not going to be a theoretical thing. Another 10 years you will see being practiced so as to have it. So in principle, do I agree that it cannot match your social skills or emotional skills or emotional quotients? But yes, it can't. But this is the way forward. We need to be sensitized and we need to look at it that way. It cannot. Technology can't be a monster to dominate you.
We have to move next session.
Thank you so much.
Thank you to all participants. Sir, our next session is immunomodulation therapy. That is immunomodulation therapy in sepsis, and the speaker is myself, and the chairperson is Dr. Pantar Chakraborty. Is a oncologist, hemato-oncologist in Fortis Hospital, Kolkata. Is a senior professor. So I will start.
I think Asif, you can start.
Yes, sir. Yes, sir.
Yeah, you can present. Yeah.
Is my slide is
yeah, it's visible. It's visible and you're audible. Yeah.
Yes. Sir. So immunomodulation therapy management in sepsis is a this is not a new concept. It is an old concept, but because we know the definition of the sepsis is complex and life-threatening syndrome include dysregulation of host response. Why immunomodulation is important? It is the reason is the definition. The reason is the evidence. The evidence showing that all patients with a infection or inflammation or any insult, they going to the multi-organ dysfunction syndrome or in a septic shock, depending upon the individual host response towards the infection. So cytokine storm in history, the term used in the cytokine release syndrome initially in 1991, and then 1993 there is a graft versus host disease. Farrell et al. Published the paper, and he used the cytotoxin storm word. And due to the COVID, there is a good effect and bad effect. And we have learned a lot of thing about the cytotoxin storm and why this is happening and how to prevent it. And lot of trial going on to prevent cytotoxin storm. And if you seen the history that cytotoxin, there is a lot of cytotoxin that including the interleukin 1, 6, 10, TNF alpha, they are the more culprit. If and it has been well published that is there any dysregulation of the cytotoxin. If there is a immunosuppression, it causes the late death due to opportunistic infection, or if it is a hyperactive, then it is a early death by organ failure. And the main culprit are already mentioned, that interleukin 1 beta 6 and interleukin 17 is like that 17 cytotoxin identified, and they have a great role in sepsis and septic shock. This paper published in India 2019 in Indian Critical Care Journal, Kumar et al., has showing that interleukin 10 is a very good marker for a patient who are in a sepsis. They are going, it is a prognostic marker. If persistent elevated interleukin 10 and the ratio of interleukin 10 and TNF alpha, if it is high, then this patient definitely going to death or fatal outcome. So how cytotoxin signaling in sepsis? When bacteria or virus coming to the system, they trigger the T helper cell and TLR, which activate the GTPase and substance 1 RAS system, and they produce the massive cytokines. And there is also genetic morphology in sepsis. That's why is person to person varies the response of infection, and there are variability in the gene encoding endogenous material that constitute the pathway of the inflammation, and polymorphism of TNF alpha, TNF beta, interleukin 6, and they causing the bad outcome in sepsis. Therefore, the immunomodulation therapies theory come to in a picture. There are two types of immunomodulation. One is suppression and one is immunostimulation. There are multiple agents available for immunomodulation, starting from the cancer treatment to the rheumatic arthritis or any chronic disease. But we will restrict our lecture to immunomodulation therapy in sepsis. And why immunomodulation therapy in sepsis is important, because we know that treatment of sepsis generally supportive nature, giving administrative of intravenous fluid, vasoactive substance, oxygen, antibiotics, and doing a culture, everything is all supportive, but there is no definitive on the pathogenesis and the process or how body react with the infection. So ideal characteristic of immunomodulator, it should be cheap, inexpensive. It is compatible with other drug, active through oral route, and you can use it as adjuvant along with the vaccine. Most of the cancerogenic immunomodulation therapy, they are is very compatible with the drugs, and it should not be very toxic, antigenic, pyrogenic, or any long-term side effect. So in sepsis, there is a multiple immunomodulation already in the market. Immunoglobulin, one of them, immunoglobulin we use for autoimmune diseases, and also in small vessel vasculitis in ICU. But immunoglobulin, there is a 7S IVIG or intact IgG or 5S IVIG or FAB IgG fragment and IgG increase the serum opsonic activity. And how you modulate the immunity, it reduce the production of the pro-inflammatory mediator and increase production of the anti-inflammatory mediator and neutralize the cytokine using anti-cytokine antibody. But there are multiple trials going on, already published, but no one has showing the much mortality benefit for IVIG in sepsis. Then another thing is cytokine inhibitor, because cytokine is the main factor to produce the organ damage or which is septic shock. Therefore, cytokine inhibitor has come in a picture, and there are multiple cytokine inhibitor available in the market. But it has been shown in the sepsis, there is a two drugs is very helpful. One is that is neutralizing the anti-TNF antibodies afilimumab, and it reduces the 28 days mortality when the IL-6 level is little higher. And another thing, we have used a lot of monoclonal antibody to reduce the cytotoxin storm in tocilizumab, though result is debatable. And tocilizumab is anti-interleukin 6 receptor inhibitor, and it is reduces the pro-inflammatory cytokine, and it also involved in the physiological process. This is the structure of tocilizumab humanized monoclonal antibody. Why interleukin 6 is important in the sepsis pathway? If we saw the role of interleukin 6 is activate the T cell, and it help to maturation of the megakaryocyte. Along with it, increase the thrombocytosis, autoantibody, and it increases the hyper gamma globulinemia, and also it increases the osteoclast activation and bone reabsorption and acute phase response, and it reduces the CYP 450 activities. Therefore, tocilizumab come in a picture in cytokine inhibitor. And there are multiple side effects, among them severe stomach pain, constipation, blood, stool, vomiting, and also it reduces the immunity. So there is an increased chances of secondary infection. Another well established drug, that is corticosteroid. We often use corticosteroid. Corticosteroid, it's bind with the corticosteroid receptor, and they produce the corticosteroid receptor complex. This complex binds pro-inflammatory transcription factor, and it produces the pro-inflammatory cytokines. First time in 2008, Merrick et al. Has published a paper that role of corticosteroid in a severe sepsis or septic shock. They saw the corticosteroid level is insufficient during the severe sepsis or septic shock, and therefore the vasoactive drug is very inactive or resistant. So they have published known as Merrick protocol for septic shock, the steroid with thiamines and all. And currently, in COVID, we saw the recovery trial, low dose steroid has reduces the cytotoxin storm, and those patients having oxygen requirement is there. They have a good benefit with steroid, and we also saw it reduces the lung fibrosis. Then coming to another immunomodulation is immunothrombosis, because we also show that sepsis associated coagulopathy, that is DIC, it is very common in severe sepsis septic patient, and there is a multiple to reduce the coagulopathy or to remodeling of the thrombosis and prevent the thrombosis coagulation cascade. There's a multiple like activated protein C and activated sepsis on coagulopathy, and only there is a it's a restriction of uses right now. And antithrombin 3 is same. It has not produced a very promising report. And newly come the Microbacterium W. It is also known as Microbacterium indicus perini. It is a saprophytic non-pathogenic stain in Microbacterium. It is an immunomodulator and known to contain multiple antigen. Its work multiple level bring the balance in this regulated immunity. It has been first used in during COVID, and there are quite publication on this that it reduces the mortality, it improves the SOFA score, it improves the ventilator days, and it is known as a potent TLR2 agonist and poly-TLR antagonist, and also MAPK modulator, and ultimately it reduces the cytokine suppression, and it reduces the pro-inflammatory cytokine in the system. And there is a study that randomized double-blind comparative control prospective study, and showing primary goal is 28-day all-cause mortality in a sepsis, and secondary outcome is SOFA score improvement, ventilator-free days, ICU and hospital of stay, and improvement of the safety and tolerability. And it has been shown that it reduces the mortality in quite significant in severe sepsis or septic patient, and also it reduces the SOFA score for a patient who got this injection at the time of initial phase of sepsis, when patient entering in the septic shock. Initially, it was dose like that, percutaneous dose 0.3 ml or in 3 consecutive day. But now the DCCI has approved the IV uses because it produces the scar in the injection site. So my conclusion on this topic is sepsis is a multifactorial and complex condition, and the main role play ultimately is not the infection, it is the cytokine which produces all the lung damage or the membrane damage, organ membrane damage and organ failure. So we this is the area where we can think about. We need more and more research on that to prevent the death in a sepsis and septic shock. Thank you.
Thank you, Dr. Asif, for that review. I think we are already running short of time.
Yes.
COVID has taught us a lot of things, and I think this is the first time that steroids, age-old steroids again have shown that they can actually improve survival. So obviously, the Th1, Th2 response, and when there's a frustrated immune response, which happens in sepsis, this can lead to more problems. But I think if there are any questions, maybe one or two, you can ask Dr. Asif.
Can I just ask one question regarding this Microbacterium W? I understand that this was given subcutaneous, and in sepsis they have shown mortality benefit. How could? Because this is something which takes long time to work. Because if you give something subcutaneous, at least 2 weeks you need to have the immunity to develop. And sepsis, we all know, first 3 to 7 days everything happens. So it's so obviously it's not going to affect your mortality. You can have some changes in morbidity. So that is my question.
Sir, actually, they have given the data, and now they were using this IV, and this is the claiming that it produces it has a lot of antigenic response, and which prevent the cytotoxin storm in sepsis.
It's just like vaccine, isn't it? So you are giving.
Yeah, it's in the short term, Ajayda. What it is trying to do is getting a known enemy so that all the missiles are targeted toward that, so that the missiles do not misfire and destroy the body. So that is what they're trying to do.
How fast that can recognize? That is my question.
Yeah, that is a very good question. And that also the response might be different in India, where, Mycobacterium tuberculosis is endemic, and in other countries where people do not have an exposure. So I think there are a lot of unanswered questions, which in the long term will tell us what actually is happening.
Thank you, sir. We have to move the second next session, and that is when to start and when to stop renal replacement therapy, and this is very debatable question in ICU. All critical care specialists want dialysis, but nephrologists say no. Right now, we are not. The patient is not ready to get the dialysis. So for this session, Dr. Ajay Sarkar, sir is sir will moderate the session, and sir is a senior consultant and clinical director of Peerless Hospital, Department of Pulmonology and Critical Care, along with Dr. Srinivas, Dr. Sandeep Bhattacharya, and Dr. Rahul Pandit with us, and Dr. Chandrasis Chakraborty. Sir, please start the session.
Thank you, Dr. Asif, and good afternoon, everybody. As Dr. Asif has mentioned that in every unit, if you see the patient, at least 1/3 of our patient develops acute renal failure in the form of AKI in different forms, and we all know 5% of them, roughly 5% of our I2 patient needs dialytic support, renal replacement therapy, and the mortality in this group of is quite high. Even with our all modalities of support, we cannot bring down less than 50%. So with this introduction, I think it's a good topic to be discussed time and again, how to improve our mortality. And the topic was set when to start and when to stop. So I'll go for the first question, when to start, to our panelist. I could see Dr. Rahul Pandit, and he'll start the ball rolling with that questions. When should he start RRT in a patient with AKI?
Hi, good afternoon, Professor Sarkar, sir. How are you doing? Thank you very much for having me on this debate. I think there are some, as Dr. Asif introduced, that there are some nephrological indications which are very clear. You have acidosis, you have hyperkalemia, which there is hardly any debate. You would essentially go across and dialyze the patient who is anuric or oliguric along with these things. But there are a lot of ICU indications which I think, unfortunately, with the communication, we are not able to get across to the nephrologist time and again, and that's where the debate happens. You may want it for volume control. You may want it for a patient who has had head injury, where you may want to actually have a better control over the volume. You may want it for sometimes for patients who have, for example, a drug-induced liver injury, where you may want to do high volume renal replacement therapy. And these are the indications where the evidence is not as robust as the renal indications, which we are quite classically aware of. But there is emerging evidence in these. And that's where we need to basically talk to our nephrology colleagues, that ICU indications are a little bit different than our classic indications of dialyzing. So that's one thing. The second thing is, very often I see that there is an attempt to convert a oliguric renal failure into a non-oliguric renal failure by giving them furosemide. And this happens very often in our septic patients, or even in patients who may have some cardiac problem, maybe a shocked patient. And I think this attempt needs to be balanced across, the fact that are we inevitably still going to land up like requiring a renal replacement therapy? And if the answer to that is yes, converting a renal failure or a non-oliguric renal failure to an oliguric to a non-oliguric does not make any difference. In fact, we just delay the whole process and in the event actually cause more harm to the patient than good. I think these are some of the aspects which we need to understand. So there are some classic indications which are non-debatable. Then there are these indications where we do it outside the realms of nephrology, and that I think there should not be any debate because those are ICU clear indications. And then there are these indications where you don't want to delay unnecessarily but want to get on with the job, and that's where we need to basically put our foot down and get the things rolling.
Thank you. Is there any other panelist? I couldn't see any one of them. So where is Sanjeev Bhattacharya and Chandrasis and others?
I think Srinivas is there, sir. I can see
If there is more, then we'll go by two of us. We'll discuss on that.
Srinivas is there, sir. Srinivas is there. I can see him on the panel. His camera is also on.
So the next question, the Rahul has already raised that question that there is no debate about your renal replacement therapy, but there is a debate about early versus late renal replacement therapy, and there are two landmark studies. One is Ellen and one is a KT study, one published in JAMA, one published in NAGM, back to back in the same time, and it's just opposite. If you go by those studies, one is saying that it improves mortality, another it says that it doesn't improve mortality. So I would ask Dr. Sandeep Bhattacharya to explain why there was some difference on those, and what, as a clinician, what should I go for? We should go for early renal replacement therapy. If that be so, then what group of patients should have early? And if not, because there is a in the same AKK trial has mentioned that early has got a lot of complications. So we are aware of that, complications related to dialysis, complications related to lines, complications with infection. So what is your opinion about these two studies? Dr. Sandeep Bhattacharya. Is he around? No. Then Dr. Srinivas, are you ready to give answer these questions?
Yes, sir.
Thank you.
So initially, when we started looking at renal replacement therapy, we all were brought up with the belief that early aggressive renal replacement therapy is the way to go in intensive care, and it saves a lot of lives and it prevents people from getting dependent on dialysis for the rest of their lives. This was the concept in which we have grown up in the last 10 years. But what has happened in the last 5 years or so, that with the early detection of acute kidney injury and the awareness that there could be several nephrotoxic interventions which we do in the ICU, and we started avoiding it, this difference in outcomes seems to have become narrower and narrower and narrower. So if you look at the studies published in the last 5 years, the outcomes of patients who have been subjected to early aggressive RRT is no different from those in whom a wait and watch approach was followed. Now, the reason why this has also happened is probably because these patients were initiated into RRT based on the KDIGO classification, and they were all taken in when the KDIGO stage 3 and above. What happens if you initiate them before the KDIGO 3? Nobody has seen it. And the second point we need to remember is that all these studies which have compared early RRT versus late RRT have compared only the hybrid forms of therapy versus no dialysis, rather than compare CRRT with the standard therapy. So even in the presence of vasopressor requirement, which was quite high in the good number of patients in both the studies which you have quoted, the choice of therapy was a SLED or a PIRRT and not a CRRT in good number of patients. So there is a difference. I mean, there is probably a bias there in that you have actually subjected these patients to a therapy which probably would not have made a difference, and then we came to a conclusion that early RRT is not as efficient or or not as effective as we thought it should be. But it is also true that those patients in whom early RRT is initiated tend to develop infections much more than in whom there is a conservative approach. The third point we need to remember is that the fact that what we believe that if you initiate RRT early, these patients will get off the machine quicker and will stay off the machine for a longer time has been dispelled by both the studies which you have quoted. So I would probably not be over aggressive at this point of time, while I will probably take a middle path and see somebody between Kirigo 2 and 3 rather than wait for somebody to be Kirigo 3 before I initiate a renal replacement.
Thank you, and excellent. So that has explained why the two study, the Ellen study has started all dialysis at stage 2, in stage 2, and Akeki, as you have mentioned, all the studies have taken patients from stage 3 onwards. That may be the reason. So next is Dr. Rao about furosemide, because we do use furosemide in our patient. Let's try if we see the IVC status, volume status, and if we are quite happy that there is a volume optimized, and then we do give furosemide. But there is one term probably being used as furosemide stress test or furosemide challenge test. So do you think instead of giving 10 mg, 20 mg, there should be one sort of definite dose in this group of patients and see whether we can avoid, at least avoid this dialysis or not, or whether that is going to harm this challenge or not. So what do you think, Dr. Rahul? Because I don't see any one of them.
So no, I don't think there is any role for actually giving a very high dose furosemide. If you're talking about a high dose furosemide where we give 2 milligram, 3 milligram per kilogram, say 240 milligrams of furosemide or something. Yes, people have tried, and I may say anything on this podium right now, but if I have a AKI patient, even I am tempted to give 40 to 60 milligrams of furosemide challenge and see what is happening, which sort of comes to around 1 milligram or 0.5 milligram per kilogram. But it is very clear that by converting AKI from a oliguric to a non-oliguric, there has been no mortality benefit which has been shown. That's no question about it. Rather, you fix on to the correction of the main problem, which actually led to the AKI, and perhaps you may get away without dialysis. But concentrating just on AKI to try and produce a urine, which then leads to just production of more acidosis and worsening of your urea and creatinine, actually has not shown to make any benefit as such in the long term of management of that patient.
Yeah, okay, fine. That's a very good answer. Regarding, the indications, we all know that patient is having hyperkalemia or uremic symptoms or volume overload. All these three are acidosis, uncontrolled acidosis. These are the indications for initiating RRT. But amongst these, which one do you think is most important, Dr. Srinivas? Is Dr. Chandrasis around? I couldn't see. And Dr. Sandeep hasn't joined, I think. So I'll go for these questions to Dr. Srinivas.
Yes, so
these 3-4 indications. So which one do you think the most important? Because if I see the pH is 7.25 and others are okay, not volume overload, not I might hang around with the urine output, because we all know that early and delayed there is a big difference, and we tend to, and there are many centers where you don't have the round the clock dialytic facilities and nephrologists are not around. So there should be some point where you need to hit the button at that point of time, because out of these 4 indications, one is very important, and one study has shown that the mortality difference is very significant if you go for early. Which one do you think?
yeah, so if you give me a choice of high potassium and matter acidosis, volume overload, and azotemia as the choices in an intensive care unit with an unstable homeostasis, I would probably pick hyperkalemia first, followed by acidosis next. Having said that, if the patient's volume status, as Rahul mentioned in the first part of his answer, if the patient has a problem either with his oxygenation or with his intracranial pressure or with what we are thinking is a third spacing which is contributing to the overall global interstitial perfusion, then volume also becomes an equally important indication for me. So if you put all the three options in front of me, I would probably choose hyperkalemia first, acidosis next, and volume management second. The only reason why acidosis and hyperkalemia and volume management have come second and third is the fact that there may be an alternative therapy, like giving bicarb till the machine is available, or diuresing till the machine is available. But for hyperkalemia, whatever you do, once it is beyond a particular level in a critically ill patient who's on vasopressors and who's got multiple problems, we may end up with a refractory arrhythmia. That's the only reason why I put potassium first, acidosis next, and volume third.
That's very good. And I think those who are listening this session must remember that potassium level is very, very important, and you can lose your patient just hang around with that high potassium. That's very important. And going to next question is when to stop RRT. So obviously, Dr. Srinivas has already mentioned about that. I'll go to Pandit again, Rahul, because you have started now, you have to stop. So you have started with.
No, sir, I can give a very simplistic answer that when the indication to start has been treated or resolved, you stop the RRT. So that's a very broad answer. But essentially, you don't. So if the answer which you're looking at is that do we wait for the kidneys to open up? Do we wait for the urine to start flowing? Then you stop. No, sometimes you may not want to just relate it with the kidneys again. Again, it depends on what was your reason why you started up. If I have started it for volume overload troubling me with my hypoxia or with my intracranial pressure monitoring, intracranial pressure, I would probably stop the RRT early. If I have done it for some other indication like a liver indication, I would basically correlate it to the liver recovery. But certainly when I am starting it for the classic indications for hyperkalemia or acidosis, I would simultaneously hand in hand treat the cause of hyperkalemia or acidosis as well if I can actually find out. And that's when we would stop the renal replacement therapy. Now, ideally in an ICU setting, most of our patients do have compromised hemodynamics, and the mode of renal replacement therapy usually is something which is much slower than a standard hemodialysis. So either we go for a sled or we go for a continuous renal replacement therapy. In a sled, we can give an extended sled for 8 to 10 hours at times in a patient who does require ongoing dialytic support. And a continuous renal replacement therapy, you just don't bother. You actually continue with the dialysis till the circuit supports you. And then when the acidosis is resolved, hyperkalemia is resolved, hemodynamics have become better, your overall patient has starting to improve, the vasopressors have come down, that's when you can sort of start thinking of giving a break and allowing the patient to have a natural course of recovery. So it's a very difficult question to actually say that at this point I'm going to stop dialysis. It is more of a clinical assessment of a patient in that individual need when the RRT was started. You would take up that decision too.
I agree that there is more clinical judgment, but we all go by a few numbers. When you talk about kidney, Akin, Raffles criteria, there are some criteria about stopping, or you can try. Just in one study, they have shown that if your urine output improves more than 400 ml, then you can stop and see how it goes. So these numbers are sometimes, I don't know, but it works or not. But in one study, they have shown that there is no urine or absolutely anuric or olivine. When the urine output goes more than 400 ml in 24 hours, then one can try and see by stopping. Is that right? Do you think?
So sometimes on RRT, actually patient remains anuric just by the fact that you are actually giving them RRT. And you need to stop to actually allow the patient to produce some urine. So that's another call which you take based on the clinical judgment that does this patient require intermittent renal replacement therapy or not. And then give him a day or two's break. Yes, in general, what you're saying is absolutely right. The guidelines are there that if they produce around 400 ml of urine a day, you generally don't need to actually initiate a renal replacement therapy again. That's, I think, a very reasonable thought.
I think we have how many times I don't know, but regarding you have mentioned about that SLADE, RRT and intermittent dialysis. So just one question to Dr. Srinivas. Do you think that if CRRT is really helpful for our patients, or if you have SLADE and if you go by SLADE in a generous way, you can save many patients? Because CRRT is a costly endeavor, and in my unit I don't have any CRRT, but I've been using SLADE quite frequently. So what do you think about that?
Yeah, I mean, this is what I am saying is entirely my personal opinion and what I have noticed in the last 4 or 5 years, where I thought, as what you are saying, that CRRT probably is not needed in intensive care if you can have a good sled machine and you can monitor what you're doing. Unfortunately, if the patient, if for pure nephrological indications, maybe it doesn't make a difference whether it's a CRRT machine or a sled machine. But in pure intensive care scenarios, like somebody with a hepatic failure, for example, or a traumatic brain injury with rhabdo who is getting dialyzed for acute kidney injury, for example, it does really make a difference. Second point is, in an septic patient who ends up on renal replacement therapy, who's often coagulopathic, if you are constrained to not use heparin on your conventional renal replacement sled circuit, you lose your circuit in about 6 to 8 hours time. So if I want to extend my sled for 12 hours, for example, I end up using two filters and the equivalent circuit. Whereas with CRRT, I have the opportunity of running it at a lower flow, and I also have the opportunity of using regional anticoagulation. So I can conserve the filter. And retrospectively, when I look back at my own data, where the amount of money which a patient spends on CRRT is probably less than what they would spend on a properly done sled which extends for 12 to 16 hours. That's the second point. Third point I would like to emphasize is that your drug dosing. If you are dealing with a septic patient, the clearances of your antimicrobials on a sled is very erratic. It depends upon what are your flows and how much target you have done. Whereas with a CRRT, your dosing can be as you would do on a normal GFR patient. So your compromise on your antimicrobial dose or your antimicrobial frequency is probably not as much on a CRRT as you would do on a patient who's on sled. So these are the reasons why I still feel that in a selected cohort of septic pure intensive care patients on whom RRT has been initiated for intensive care indications, CRRT still has an edge over SLED despite all the negative evidence we have.
Thank you.
I completely concur with Srinivas. I completely concur with Srinivas. What he said is what we practice right now.
Sir, we have to conclude this session.
Just last, early versus late RRT we have explained, but two of you, do you go for early RRT in your septic patient who is anuric, and how long are you going to wait? Just one or two words.
I am usually an early one, sir. I believe that we need to have things under control. And as Srinivas said, in the septic patients, it's important to give them correct dose and frequency of antimicrobial as well. And you start getting restrained by giving half dose, and then you dose it every second day or something. Those are just doses which don't help. At that point of time, the Sanjeevani, if I may use the Hindi word, Sanjeevani booty is actually the antibiotic. We need to make sure that we can give them. And if dialysis or renal failure is getting in my way, I would rather initiate it very quickly and start on them on CRRT and get on with the job, rather than actually dilly-dallying and waiting and then adjusting the doses and not knowing what the absorption of that dose is and how the pharmacokinetics and dynamics have changed for it.
Okay. And the same with Srinivas, because I go by early. I know there are debate over that, but I agree with all our panelists are in the same opinion that in case of sepsis, you need to go for early dialysis if your patient demands that. With this few words, I like to thank all my panelists and also to thank you for this session. Thank you.
Thank you to all panelists and moderators for such a wonderful session. We will move to next session, that is AKI, role of furosemide. And with us the eminent speaker that Dr. Orgho Majumdar. He is a director and head of nephrologist AMRI Hospital, AMRI Hospital, and also HOD of AMRI Hospital Mukundapur. And sir is a president of Nephrology Society. Sir, please start your lecture.
I feel all our panelists are in the same opinion that in case of sepsis, you need to go for early dialysis if your patient demands that. With this few words, I'd like to thank all my panelists and also to thank you for this session. Thank you.
Thank you to all panelists and moderators for such a wonderful session. We will move to next session, that is AKI, role of furosemide. And with us the eminent speaker that Dr. Orgho Majumdar. He is a director and head of nephrologist AMRI Hospital, AMRI Hospital, and also HOD of AMRI Hospital Mukundapur. And sir is a
Oro, can you unmute? Can't hear you.
আরে এখানে হচ্ছে যে আটকে গেছে কেন?
Orgo, just unmute and can you give me?
Orgho sir, please unmute.
We can't hear you. Can you share the screen?
Orgho sir, we can't hear you. Omida ma'am. Hello. হ্যাঁ ম্যাম, আসিফ বলছি ম্যাম। ওই ডক্টর সুবল দীক্ষিতের লেকচারটা ছিল এই 3:55, স্যারের 4:10 থেকে একটা হচ্ছে ওই মিনিস্ট্রি লেভেলের মিটিং আছে। স্যার ইজ হ্যাঁ আপনার মানে এর পরেরটা স্যারকে দিয়ে দিচ্ছি, স্যারের পরেই আপনারটা শুরু করছি। হ্যাঁ হ্যাঁ
আসিফ আমার কি এখানে আছে?
Yes, yes, sir.
Asif Rajarshi.
You are chairperson. Sir, you are chairperson for this session.
In this session?
Yes, sir.
Majumdar is not coming in the.
But it is not with Tanmada.
No, not Tanmada. It is Dr. Orgho Majumdar.
ওনাকে তো দেখা যাচ্ছে, কিন্তু ওনার স্ক্রিনে আসছে না।
So, Dr. Majumdar, I will request you, if you have any of the headphone with you, can you just connect with your headphone and try speaking?
Can we start next session? Then we will come.
Acha, Asif, I would suggest you tell some of them to switch off the camera.
Okay, should I switch off my camera?
Switched off the. I've switched off my camera. I think the others should switch off their camera. Then
Okay.
তোর ওখানে তোর নেটের জন্য হচ্ছে ওটা। Can I request the others to switch off their camera, please?
Yeah.
Yes. We are just switching off.
Yes, everybody.
Shushil, can you switch off your camera? Shushil.
I have done it.
No, Shushil. Shushil, can you hear me?
No, it's not related to camera. It's something else. So we will move to next session. Then we will come back.
Okay, then we are basically switching off.
Dr. Ghosh. Can we move to next session? Then we will come back.
Dr. Majumdar, can we do that?
We're not getting.
We are not able to connect. We are not able to connect with Orguda, I believe. Asif.
Yes.
Asif, you call up Orguda by your own phone.
Sir is
from a different line. You call up and catch in a different line.
Yes.
We are in the queue.
I've done that.
Can you hear me?
Yes, I can hear you now.
No, it's not related to camera. It's something.
I've switched off my camera.
So we will move to next session. Then we will come back. Okay. Okay.
We are basically switching off.
We are moving to session goals.
Then what is the time?
And we should log in. Next session. Then we will come back.
Dr. Majumdar, can we do that?
We're not getting.
We are not able to connect. We are not able to connect to Orguda, I believe.
Sir, I will request Asif sir. I will request if you can type Dr. Majumdar number in the chat.
You call up Orguda by your own phone.
Not getting him. That is
from a different line. You call up.
Rajesh, can we come back after the next session? Is it okay with you? Or
Yes, no problem, Shwashindra.
Go ahead. And Asif, have you received Orgo's slide?
I've done
Can
that.
you hear me?
Yes, I can hear you now.
You're not related to camera.
I've switched off my camera.
So we will move to next session. Then come back. Can we start session? We are moving to session goals.
Then what is the time?
We should log in. Next session, then we will come back. Yes, we are starting next session. Dr. Shiva.
Yes. Asif, I will talk, no problem.
Yes, sir. You start.
Yeah. Can I share my slide?
Yes, sir.
Yes. Number in the
Getting
Can you see?
Rajesh, can we come back after the next session? Is it okay with you? Or
Yes, no problem, Shwashindra.
Can you mute?
Yes, I can hear you now.
Mute others. Please. Can we start? Yes, sir. We are moving to
Yeah, Asif, no problem. I am ready.
Yes, sir.
You
So
can see the
our
slide.
next session is nutrition in critically obese patient. Dr. Shubal Dixit is an eminent speaker, and sir is a chief intensivist director in Sanjeevan Hospital, Pune, and sir also ICCM president, ICCM secretary. Sorry, ICCM president. Sorry, sir, you start.
Yes, sir. Thank you, Asif. Can you see my screen, Asif?
Yes, sir. Yes, sir.
Yeah. So thank you, Asif, and thank all the organizing committee, and thanks Suresh also for requesting me to talk on this important topic of nutrition in the critically ill obese patients. And nutrition itself is a topic which is very close to my heart. We know that critically ill patients are always in a hypercatabolic state, and because of the hypercatabolic state, they are very prone for rapid state of malnourishment. And this is mainly because of the stress which is induced by the liberation of the various inflammatory markers, cytokines, and the other mediators. And basically because of this, there is a poor outcome, and this has been associated because of critical illness, and that mainly plays the key role. And therefore, giving nutrition early is very important to reduce the morbidity as well as mortality. And majority of these patients, those patients who are into cancer cachexia, those patients of inflammatory bowel disease, those patients who are obese, they're definitely in a very severe hypercatabolic state, and the inflammatory response is much variable as compared to those which are seen in any other normal individual. And the percentage of malnourishment is much more greater than as compared to any other normal subset of patients at that minute of phase. If you really see how the phases are there, into the acute phase, what we see, there is an early period where there is a severe amount of metabolic derangements and a metabolic instability. And this is a state where very severe catabolism occurs. And this follows by a late phase, which is approximately about 4 days to 8 days. And here significant amount of muscle loss can occur if proper nutrition is not given. If you don't give nutrition, the amount of muscle mass which can be lost is almost about 900 grams of per day of muscle mass can be lost. And in case if you treat it, then over a period of time, that means the anabolism starts, and it's a slow phase anabolism which occurs, and then improvement occurs, and it takes almost about 4 weeks to 6 weeks for this entire hypercatabolic state to go down and then achieve certain amount of stability. Various studies have been shown. Various studies have definitely shown that malnourishment, which has been associated with increased amount of ICU length of stay, increased readmission to the intensive care units, and increased amount of morbidity. And malnourishment itself is associated with poor outcomes into the intensive care units, and this way back in the Journal of Enteral Nutrition. So medical nutrition therapy, is it now called as? It is mainly enteral or parenteral. Yes, it is very important because we need to see the metabolism of the patient. All patients are in a very severe hypercatabolic state. There is a big amount of glucose dysglycemia which is occurring, which is there because of the preparation of various cytokines and the anti-insulin hormones. There is a larger breakdown of proteins and much amount of reduced protein synthesis, and therefore if you don't feed it also at the same time, intestinal changes of villus atrophy can occur, translocation of bacteria can occur from the gut, and therefore thus we can land up into secondary complications and multiple organ failure. This study was again given and published that all patients who are mechanically ventilated, definitely by whichever route you are giving early calorie intake was associated in case if you don't feed them, that was associated with mortality, and therefore early nutrition was also associated with increased risk into these patients of septic shock. The various guidelines which were published by the European Society or the Canadian guidelines or the SCCM and the SCCM guidelines and the Australian guidelines all suggested that you should start feeding the patients within the first 24 hours after achieving a hemodynamic stability. And that hemodynamic stability is defined as one, that means there is optimization of the fluid and there is a decreasing doses of vasopressors which are requirement. So you must have a decreasing dose of vasopressors which are required in case if the patient is in gross shock and the requirements of vasopressors are high. You should hold feed because of mesenteric ischemia, which can also give rise to paralytic ileus, and then you can land up into problems of refeeding, or sometimes the feed which does not get tolerated, which is very, very important. And thus achieving a hemodynamic stability is defined mainly by the reducing doses of vasopressors, and the MAP should be at least about 60 millimeters of mercury, and the fluids really needs to be optimized. Which is the best way to feed the patients? Yes, of course, the gut, because if you use it, otherwise you'll lose it. And because maintaining the gut integrity is very important, because if you don't feed it, then the villus atrophy will occur, and that villus atrophy over a period of time will undergo a translocation of bacteria from the gut, and that can lead up into secondary complications. Giving enteral nutrition is much more cheaper, much more physiological, much more easier, and than giving any other form of different forms of nutrition support. And the problems what we face in patients of these obese sometimes is you get vomiting, you get increased amount of gastric residual volumes, but you must not get worried about the gastric residual volumes, because nowadays checking up of the aspirates is not much that amount of importance unless you get a severe intestinal obstruction. Definitely you should continue to feed the patients, reduce the rate of feeding by half, use prokinetics in the form of erythromycin or using metoclopramide or intravenous of levosulfide, and continue to feed the patients. Yes, diarrhea can be one of the problems, but mind you, diarrhea is not always because of enteral nutrition. It could also be because of the long-standing admission into the intensive care units. It could be a pseudomembranous colitis. It could be because of antibiotics. So please rule out a Clostridium difficile infection before blaming diarrhea. Hemodynamic instability if the patient worsens, and if you have the fear of complications of perforations, and more importantly, the problems is if you don't have a proper feeding protocol. You must have a feeding protocol to assess it, how feeding should be given, whether a continuous feeding should be given with the help of a feeding bag or an infusion pump, and at the same time, you must also check for the delivery of nutrition, which is equally important, not only planning up of the nutrition prescription. And important is, you must also have the facility to give a post-pyloric feeding in case if you are dealing with a pancreatitis, in case if there is a gastrectomy, which is also being done, or in case in these obese patients, sometimes a sleeve gastrectomy, which is also sometimes being considered. You also need to consider a post-pyloric feeding if it's a real morbid obese patients, because you can't continue to keep the patient nil by mouth for an extended period of time. Now, inadequate delivery of nutrition is also very common. Multiple studies have been done at different sites, and you can see here from this, almost achieving the goals which were there were just in about 50% to 60% of the patient we could achieve the goals, and this was the frequent problems which are associated with the delivery of it. At the same time, not only the prescription was planned, but it was also seen that there was a discrepancy which also existed between the delivered amount of the product of nutrition along with the prescribed amount, and that occurred in approximately about 15% to 40% of the patient. That means the X prescription was given, but a Y prescription or the less amount of quantity was also being delivered to such kind of patients. And mind you, these problems occur because if you don't have a feeding protocol, if you don't have exactly the quantification how it needs to be given, and if you don't have a proper nutrition prescription which is being planned. Now, giving adequate nutrition may also get you home, but the effect of caloric and protein deficits on discharge destination of critically ill surgical patients is very important. You have seen here from this year that in case if you find that you're giving a higher calorie and a protein are mainly associated with increased length of ICU stay, or associated with the length of hospital stay, which is also increased into these subset of patients. And at the same time, there were other studies which we find that the higher calorie and protein deficits are again associated with high rates of in-hospital mortality, as well as a 30-day mortality and lower rate of discharge, which was also seen into these subset of patients. So giving the exact calories, giving the exact balance, don't give too much, and at the same time don't underfeed. Both are important. So you must achieve the exact delivered number of calories, which are very, very important. And thus, they can, if you don't give it, then that inadequacy can also lead to morbidity and mortality. Morbidity into these morbidly obese patients is tremendous. You may have land up into other medical complications of deep vein thrombosis, difficult to wean patients off. There are other complications. Plus, they have got an element of, again, obstructive sleep apnea, which can also further complicate weaning from mechanical ventilation. So enteral nutrition is the key. It is often the most important thing, and don't get worried about a GIT failure or a gastrointestinal tract failure. And in case if you cannot achieve the goal of approximately 70% to 80% of the calorie goal within the first 72 hours, you should use partial parenteral or supplemental parenteral nutrition support, so that you can again prevent underfeeding, and as a result of which you can also avoid the protein energy complications or the protein energy deficit complications which are really going to occur. If you really, this is a flow chart which is just been taken up. It's very simple, that analyze each and every admission into intensive care unit with the help of Nutrix score. Take the ideal body weight into consideration, not the actual body weight into consideration. You should definitely start off with at least 22 to 24 kilocalories or per kg body weight. Try to achieve 75% or the 80% of the calorie goals, and especially into these, if you find that the delivery is quite sufficient enough, then don't hesitate and build it up over the next 72 hours. And in case if you cannot reach 80% of the caloric goals, and if enteral nutrition cannot be continued further, then definitely use supplemental parenteral nutrition support so as to give the calorie deficit, because having a cumulative calorie energy deficit per day, which goes up above again about 8,000 kilocalories per day, that can also increase the morbidity as well as mortality into intensive care units. And this was again said that yes, avoid underfeeding into severely ill patients and start them on an early enteral nutrition support as much as given. Now, clinical practice, as I said, each and every patient needs to be assessed with ideal body weight. You should screen them with Nutrix score. You should see the other parameters such as the inflammatory markers, such as the CRP, the triglycerides, the sugar levels, the HbA1c levels, the urea, the creatinine, and the urinary nitrogen ratios, which is very important, especially into these obese critically ill patients. You must also calculate the BMI of these patients, and You must have a feeding plan and a feeding protocol must be in place. You must see that the enteral nutrition delivery is optimized. You may have problems of the intra-abdominal pressure or the compartment intra-abdominal pressure which is going up because of the thickness of the abdominal muscle wall. So therefore, you have to sometimes consider to use continuous feeding with the help of prokinetics and start them on early supplemental parenteral nutrition support in case if you cannot achieve 60% of the calorie goals are not reached within about 72 hours. Vis-a-vis, if you compare it with a normal person, we say at least you must reach at least about 75% to 80% of the calorie goals within the first 72 hours. Use supplemental parenteral nutrition support. You must definitely use vitamins, minerals, trace elements, and of course immunonutrition and fish oil. They are contraindicated, especially in case if you are dealing with a septic shock with renal failure. But mind you, in case if you have got a cancer patients, in case if you have got a trauma patients, in case if you have a burns patient, definitely the glutamine levels are very much on the lower side in the initial part of it. And these are the subset of patients where you can consider to use fish oil or in the form of glutamine, preferably and probably that the patient should not be into septic shock. The patient should not be having a renal dysfunction. They are the prerequisites before consideration to initiate immunonutrition into the subset of patients. Again, nutrition into these obese patients. These patients are definitely separate. They are unique challenge, as I said. Early administration of proteins with carbohydrates and then lipids. They are very important in order to maintain a good amount of a glycemic control, in order to avoid no amount of anabolism which is also occurring. And the morbid obesity is mainly defined as class 1, class 2. The BMI levels are going about 30 and progressively upwards to moderate, severe, and very high. In case if the BMI is about 40, definitely it's the risk associated is very high and it's almost a class 3 kind of obesity. You will have problems of dysglycemia, HbA1c, the muscle breakdown, and the requirement of calories also going to be very high. In these patients, I would definitely go by a case base. Does obesity really impact the outcome in critical ill patients? And if so, is there a risk from obesity which is in stratified? And these was published in the Journal of Enteral Nutrition in 2011. It is said that these obese critical ill patients are expected to have a greater number of comorbidities. As I said, they may be pressure sores, they may be bedridden patients, the morbidity and the mobility is less. They may have aspiration pneumonias, the lung functions are not proper. There is obstructive sleep element. There is also element of a renal dysfunction because of a morbid obesity, because of a pressure abdominal compartment, abdominal pressures which are very high. There may be UTIs which are again compressions and subsequently more complications than the lean counterparts. And these obese patients, as I said, have great metabolic derangements and they really many affect the delivery and the fuel utilizations. Does obesity impact the outcome in critically ill patients? The effect of obesity on the ICU and the mortality is both controversial and there's very much uncertainty. But most experienced clinicians believe that the mortality may be worse in those patients, as I said, if the class 3 obesity of the BMI is more than 40. And these critically ill patients are at an increased risk mainly because of the obesity related complications rather than and superimposed with the additional comorbidities like diabetes, ischemic heart disease, obstructive cell element, sugar control, hypothyroidism. All these problems can further complicate the delivery as well as the recovery of these patients. And what is the focus of nutritional assessment? More important is sometimes say the actual body weight, but more important you have to calculate and you have to see the Nutri score along with the anthropometric measurements. You must also try to have the actual body weight and the usual body weight and the ideal body weight. You must measure the height and the weight and the waist circumference and other biomarkers, as I said, the CRP, the liver functions, the triglycerides, the cholesterol, the thyroid functions, HbA1c, sugar levels have to be seen. And these are very, very important. The obese patients, you also need to existing for other comorbidities which are there, whether he's had a stroke, whether he's had a blood gas, and what is the urea nitrogen levels, what is the carbon dioxide levels and the baseline deficit before initiation. And in case if you, along with this, you must also try to measure with the help of ultrasonography, the muscle thickness, especially the triceps or especially the rectus femoris muscle thickness should be measured, so that you know that assessment and monitoring of the delivery of nutrition support can be very well seen. Along with this, in case if you have it, it's very much better to have indirect calorimetry. The indirect calorimetry also tells you the exact amount of nutrition support, because the degree of inflammation is going to be variable, and this is going to be variable depending upon the oxidative as well as the metabolic stress. And therefore, the patterns of weight change and the nutrition intake prior to the admission have to be evaluated, and the use of an actual body weight is not recommended because of lack of validation of the studies, and you have to have a greater amount of assessment as far as the weight is concerned and the ideal body weight. And what should be the protein target and the energy patients, especially into these patients? High protein but feeding should be provided to these amount of ICU patients, regardless of whether the route of feeding is either enteral or a partial parenteral nutrition support. These patients usually don't require total parenteral support, and the protein delivery should be started actually depending upon the weight-based basis around about 2 to 2.5 grams per kg of ideal body weight, especially for class 1, class 2 or class 3. If the BMI is about 20, about 30 to 35, 35 to 40 and above 40 is class 3 of morbid obesity. And these protein adjustments should be done depending upon the urinary nitrogen ratios, and they have to be measured. That is, the 24-hour urine studies should be done, and then you can have the assessment of the urinary nitrogen ratios which are giving up. And the recommendation for the protein target delivery, as I said, it should be about 60% of the caloric requirements, which is being provided by indirect calorimetry or by other predictive equations. And if you know calorimetry, you can use this formula of about 11 to 14 kilocalories per kg of ideal body weight, of actual body weight. Or in case if you're having the ideal body weight, you can use about 20 to 22 kilocalories of ideal body weight, which should be started off, and they should be initiated on enteral nutrition support, and to achieve it 60% of the calorie goals within the first 72 hours. The hypercaloremic studies which have been seen into these obese patients, large number of studies have been done. You can see here the actual body weight was taken into consideration. They also gave a protein delivery of approximately about 1.5 to 2.1 grams of grams per kg of body weight, and they can see the outcome years into these patients, that they found that the wound healing was also better. There was also less amount of insulin therapy, and there was no difference in the mortality, and there was again no difference in the mortality by Liu in 2000 studies, and there was a decreased amount of ICU stay, decreased antibiotic stays, and there was a trend in towards a decrease in the ventilatory free days into these studies, which was published way back in 2005. So even the SCCM and the SPEN guidelines suggested that these patients definitely should follow the bundle of care. You should initiate them on enteral nutrition support within the first 24 hours. You should always keep the head up and elevated. You must also sometimes use prokinetics early and use continuous kind of feeding. You must also continue to avoid into these, and you must also monitor the sugar levels, control the sugar levels to between 150 to 170, and you must start partial parenteral nutrition in case if you cannot achieve 60% of the calorie goals. We service used to take about 80% of the calorie goals in a normal individual into these high risk kind of patients. And the modern parenteral nutrition support is not associated with any amount of infections and complications. You can see here that Wishmeyer, Jalui, and Gattinoni, all the biggies of intensive care were there into this meeting, which was held way back in 2014. And they said that yes, if you use a combination of lipids plus glucose, it gives you a better amount of glycemic control. It improves lipid formulations because of their requirements. And in case if you really need to give it, you can also use smaller 3-in-1 bags, all-in-one bags, which are much more easy. You must have a vigilant central line for delivery of these partial parenteral nutrition support. And you may benefit it, especially if you are using a soya-based kind of feeds. And these omega-3 fatty acids, as well as these fish oils, sometimes may be required, especially on inadequate enteral nutrition support, provided the patient has got a hemodynamic stability, no renal failure, and the patient is not into a septic kind of shock. You must supplement them with vitamins, minerals, as well as antioxidants. And last few slides, and the last slide for the take-home message is, all patients should be screened for malnourishment. You should screen them as early as possible. Use a Nutri score. Use indirect calorimetry in case if you have it. You must have a variety of agents which are available, and they should be added in case if the patient is not into septic shock. In obesity, it's a complex situation. Achieve 60% of the caloric goals, but take into consideration the various comorbidities which are there into these patients so as to reduce the morbidity and the mortality. And the basic principles of critical care nutrition also apply to these obese patients. You have to give them high protein and hypocaloric diet so that you can reduce the fat mass, improve the insulin sensitivity, but at the same time, you preserve the body mass. Thank you very much.
Thank you, sir. Thank you for wonderful presentation, and thank you, Anirban, for hosting this session. And we will move to our next session. Dr. Majumdar, are you ready for your presentation? Dr. Orgo Majumdar? Dr. Orgo Majumdar? Sir, are you ready?
Asif, can I leave?
Yes, sir. Thank you. Thank you, sir. So we are...
Thank you, Asif, and thank organizing.
Thank you, sir. So we are starting the next lecture, Evolving Paradigms in the Selection of Biologics in a Severe Asthma. And the we will have an eminent speaker, Dr.
Also apply to these obese. You have to give them high protein and hypocaloric diet so that you can reduce the fat mass, improve the insulin.
Dr. Sushil
Agarwal, you preserve
body mass. Thank you, sir. Thank you for wonderful presentation, and thank you, Anirban, for hosting this session. Our next session, Dr. Majumdar, are you ready for your presentation? Dr. Orgo Majumdar? Dr. Orgo Majumdar? Sir, are you ready?
Asif, can I leave?
Yes, sir. Thank you. Thank you, sir. So we are...
Thank you, Asif, and thank organizing.
You cannot be heard. Orgo, can you speak?
Evolving Paradigms in the Selection of Biologics in a Severe Asthma. And the we will have an eminent speaker, Dr.
You have to give them high protein and hypocaloric diet so that you can reduce the fat mass, improve the insulin.
Dr. Sushil Agarwal,
you preserve
body mass. Thank you, sir. Thank you for wonderful presentation, and thank you, Anirban, for hosting this session. Our next session, Dr. Majumdar, are you ready for your presentation?
Welcome, Angira. I do not know whether we are going with Dr. Majumdar's presentation or
yours. Asif, can I leave? Yes, sir. Thank you. Thank you, sir. Hello. So we are...
thank you, Asif.
You cannot be heard. Orgo, can you speak?
Evolving Paradigms in the Selection of Biologics in a Severe Asthma. And the we will have an eminent speaker, Dr.
You have to give them high protein and hypocaloric diet so that you can reduce the fat mass, improve the insulin.
Dr. Sushil Agarwal,
you preserve
There is some voice in the background.
Thank you, sir. Thank you for wonderful presentation, and thank you, Anirban, for hosting this session. Our next session, Dr. Majumdar, are you ready for your presentation?
I cannot hear anything because there is something which is being played in the background.
Evolving Paradigms in the Selection of Biologics in a Severe Asthma.
Talk, but I don't think I will be heard.
We will have an eminent speaker,
Should I talk or I just cannot understand?
Thank you, Anirban, for hosting this session. Our next session, Dr. Majumdar, are you ready for your presentation?
Welcome, Angira. I do not know whether we are going to Dr. Majumdar's presence or not.
Start please. সবাইকে ফোন কর এক থেকে ফোন কর
Played in the background. Yes, now it's clear. Okay, thank you.
Yes.
Okay. So, thank you, organizers, for inviting me for this talk, especially Shubhashita. And thank you, Chairperson, for entrusting me with such an important topic, a topic which is very close to my heart. I'll try and be as quick as possible because I realize that we are running really short of time. So the objectives of my talk today would be to be able to recognize which patient would benefit from which biology and to understand how different endotypes of airway inflammation would help us in selection of the biologic. And I will try and put it with the help of case studies so that we can put everything together at the end of the lecture into the clinical practice scenario. If we take a look at the GINA guidelines, it is very obvious that the step where biologics comes in is the step 5. That is when all the medications in step 1, 2, 3, and 4 have exhausted. That is the patient in which we have to consider using biologics. However, there is no clear-cut indications that has been made by GINA to tell us which biologic is going to be prescribed to which patient. It just says, step 5, refer for addition of treatment with anti-IgE, anti-IL-5. Now, given the fact that we have several anti-IL-5s coming into the market very soon, we need to have a very clear-cut understanding as to which biologic we would be prescribing to which patient. Now, why do we need biologics at all? That's because around 5 to 10% of asthmatics remain symptomatic despite the best available therapies. And there are patients in our clinics of severe asthma who are on long-term oral corticosteroids and develop its heinous side effects. So biologics, in fact, help to taper off the dose of oral corticosteroids. And again, how do we decide which biologic we use for which patient? The approach that I usually take is to try and understand what is driving the disease in my particular patient of severe asthma. So that's what I call a mechanistic approach. There are several methods by which we can do phenotyping. If we are using sputum, we could do it by way of using a sputum quantitative assay. Measurements of the various granular contents of eosinophil. Blood tests to look at the eosinophil counts, the eosinophil cationic protein, periostin, and even proteomics. Exhaled breath measurements in the form of nitric oxide, carbon monoxide, hydrogen peroxide in the condensate, in breath condensate, and also sometimes temperature helps to understand whether or not there is an underlying inflammation going on. And urine has also been used to differentiate between patients who have uncontrolled inflammation versus no inflammation. Now, this is what I mean when I say that I approach my patients from a mechanistic point of view. There are 3 different mechanisms which drive severe asthma patients. The first one is the Th2 driven or the eosinophil driven mechanism. The second is the Th1 or neutrophil driven mechanism. And the third one is the B cell mechanism. So let us see how we understand which patient belongs to which mechanism point of view. So if we are looking at a B cell mechanism, the thing that we would measure is a serum IgE. If we are doing a high Th2 patient, that would be blood eosinophil counts. And FeNO is sometimes used as a surrogate for sputum eosinophils, but which is not true. FeNO can only tell us whether or not an underlying airway inflammation is going on. It can not tell us what type of inflammation it actually is. So Sputum quantitative assay, on the other hand, can tell us all the different types of inflammation, and in fact, it also helps us to prescribe drugs and to modify or titrate the drug doses too. The concept of phenotyping is quite old. This gentleman here, Harry Morrow Brown, was the first person who in the year 1958 published this paper where he was very observant and he could find that approximately half the patients of asthma did not show improvement with corticosteroids. In fact, he was also able to attribute the responsiveness to steroids to eosinophils present in the sputum. For some unknown reason, this method of phenotyping did not hold on for a long time until this gentleman here, Freddie Hargreave, started his own concept of describing the airway diseases of having three different components, of which the airway inflammation was the most important component, and that gave rise to all the other features of asthma. We measure airflow obstruction with the help of spirometry, airway hyperresponsiveness with bronchoprovocation tests, and airway inflammation is measured by a process which we call the sputum quantitative assay. I'm not going to describe the process here, but just going to talk about the interpretation, because the process of sputum quantitative assay is actually a laboratory technician's domain. So I'll just talk about the different interpretation of the results. You could have eosinophilic inflammation, which is more than 3% eosinophils in sputum with a normal total cell count. You could have a neutrophilic inflammation where there are more than 65% neutrophils in the sputum with or without increase in the total cell count. You could have a combined inflammation where you could have eosinophilic and neutrophilic, or a paucigranulocytic inflammation, which is essentially having a normal cell count in the assay. Now let us see how we can use that knowledge in this 50-year-old gentleman who was a never smoker and asthmatic since late 20s. He came to the clinic with a history of recurrent exacerbations, 3 such exacerbations in the previous 1 year, and every time he responded to short courses of corticosteroids. He gave us an allergy to dust, rhinosinusitis, nasal polyposis. His father had asthma, and his 16-year-old son had just started to be breathless with exercise. The patient was on treatment with inhaled corticosteroid, very high doses of fluticasone, long-acting muscarinic agents, long-acting beta-2 agonists, and a leukotriene receptor antagonist. He had documented sputum eosinophilia once, and his specialist decided to maintain him on a low dose of prednisone, 7.5 milligrams per day. When the patient came to me in the clinic, I went through these investigations whereby the FEV1 was not too low. It was at 62% predicted. FVC was at 78% predicted. HRCT scan of the thorax was normal. The serum IgE was essentially normal. The absolute eosinophil count of blood was 0.3. So anything more than 300 cells of eosinophil in the blood is eosinophilic, which is, we just had a borderline case in this patient. The sputum quantitative assay showed a total cell count of 9 million cells per gram of sputum with 60% neutrophils, 10% eosinophils. The normal is, you would remember, is less than 3. So because we have a count of 10%, this patient is supposed to have an eosinophilic bronchitis or an eosinophilic inflammation which is going on in the airways. So what do we do next? The patient is on very high doses of inhaled corticosteroid, very high doses of oral corticosteroids. So we need to do something for the patient because he still remains symptomatic. The next thing to do would be to start on a biologic, but again, which one? Now, the anti-IL-5s or the anti-eosinophil drugs are and there are quite a number of them, and this is a time chart showing which ones are available. At present, in India, we have just mepolizumab available. Benralizumab is going to be launched, I think, next month or maybe the month after that. And we've been having omalizumab since 2003 in India, although it is not being used that much in the severe asthma patients. but still it's there in the market, and some people have really shown a lot of improvement by using omalizumab. Now, I am showing this slide because I wanted to highlight that there are essentially two different pathways where we can have the eosinophils in the airways. The canonical pathway, whereby the allergen comes in contact with the airway epithelium, which secretes IL-5, IL-25, which goes and stimulates the naive T cells into secreting cytokines, either IL-5 or IL-13 or 14, and depending on which pathway is predominant, we get the clinical features. And this is what helps us differentiate between the patients who are going to benefit from IL-13, IL-4, or IL-5. Now, you can see that the IL-13, IL-4, the one which I have encircled with the green color, that points to the airway smooth muscle. So if we have a lot of secretions, a lot of bronchial hyperresponsiveness or twitchiness, these are the patients who are going to respond to anti-IL-13 and anti-IL-4. Whereas if the IL-5 related events are more, which is a high eosinophil count in the blood or in the airways, these are the patients who's going to respond to mepolizumab or the anti-IL-5s. Now, this is one pathway which is common in all individuals, but there is also an alternative pathway whereby we have innate lymphoid cells in the airways, which are the source of eosinophils in the airways. So this is to share with you the concept that there is a disconnect between eosinophils in the airways and eosinophils in the blood. Now, from this graph, it's pretty clear that you could have very high levels of sputum eosinophils, but a low blood eosinophils, and vice versa. So one is not going to be a surrogate of the other. If you have a lot of eosinophils in the blood, it does not mean that we are going to have a lot of eosinophils in the airways. Now, eosinophils in the blood could be present, but not being activated. So just the mere presence of eosinophils in a certain place, or rather in the blood, does not mean that it is pathogenic or contributing to the pathology of the patient. Now, everybody is talking about these days about the anti-IL-5s, that is the mepolizumab, reslizumab, and benralizumab. Now, what is the difference between these three anti-IL-5s? Mepolizumab is the oldest one. It's an anti-IL-5 directly. It blocks the interleukin 5 from functioning in various cells. Reslizumab has a similar way of mechanism of action, whereas benralizumab, it appears to be a receptor antagonist. So when we say it's a receptor and antagonist, we have to demonstrate the receptor being present in the particular cell where the molecule is going to work. So if we do not have a cell where we can demonstrate the anti-IL-5 or the IL-5 receptor being present, then this molecule is not going to work, which means that if we have IL-5 in the blood and no cells with IL-5 receptors in the airways, this drug is not going to work that well. So this again brings us back to the concept that we need to demonstrate a high level of eosinophils in the airways in order to predict the fact that this patient is going to respond to a benralizumab or a receptor blocker. Besides the IL-5s, you also have anti-IL-4, anti-IL-13, the dupilumab and the lebrikizumab. These function on both the B cells as well as on the smooth muscle cells, like I pointed out in the earlier cartoon. These are not yet available in India, so we still have to restrict our use to the anti-IL-5s as of now. Now, we've been having mepolizumab in our armamentarium for severe asthmatics for quite a long time. And most of the initial studies were failures because they treated all asthmatics as having a similar or a homogeneous profile of disease. So they just took the severe asthmatics, randomized them, and gave them mepolizumab, which is why that was a failure. But for the first time, Dr. Nair and associates were able to demonstrate that if we could be very, very sure that a particular patient was having a eosinophilic variety of severe asthma, it was mepolizumab worked wonderfully well. And how did they do that? It was not only once that they demonstrated eosinophils in a particular patient, they demonstrated that over the past 1 year, the patient had twice or 3 times demonstrated that he or she had an eosinophilic airway disease and had responded to corticosteroids. This is what happened when they selected patients according to that exacerbation history and eosinophilic inflammation history in the DREAM study. And this is
We're
when...
running shortage of time. Ma'am, we are running shortage of time, please.
Yeah. I'll finish up, don't worry. So, mepolizumab reduced the exacerbations rates. And of course, the blood eosinophils count and the sputum eosinophil counts did come down. The second phenotype that I'm going to talk about is the Th1, or the high neutrophilic bronchitis phenotype. And the only way that we can identify this sort of a phenotype is by doing the sputum assay. No matter how much you look for the neutrophils in the blood, it does not come up. It has to be present in the airways, and sputum is the only method where we can find out if severe asthma has a neutrophilic component. There are drugs available to treat, there are biologics available to treat neutrophilic asthma, but it has to be done very carefully because neutrophils are the firefighters in our system, and if we knock them down, then God help us. TNF-alpha is another biologic which has been used in patients who have postgranulocytic sputum, because it has been shown that anti-TNF-alpha does not have an effect on airway inflammation in any way. So it is useful in improving the quality of life and improving the hyperresponsiveness in postgranulocytic sputum patients. And the last phenotype that I'll be talking about is the serum IgE, or the B cell mechanism. I think most of us are aware of this mechanism because we've always thought of asthma being atopic and non-atopic. And when we say atopic asthma, we look at serum IgE to demonstrate whether or not it's high or not. And the way we recognize this phenomena is, like I said, by having a high serum IgE or having an allergen-specific IgE, which is quite high. And the biologic to be used in such a scenario is omalizumab, which reduces the emergency visits for asthma, and it also improves the quality of life. So this is my last slide. This is a synthesis of all the information that I have been able to talk about during the past 10 to 15 minutes. If the patient is atopic with a reversible airflow obstruction, if the IgE is raised in the serum, if the eosinophil count is high, but not that high, then we can use an anti-IgE. Anti-IL-13 is usually used in patients who are atopic, have a lot of mucus hypersecretion and airway hyperresponsiveness. When we have severe asthma with frequent exacerbations, which we have demonstrated to be eosinophilic by way of having an increased blood eosinophil count or an increased sputum eosinophil count, we can use one of the anti-IL-5s. If there is atopy, nasal symptoms, aspirin sensitivity, and sputum eosinophils, then we have to go into the leukotriene pathway. If it's severe asthma with a normal sputum but airway hyperresponsiveness, anti-TNF-alpha has been tried in such a scenario and have definitely worked. But a more important intervention would be to try bronchial thermoplasty. Severe asthma infections, severe asthma without infections, but a lot of sputum neutrophils, then we can have one of the biologics which is anti-neutrophilic, that is anti-CXCR2.
Next talk is AKI, role on furosemide, and eminent speaker is Dr. Orgho Mojumdar, sir. He's a head of medicine and nephrology department, EMRI hospital, and also sir is the president of Nephrology Society. Sir, please start your session.
Hello, good evening. Can you hear me?
Yes, sir. Yes, sir.
Okay.
And Dr. Rajasri Roy is the chairperson of this session. Please, sir.
Okay, thank you. We have been using this molecule for the last 50 years or so. We use it almost every other day since the publication of this landmark article in Circulation. And you see the indications there are more or less similar: congestive heart failure, cirrhosis with ascites, nephrotic syndrome, essential hypertension. But the topic of today is the use of this molecule in AKI. Now, just before I go into the topic, we just briefly discuss the mechanism of action. Now, as we know that 85% of furosemide is excreted by the kidneys, and it is 98% protein bound, very highly protein bound. So hardly any portion of the drug is filtered through the glomerulus. It comes to the blood circulation to the tubules, and there is a human organic anion transporter system which helps to transport it through the proximal tubule and then facilitates its direct antidiuretic action in the ascending, thick ascending limb. In the thick ascending limb, there is a transluminal NKCC2 channel which is blocked, and thereby this sodium-potassium ATPase receptor also doesn't operate once furosemide is given, and therefore we can eliminate sodium and water from the body. So coming to the topic of today's talk, that is the role of furosemide, and I'll divide it into three parts: that in prevention of AKI, in the therapy of AKI, and in prognostication. First, coming to prevention of AKI. Now, how do we get the diuretic response? Basically, in AKI, when the urine output drops off, all we want to do is maybe give a shot of furosemide and see that there is a diuretic response. This depends on the urinary concentration, the time of delivery to the site of action, and the dynamics of the response at the site of action. Now, this is a cross-section of the tubule, and as you can see that once ATN develops, there is loss of polarity of the cells, and they detach from the basement membrane, they are apoptosed, and they block the tubules. So the first obvious effect of furosemide may be to improve the flow of filtrate and prevent this obstruction, and thereby it often converts oliguric into a non-oliguric AKI, and which is much easier to manage, because if the patient is producing some so-called urine that is getting rid of the water, then we can give the patient the necessary antibiotics and TPN, etc. Also, it decreases the medullary net oxygen consumption. I'll just explain in a minute. And by the diuretic, obviously, it prevents fluid overload. Now, there were some elegant animal experiments which showed that under hypoxic conditions, normally the S3, the straight segment of the proximal tubule, comes very near the thick ascending limb, particularly in the juxtamedullary nephrons. So if the ATP is blocked and there is conservation of oxygen in the thick ascending limb, that oxygen may be utilized by the S3 segments. And this study in animal experiment showed that the use of furosemide increased the oxygen availability in the S3 segment and improved the survival and prevent apoptosis. And this was also subsequently showed by Aravindan that furosemide prevents apoptosis and associated gene expression in a rat model. So now we have the rationale of using this molecule in preventing AKI. Now, this was one of the earliest studies in the published in NEJM, where they compared saline infusion, mannitol, versus furosemide in preventing AKI secondary to contrast agents. And as you can see from the results, the furosemide did not fare quite as well, because 11% of the patients on saline, 28% of those on mannitol, and 40% of those on furosemide went on to develop AKI. So the early results weren't promising regarding prevention of CA-AKI. Similarly, another study published in 2000 showed lack of renoprotective effects of furosemide during cardiac surgery. That's the other scenario where we try to prevent AKI by use of these agents. And when low dose dopamine was compared with furosemide versus placebo, you can see that in the furosemide group, the creatinine did go up, and particularly those receiving boluses, the creatinine really went up. So early results were discouraging. But recently, we'd say a new concept has arisen, and that is induced diuresis with matched hydration. And with this, who knows, probably furosemide may be making a comeback. So in this study published in JACC, this is the MYTHOS study. So this was patients who are again going to be exposed to contrast agents for imaging. So initially, intravenous saline 250 ml was given over 30 minutes, and after that, furosemide infusion was started at 0.5 mg per kg. And the urine output was sort of maintained at more than 300 ml per hour over the next hour. And then the contrast, that is the coronary angio, was done, and patient was observed over the next 4 hours, and throughout a saline infusion was given. Now, when we tried this strategy, now look, this is the overall incidence of AKI, more in the control group, and even in elective or urgent angiography, the group which received the furosemide infusion had much lesser incidence of contrast-induced AKI than the pure saline infusion. Now, again, in the backdrop of this concept, this AKI guard machine has been evolved, and this actually measures the online renal outflow per minute. And if there is an infusion of saline running, it will match the inflow with the output, and thereby preventing any central volume depletion. So this was a study using the AKI guard machine, and it compared sodium bicarbonate, isotonic saline, N-acetylcysteine, and vitamin C prophylaxis, which is called the BS-NAC group, against high volume forced diuresis with matched hydration in the CI-AKI prevention. So again, before contrast. And the remarkable result was that in the furosemide group, there was lowest incidence of CI-AKI. You can see 7% versus 25%, very statistically significant. And the major adverse cardiac and cerebrovascular events at 1 year was also 7% before versus 32% in the other group. Readmissions to cardiology and nephrology departments was again 8% versus 25%. 3 months after the procedure, the decrease in estimated GFR was 0.02% for MHG group versus 15% in the control group. So it seems that if you can keep the patient hydrated, then the effect of furosemide is quite beneficial. And this was a subsequent systematic review and meta-analysis. And you can see from this that in this forest plot, the diamond is on the left, so favoring renal guard. So using furosemide infusion along with saline infusion, using the AKI guard or the renal guard, definitely in all the studies, there was in favor of prevention of AKI with furosemide. So this must be the way we handle furosemide in future. Now coming to therapy of AKI, unfortunately, in this regard, there hasn't been much progress because once ATN is established and the cells are apoptosed, like I showed you in the earlier cartoon, then very little can be done. This was loop diuretic used in the management of acute renal failure. This was a prospective double-blind placebo-controlled study published in NDT in 1997, and all the patients received baseline saline and dopamine infusion, which was very prevalent in those days, and torsemide was compared with furosemide versus placebo. And as you can see, both in the torsemide group and in the furosemide group, there was increase in urine flow, but there was no increased incidence of renal recovery or need for dialysis. So the rationale was that a bolus of furosemide might help to assess the integrity of the renal tubular function at an early stage of evolving AKI. Because if furosemide works, that means the circulation around the tubules, the circulation is intact, and the organic transporter is also working. So tubule function is intact, so that the furosemide is actually being transported into the proximal tubule and is able to work in the distal tubule. So in a way, it tells us early on in AKI about the health of the tubule and the circulation around the tubule. So the kidney's response to furosemide challenge would enable a clinical evaluation of renal tubular function and reserve. The availability of furosemide at the site of tubular action necessitates adequate renal blood flow and organic anion secretion in the PCT. The successful diuretic response requires no limitation to urine flow by intratubular obstruction by cellular debris. This could help stratify patients with severe tubular injury before it becomes clinically obvious. Now, what was the test? Now, patients in stage 1 or 2 AKI by the Akin criteria, if they had not received furosemide in the last 7 days, they were given 1 milligram per kg furosemide bolus. If they had received furosemide in the previous 7 days, they received 1.5 milligram per kg furosemide bolus. Next, the urine output was monitored for the next 6 hours, and the important aspect was what was the urine volume at 2 hours after the loading dose. Was it more than 200 ml? If so, then it was said to be stress test positive with a positive response, or if not, it was a negative response. So the outcome targets were the primary outcome was noted as the progression to AKI Akin stage 3. So by use of this furosemide stress test, could we say the which patients will progress from stage 1 or 2 to stage 3 and the need for RRT? Within 2 weeks of this furosemide test. The secondary outcome was the aggregate of developing AKI akin stage 3 or death within 2 weeks of the FST. Now, as you can see that it is the 2-hour urine output which was most important. And this is the urine output in the patients who are responsive or stress test positive. And in the striped bars, you can see that these are stress test negative. And these are the patients with progress to akin 3. If we look at the area under the curve, it's the 2-hour urine, which is most gives the most effective information. Area under the curve is 0.87. And furosemide stage area under the curve for progression to akin stage 3. Again, the 2-hour urine has a AUC of 0.81. So, if we summarize the results again, the subjects with progressive AKI had significantly lower urine output following FST in each of the first 6 hours. The area under the curve for total urine output over the first 2 hours following FST predict progression to akin 3, and the AUC was 0.87. The ideal cutoff for predicting AKI progression during the first 2 hours following FST was a urine output of 200 ml. And this had a sensitivity of 87%, specificity of 84%. Of course, a very, very important word of caution, using it in a patient who was not appropriately fluid resuscitated would be counterproductive. So first, it is crucial that we must ensure that the patient has received saline and is euvolemic before we try this furosemide stress test. Otherwise, this itself can precipitate AKI. It is vital to replace volume, and the FST can be carried out only in a clinical setting where heart rate, blood pressure, urine output can be monitored closely. So preferably in an ITO setting. Subsequently, more studies have compared furosemide stress test with the available biomarkers we have in predicting severity. And here, the 2-hour furosemide urine output had an area under the curve of 0.87 compared to the other biomarkers like urine NGAL of 0.65, interleukin 18, 0.65, etc. So it performed much better. And this study also showed that if you combine the 2-hour urine output with urine NGAL, then the area under the curve was over 0.9. The other area, this is a recent publication which studied the use of furosemide stress test in a post-transplant setting, and it showed that FST is a more accurate biomarker than urine NGAL in predicting which patients will develop delayed graft function. And it had a sensitivity of 87.5% and specificity of 82.9%, and with 82.5% accuracy. The multiple logistic regression analysis showed an odds ratio of 0.99 for the 4-hour urine volume to predict delayed graft function. So I think all of us nephrologists will find it very useful, particularly to understand that in the post-transplant setting, which patients might develop delayed graft function. So the future strategy, one might look at this sort of algorithm. If a patient is developing renal angina, that means the urine output is dropping off and is in early stage of AKI, then patients in whom AKI is established with the level of biomarkers may then be subjected to a furosemide stress test and an assessment of the renal reserve and integrated renal function, that is the renal blood flow, the organic acid secretion, thick ascending limb function, and tibial-luminal patency can be studied. This can give an idea about the severity, risk of progression, and prognosis of AKI. So maybe this is what we are looking at in future. So to conclude, matched furosemide infusion with hydration may help in preventing AKI in certain situations like contrast-induced AKI. AKI guard may be a valuable adjunct in this regard to ensure that the patient is not volume depleted. However, furosemide does not have much of a role to play in established AKI where ATN has occurred. The furosemide stress test provides a tool for assessing the integrity of the renal tubular function at an early stage of evolving AKI. And the kidney's response or lack of response to furosemide challenge facilitates a clinical evaluation of renal tubular and function and reserve at an early stage of AKI and helps us predict that which patient may progress to Akin stage 3 and may need renal replacement therapy in future. Thank you.
Thank you, sir. Thank you, Chairperson. Our next topic is, we are moving to next topic. Our next topic is current management of COVID LRTI with special emphasis on steroid and remdesivir. And our eminent speaker is Dr. Suresh Ramasubram. He's a director critical care specialist and HOD department of the critical care medicine, Apollo Gleneagles Hospital. And along with the chairperson is Dr. Sumit Sengupta. Dr. Sumit Sengupta is a senior consultant pulmonologist in is a consultant pulmonologist. Sir, you introduce yourself.
That's okay, not a problem. Senior consultant pulmonologist is good enough. Don't worry. Go on, get on with it.
All right. Let me just share.
Hello, can you hear me?
Yeah, we can.
Yeah, that's fine. Get on with it.
All right. Can you guys hear me and see the screen?
Yes, sir. Yes, sir.
Introduction. So, all right. So this is a kind of a topic which is interesting because we see a lot of things happening. So I'm not going to talk about general management of COVID-19 because in 15 minutes I just want to cover a few things. So we're going to cover corticosteroids and remdesivir. So we all know that SARS-CoV-2 virus became a serious pathogen for this species called Homo sapiens in 2019. Though it was therefore giving it the acronym COVID-19. So though it's COVID-21 today. But we've been ravaged by this bug from March 2020. March 27th is when we started our unit and continues unabated in most of the Western countries. But remarkably, we don't know why, we have seemed to have kind of completely stifled it or completely trumped the whole situation. There are certain antiviral and anti-inflammatory drugs. They have been studied extensively, and there have been some really interesting way in doing studies in a rapid evolving system. And the WHO and the MAGIC system has really, given us phenomenal data. Initial data was only Chinese data, and then subsequent all the data is kind of very good because it's real lifetime. They are able to analyze what is happening, what is helping, and what is not. So as I said, I'm only going to talk about corticosteroids and the antiviral drug remdesivir in the core of my topic. So obviously, to look at this, I think we all need to look at the clinical phase of COVID-19. Though the days that I put in the bracket may not be 100% this thing. You can have initial symptoms may last only 2 to 3 days. Sometimes it might last 7, 10, 14 days also, that people have some fever and cough and a little loss of taste before they realize malaise going on for many days. And then subsequently you have the respiratory symptoms, which is because of the airway inflammation and the pneumonia features. And then you have the hyperinflammatory situation, which is this ARDS and septic shock. So the classical timeline is 0 to 7, 7 to 10, 14, and greater than 14 days is what greater than 10 days I have written as the ARDS phase. So when we talk about why, or this is the other way of looking at it, is to say that the viral response phase is the first predominant, which is driving the symptomatology in the first 10 days of illness. And this is basically the constitutional symptoms, followed by shortness of breath with and without hypoxia, and then ARDS. And it's kind of very difficult to say when you get this patchy inflammation, patchy mnemonic consolidation on the CT scan, whether to say it's ARDS or not, because the PF ratio is 200. Do you call it ARDS or do you just call it pneumonia with hypoxia? Again, it's like, trying to separate the wheat from the chaff. So sometimes probably doesn't make any difference. The idea is that the patient is breathless and has got a mnemonic process going on. But yes, it does make a difference because there's a certain guideline. So the way I look at it is as You got a pulmonary phase when you're complaining of breathlessness. So there's obviously you've got some alveolar involvement in the absence of any airway disease or any absence of pre-existing lung disease, heart disease. And then you have the ARDS phase, and in between something what we call as the organizing pneumonia phase. You don't know whether the pneumonia itself in the pulmonary phase is organizing pneumonia. We call it cryptogenic organizing pneumonia if you didn't know a cause, but if you know it, it's a secondary organizing pneumonia. And the mimic of ARDS, one of the commonest mimics of ARDS is cough or cryptogenic organizing pneumonia. So even in both these phases, you have organizing pneumonia as a part of your response. So therefore, it becomes kind of interesting to see whether steroids is going to make it this thing. There are certain terminologies which we are all familiar with. We say severe COVID when your oxygen sats is less than 90% on room air. This is not normally what we understand about severity, but this is what is the accepted definition. And non-severe is when you don't have any signs of severe or critical. And critical COVID means you have ARDS, sepsis, septic shock, or you require vasopressors or mechanical ventilation or any of these things. So in any of these situations, you have what we call as a severe and COVID. So why steroids? So obviously steroids, glucocorticoids, basically they're going to have an immunomodulatory effect, results in increased expression of anti-inflammatory molecules, the GREs, which leads to production of anacrenin, which is going to be an anti-inflammatory. It's going to promote production of nuclear factor kappa B cells, which is going to decrease the production of pro-inflammatory cytokines like IL-6, IL-2, and TNF-alpha, and CRP is also going to go down. So one of the best ways to decrease your IL-6 levels is actually glucocorticoids, and that's what we have been noticing is that the requirement for tocilizumab and those things have come down because we're using much more upfront glucocorticoids. We're not seeing the cytokine storms as much because we are using a lot of steroids. So this is the basis of working with the steroids. Obviously, when you give steroids early in the illness, then you have if you're going to suppress these inflammatory response, you're going to have a viral multiplication, which is going to happen the fear was that, especially in MERS and SARS-CoV-1, the fear was that you will have a significant multiplication of the virus and the time for clearance of the virus might increase. So always it is a problem of giving during the viral multiplication phase, during the viral response phase to give the corticosteroid is not a great idea, just theoretically. And this is what has been shown in various studies, which we'll talk about. So if you look at, this is something which we looked at about 4 months ago, and asked these fundamental questions, and I asked when to start steroid, which steroid, and dose and duration. I'm going to probably discuss the same thing again. So now let's look at the fact that you have a pneumonia. So if you have a pneumonia and you don't know it's COVID or what virus, influenza B, or whatever it is, or 35% of pneumonias are typical pneumonia, atypical pneumonia, whatever it is. So if you look at the ATS guidelines on pneumonia, they strongly recommend not routinely using corticosteroids in adults with severe CAP. And not routinely using, and severe CAP means requiring ventilation, requiring septic shock. So we suggest not routinely using corticosteroids in adults with the influenza CAP, not using cuddles with any of these things. And they only say that if you have severe septic shock, you can use the surviving sepsis guidelines to use corticosteroids in patients with CAP and refractory shock. Otherwise, they are going to be talking about as I said, no role for steroids in community-acquired pneumonia is what we are saying. But when we talk about COVID, then we say, no, there might be a role, isn't it? So the WHO says that we recommend systemic corticosteroids for the treatment of patients with severe and critical COVID. And where is this evidence coming out from is what we'll talk about in a little bit. So the various doses that has been studied in this is the methylprednisolone. This is from the Glucovid trial, 40 milligram every 12 hours for 3 days, and then 20 milligram every 12 hours for 3 days. Then from the 2 DEXA trials, DEXA-COVID and Codex, this is DEXA-COVID followed the ARDS DEXA study published in JAMA in 2018, which is 20 milligram daily for 5 days, followed by 10 milligram for 5 days. Then you have the CAPE COVID trial looking at hydrocortisone. Then you have the REMAP CAP looking at hydrocortisone. And then, of course, the largest study is a recovery study, which looked at dexamethasone 6 milligram given once daily, oral or intravenous for up to 10 days. So these are the various studies, and predominantly, if you look at the meta-analysis which is published in CHEST this month, I'll again look at the various data and I'll tell you the average dose is about 40 milligrams of methylprednisolone in the system. Now, if you look and say, okay, COVID is, when somebody is hypoxic with COVID, PF ratios are low, they are behaving like ARDS, we should look at ARDS. So then if you look at ARDS and look at the recommendation from the ATS, what is the recommendation? They say use corticosteroids in early patients with moderate to severe acute respiratory disease. Early means the first week of illness, and they say within 14 days here, but predominantly it is better to say within first 7 days. And then you can use a dose of 1 milligram per kilogram in this situation as it's within 7 days of onset. And late, that is after the second week, a dose of 2 milligram per kilogram followed by slow tapering. And they have suggested methylprednisolone is suggested because of its greater penetration into lung tissue and longer residence time, while the Spanish group used the dexamethasone because of the lowest mineralocorticoid effect. So this is from the guidelines, from the critical care medicine guidelines, it's like methylprednisolone is probably better in ARDS, in a diffuse, whatever be the etiology of ARDS, in the first week of illness and in the second week of illness. Obviously, this has to be tempered down by the fact that we might have obvious sepsis with gram-negative bacteria going in the blood or gram-positive bacteria. This is not the situation. This is we're talking about where there's an obvious sepsis is controlled and the sources of sepsis are better under control. In this situation, we can think about it where ARDS and it becomes the predominant pathology. So this is in terms of, the other third thing, as I said, is organizing pneumonia. So this is the kind of CTs we are seeing: peripheral, pleural-based, bilateral, symmetrical, asymmetrical consolidation, which is organizing pneumonia. The difference between organizing pneumonia and ARDS is basically the lack of hyaline membrane, and that the fibrin tissue that is laid down is predominantly in the alveoli and in the tissue in the terminal bronchioles and beyond. So as a result of which, organizing pneumonia, the difference is the same. ARDS, it's predominantly laid in the interstitium and the alveoli, while this is laid predominantly in the alveoli and the conducting airways are leading up to the alveoli. So there is really not much of a difference. But what we do see in autopsy studies in acute fulminant organizing pneumonia, which can present as a mimic of ARDS, and you cannot clinically and pathologically distinguish between them. As I said, the only dominant finding is the presence of fibrin balls without classic hyaline membranes. If you see hyaline membranes, then you say this is diffuse alveolar damage, and this is because of ARDS. So in this group, when you have organizing pneumonia, which is an orphan disease, the recommendation is to receive 0.75 milligram per kilogram of prednisone during first 4 weeks, and it's a long, almost a 3-month course. And in severe cases, initial treatment consists of IV bolus of 2 milligram per kilogram of prednisolone. And in fulminant cases, even pulse steroid have been used in case series, which have been published by Talmaj King et al. From Seattle and things like that. So there is this organizing pneumonia. So between these three concepts of ARDS, just treating plain pneumonia, just treating secondary organizing pneumonia, so we really get confused as to what we need to do. So I broke it down into this way. So if you are presenting within the first week of symptoms with mild, moderate, or severe hypoxia, and you have at least, so then you should just follow the recovery data, that is use dexamethasone 8 milligram or that is Solumetrol 32 milligram ideally, because it's a prednisone equivalent of less than 30 milligrams is what we talk about in the medium dose steroids when you talk about Dexa 8. Or as I said, and if you think that this is ARDS because the PF ratio is low or he's already on a ventilator, but this is the first week of illness, then we use the ARDS first week of dose, which is 1 milligram per kilogram. It will work out to about 60 milligrams in majority of the people. We generally not tend to use this 20 milligram per day into 5 days, just because of the lack of habit. But this is what should be there. And then you see whether you're going to respond or partial response. How do you assess response? Is probably a SOFA score using the pulmonary organ as the SOFA score. And then you have to give at least 3 to 5 days before we change the steroid dose and say, oh, this is not responding. All right, so what happens if you don't respond? So first week of shortness of breath on steroids, you're worsening or your status quo, and we are panicking. So then we are looking at inflammatory markers, we're looking at VT, we're looking at secondary pneumonia as gram-negative, Acinetobacter pulmonary edema. If you don't identify anything, PFO openings, so you do all these blood tests, you await results. If you have good response, well and good, patient is getting better, they start tapering the steroids after first week, and then by day 10, you're ready to go home. So it is in this situation that we get into trouble as far as this thing. So if you're poor response, if you have then we say, okay, are you getting into ARDS and or you're getting into a fulminant organizing pneumonia? Again, these are pathological terms. It doesn't make any difference. Clinically, radiologically, yes, you might have an idea. It is not the classical bibasilar dependency, but a peripheral pneumonias, then you might say this is an organizing pneumonia. And if there's no cytokine storm, you might now think about giving a higher dose of steroids. So you increase the steroids, how much you increase, nobody knows. This is where we get into trouble, is we don't know whether we should give pulse dose of steroids now or a 2 to 5 milligram per kilogram. The empiric usual thing is to give 2 to 5 milligram per kilogram. Again, the duration is not very clear what to do. So this is what happens when we don't know, when people don't get better, we don't know what to do. Similarly, if somebody presents in the second week of hypoxia, say illness with shortness of breath, previously untreated, and he's got severe mild, moderate, or severe ARDS, and so then we give 2 milligram per kilogram of steroids as the Meduri protocol states, and taper it over 13 days. Similarly, if he presents in the second week of shortness of breath, previously treated with the first week of illness, as we mentioned, whether it's for rescue steroids, organizing pneumonia, ARDS, again, this is whether it's completely fibrotic and mixed. We don't know what exactly is happening. So this requires us to assess the CT scan very well before we say. The third week, somebody presents, and then it's again the CT chest. If it's per fibrotic, then it's more perfidin. And if you still have organizing pneumonia, and now as the ATS calls it, that the persistent acute inflammatory interstitial lung disease, that means your CRPs and high D-dimers are high, then you might think about not only increasing the steroids, you might think of cyclosporine and cyclophosphamide, and continuing with the steroids at a 0.5 milligram per kilogram. Dose of prednisolone. So this is what is the spectrum of illness, and the steroids, as I said, goes on in various doses. So the last thing is, the second thing that I wanted to touch base was remdesivir, which is an inhibitor of the viral RNA-dependent RNA polymerase with in vitro activity against both SARS-CoV-1 and the MERS-CoV virus. So it's an efficient anti-coronavirus, irrespective of whether it's CoV-1 or CoV-2 or the Middle Eastern respiratory syndrome. Again, two major evidence for remdesivir, because it was initially accepted with the registered data from the company. So WHO-led open randomized solidarity trial reported that 301 of 2043 patients received remdesivir, and 303 analyzed received standard of care, died by day 28. So there was hardly any mortality difference if you gave remdesivir in seriously ill patients, including mechanical ventilation, so on and so forth. So based on the solidarity trial, there was a kind of a drop in interest in remdesivir. But the Act 1 trial published in NEJM in November 2020, sponsored by the NIH, basically had a similar result, saying there's no difference in mortality, though 11.4% versus 15.2%, but it's not statistically significant. But what they showed was there's a median recovery time of 10 days as compared to 15 days. And this was as compared to those who received placebo, and this was statistically significant numbers. So as a result of which, the Act 1 concluded they were superior to placebo in shortening the time to recovery who were hospitalized with COVID-19 and had evidence of lower respiratory tract infection. That means you had a CT or a chest X-ray which showed pneumonia, and you had symptoms of cough and breathlessness, and saturation was less than 90%. Why the disappointing results of remdesivir was that, as I said, again, the viral phase is over by the time most of these patients come in seriously with ARDS. So there's probably no point in the initial phase of intense viral replication has already progressed to respiratory failure. So the main problem right now is the host inflammatory response. So treating them with antiviral may not be very useful. Again, even though we know that the second week of illness, patients are very ill, their coronavirus is still, RT-PCR is still positive, but their concentration is substantially lower in this phase, and they're not that infectious. And that's why we transfer them out to a non-infectious facility by about 3 weeks of illness, because we know the virus is gone by 10th day itself. We know for sure that the virus is gone from the system, or if it is there, it is in a very low level. So these are the two reasons why remdesivir is not work. So what we know for remdesivir in 2021 now is that for patients with mild or moderately severe COVID and no need for respiratory support, that is not requiring oxygen, there is no significant benefit at day 28, and therefore use is not recommended. It's only at high risk of hyperinflammation. That means your inflammatory markers are high and you're going to be hospitalized because of persistent fever, persistent inflammatory marker, or you're requiring supplemental oxygen, and you are in the first 10 days of illness and you want to shorten the time to recovery and reduce the risk of progression, which is what the fear is, that I shouldn't go into a remdesivir. So that is why we tend to continue to use this, because this is the fact that patients have come into our healthcare system and we have to do something which is definitely shows that it might be reducing the risk of progression. So we can't just sit with him and say, okay, just give you 6 milligram of Dexa and sit still. So I think this is one of the reasons that it's a decision to continue to support it. That's why we are continuing to do that. So the plus clinically important endpoint, which is very important in our country, is also is cost effectiveness, and to move them out of the unit, out of the ward, and send them home if their fever, if their breathlessness gets better faster. So I think it still has a role, especially if you're within the first 10 days. So that is what is the role of remdesivir in 2021. To summary, I'm going to say that COVID-19 is going to be here to stay. We will continue to get CAP and ARDS on and off over the next 6 months. We might not have to keep a unit open, but we will still have to have isolation facilities, and we will have these things. So the early pulmonary phase within 10 days with clinical severity and signs of hyperinflammation will benefit from remdesivir, even with the lack of mortality benefit in the two major studies and the so the benefit of just quicker recovery. And again, these maybe still we have to be sorted out as more and more studies are going to come out on these things also. The early pulmonary phase with clinical severity will also benefit from low dose steroid, and use of steroids at doses of less than 30 milligram prednisolone equivalent, which is what is called as a medium dose steroids, is what is recommended. So low dose means less than 7.5 milligram steroids. So I think it's the right term is to say medium dose steroids, because low dose means less than 7.5 milligram of prednisolone equivalent. So it is a medium dose up to 7.5 to 30 milligram, which is going to be beneficial in early COVID-19, in the first week of illness of breath, first week of not illness, first week of breathlessness. That is when it's causing hypoxia is the issue. And early steroids in ARDS also is beneficial. So if you're in full-blown ARDS in the first week of illness with breath, after the starting of the breathlessness, again using a 1 milligram per kilogram of methylprednisolone or Dexa 20 milligram may be useful in this situation. But the duration of treatment remains only 7 to 10 days unless if they fail to improve. We really need to assess in the algorithm that I mentioned. But those algorithms are kind of almost not. They are kind of things which we have been doing, but it's not written anywhere in a book. But most of us have been doing like that, looking at CT scans and deciding whether it's fibrotic, still GGOs are there, and so on and so forth, and deciding inflammatory markers, how they are, and then deciding. Of course, late ARDS organizing pneumonia, the doses and treatment remain controversial. Thank you very, very much for your kind attention. And
thank
that's
you,
all
sir.
I had.
Dr. Sumit, you want to say something?
No, I think Suresh has covered everything very nicely, and couple of places where I use it extra. If on day 7 from symptom onset, the patient is still febrile, I think that's a good marker for almost 25% of patients go on to develop hypoxia, and we use remdesivir even in the absence of hypoxia in those patients. Just let's say an extrapolation of all the data. So day 7. So day 7, and the other thing is that more than 20 days of steroids, I think, is actually counter beneficial, and we are seeing people getting stuck on steroids without really fine tuning, and you have to individualize. And the dexamethasone 6 for 10 days, or the Dexa-ARDS, as Suresh mentioned, 20 for 5 days and 10 for 5 days. A combination of this ultimately maximum 20 days would be my let's say suggestion, rather than going on for weeks and weeks of steroids, which I don't really think is very beneficial. But otherwise, I think I agree with Suresh on everything he said.
Thank you, sir. Thank you. Thank you, sir. We will move on to next session. Our next session is radiological approach to COVID lung infection. And we have an eminent speaker, Dr. Somali Ghosh. She is a senior consultant radiologist in Apollo Clinicals Hospital. And the chairperson is Dr. Usha Gwenka ma'am. Ma'am is a director of Department of Radiology in Apollo Clinicals Hospital. Somali ma'am, can you start your presentation?
Good evening, everybody. So I'm going to talk on imaging on COVID today. So let me start with the basics. Why do we need imaging at all in COVID when we know that the principal diagnostic test for COVID-19 is RT-PCR? That is because RT-PCR has a sensitivity which is quite low, which is 60 to 70%. And not just that, RT-PCR takes hours or even days before the results are available, and that puts a strain on the holding units. Now, what does that mean? It means that in the emergency, all these patients with fever, dry cough, shortness of breath, they come, and the attending doctor now has to wait hours for the RT-PCR results to come before they can send the patient to the isolation of the COVID ward or to the normal ward. And this is where the role of imaging comes in, because now the attending doctor can take a quick decision based on the imaging results and send the patient to the COVID ward or to the normal ward. But the big question is it going to be X-ray or CT? Now, an X-ray like this For example, you've got all these opacities in the periphery, and in the pandemic scenario, you feel that this could be COVID, and CT done actually confirms that. So this is quite obviously a COVID patient that we are dealing with. But what about an X-ray like this? Some will say that yes, there is opacities, and some radiologists will say no, there isn't, until a CT scan done shows that yes, there is. So there is a lot of inter-observer variability when it comes to X-rays. And an X-ray like this, for example, will be reported as normal definitely, but a CT scan done will pick up some subtle ground glass opacities. So X-ray obviously has much poorer sensitivity than CT scan. So CT scan has a sensitivity of 84 to 94%, whereas X-ray has a much lower sensitivity of 67%. But in spite of that, American College of Radiology recommends using it for management of hospitalized patients and also as the first line of imaging. Now, why is that? That is because there are certain disadvantages when it comes to CT scan. The decontamination of the CT room is a problem. Patient transfer to CT suites can be a potential hazard for cross-infection, and most centers and institutions do not have a dedicated CT machine. And that is why the portable X-ray becomes more advantageous because the risk of cross-infection is minimized. We in our hospital, however, we have a dedicated CT machine, and so most of our patients undergo a CT scan, and most of the literature available is on CT scan. So I'm going to speak primarily on the role of CT in COVID. So it is not only used as a diagnostic tool, it is also used for prognostication, for evaluating disease progression, for monitoring response to therapy. Let us come straight to the CT features of COVID-19 pneumonia. So the hallmark is, of course, the ground glass opacities, which is usually in the peripheral in location, or they're rounded opacities like this. They usually involve both the lungs, and there is a predilection for both lower lobes. Or we get ground glass opacities with interlobular septal thickening like this, which is called the crazy paving appearance. Or we get consolidation in a peripheral distribution. But the feature which actually distinguishes COVID from other viral pneumonias is vessel dilation. And that is because the pathophysiology of COVID is pulmonary vasculopathy and microthrombus formation. So you can see there is lesional and perilesional vessel dilation. If you compare it with a normal lung, there is no such dilated vessels. And as the disease progresses, the vessels becomes more tortuous and they proliferate. There are some signs there are some names given to this feature, and one of them is called the dandelion sign, where you have this flower-like appearance and the stem, which is the dilated vessel. Then you have the feather sign. Here is the central vessel, the dilated vessel which is running through that ground glass opacities, appearing like a feather, and the branches which are also dilated. Now, organizing pneumonia. This is something which we need to know, because the clinicians often ask us whether the pneumonia is organizing. So we get architectural distortion over here, or we get the reverse halo sign, which is central ground glass opacity surrounded by the more denser area. This is the reverse halo, and we also get the perilobular ground glass opacities or a perilobular consolidation. Pleural effusion is one sign which is actually conspicuous by its absence. We do not get pleural effusion very often, but in the severe cases, we do see pleural effusion. Temporal changes of COVID-19 pneumonia. What do we mean by that? It means CT changes over time. So we have an early stage, a progressive stage, a peak stage, and an absorption stage. So early stage is 0 to 4 days when we have these subtle ground glass opacities and they involve less number of lobes. The progressive stage is 5 to 8 days. When we see a progression of the disease, there is more extensive GGO now, and also the crazy paving appearance. Then we have the peak stage, that is the stage of consolidation, that is 10 to 13 days. We see consolidation, pure consolidation like this, or consolidation mixed with ground glass opacities, which is more often seen. And then comes the absorption stage, when there is gradual resolution of the pneumonia. But having said that, in our experience, we have seen that the time frame that is mentioned over here is not strictly maintained. As seen in this case, for example, the patient has come with subtle ground glass opacities. After 2 days, it becomes progressive, but on the 6th day itself, there is architectural distortion, and so the pneumonia has started organizing in 6 days' time. Coming to the complications of COVID-19, we have secondary bacterial infection. We often have secondary fungal infection as well. Then you have the dreaded acute respiratory distress syndrome when the cytokine storm sets in, that is on 8 to 12 days. We have this ground glass opacities anteriorly and the more denser opacities or consolidation posteriorly. So this is called the posterior gradient. This picture is not any different from any other type of ARDS. And this is the whiteout lung, which is often we hear this term with COVID. This is nothing but the severe form of ARDS. And we see that the entire lung is almost involved. An increase in D-dimer warns the clinician that there may be a thrombus. Remember that these patients are already on antithrombotics because we expect thrombus formation in this disease. And so we don't get a very big thrombus, we get a small thrombus like this. But having said that, we sometimes get a thrombus as large as that. But how do we report COVID CT? We report it by the CORAD system. The Dutch Radiological Society came up with this CORAD system where we give the level of suspicion. So CORADS 1 is when we don't suspect COVID at all, and CORADS 5 is when there is very high suspicion of COVID. Similarly, the RSNA expert consensus also came up with the typical appearance, the indeterminate appearance, the atypical appearance, and the negative for pneumonia appearance based on the CT features. So here is a case which is absolutely normal looking. And here is another one where we see a non-infectious disease. This is ILD over here. We'll call it CORADS 1 or negative for pneumonia. This is centrilobular nodules. This is consolidation, but not in a peripheral distribution. And here is a cavity formation. So all these cases indicate that there is some kind of infection going on, but it is not like COVID. And so we call it CORADS 2 or atypical appearance for COVID. Then again, we might have a small focal ground glass opacity like this, or ground glass opacities which involve just one lung, or ground glass opacities which is not peripheral in a distribution in a perihilar location. We call it CORADS 3 or indeterminate appearance for COVID because we are not sure that we are dealing with COVID here. Or we have an appearance like this where we are almost sure that we are having COVID because this is the crazy paving appearance. But then again, it is not exactly like the typical appearance of COVID. So we call it CORADS 4. Again, we have ground glass opacities in the periphery, or we have ground glass opacities which is rounded like this, or an organizing kind of pneumonia appearance. Now we are sure that we are having the typical appearance of COVID, so we give it CORADS 5 or typical appearance of COVID. Now, once we call this typical appearance of COVID, the clinician wants to know how much of the lung is involved. And so we have the CT involvement score. So each lobe is given a score of 5 points each, so a total of 25 points. So the scoring system is done like this. A score 1 is for less than 5% involvement. Score 2 is 5 to 25, 3, 26 to 49, 4 is 50 to 75% involvement, and score 5 is more than 75% involvement. So let me give you an example of this. We see a case in all the three planes. This is axial, the coronal, and the sagittal, and we do an eye estimation. So in the right upper lobe, I would say that only 5 to 25% of involvement is there. So I give it a score of 2. Middle lobe, I feel that there is no involvement at all. So I give it a score of 0. Right lower lobe obviously is much more involved than the others. I'll give it a score of 3, as I feel it is 26 to 49% involvement. So similarly, left upper lobe, a score of 2, and left lower lobe, a score of 2 again. I add them all together and I give it a score of 9 points out of 25. Now, how important is the scoring system? It really has no bearing on the treatment of the patient, but it does have a value where the prognostication of the patient goes. As our study done in our department shows, we found out that when a severe score of 18 to 25 has more mortality, morbidity, and hospital stay. What is in size, what exactly happened, and the COVID actually, the ground glass opacities disappear. What exactly happened? The bronchoalveolar lavage done showed a hitherto unknown tuberculosis, but why the sudden enlargement of the cavity? It was because this patient was given steroids, just like many other patients of COVID. Another patient had come from a nursing home outside, and the patient showed cystic areas and cavitation like this, and we thought that we were dealing with a secondary bacterial infection, but bronchoalveolar lavage showed no growth at all. So this was one of the rare cystic changes in COVID. The patient ultimately died of a bronchopleural fistula. Here is a 66-year-old male, came with ARDS. The reason why, and became worse, the reason why I'm showing you this is this pneumomediastinum. Obviously, this patient was on positive pressure ventilation, which caused the weak alveolar wall to rupture and the air to seep into the mediastinum. A 59-year-old female patient with ARDS, we can see that the patient was ventilated, and then she came out of the ventilator. She got better, and we can see the organizing, the pneumonia is organizing over here, and she improves even further, and there is actually no evidence of any fibrosis at all. So she was completely recovered. A male patient, 59-year-old, came in, went into ARDS. developed a small thrombus over here, and finally recovered without any fibrosis. But this patient over here was had severe ARDS, but she was discharged from the hospital. She came in after 3 months, and we can see some residual fibrosis over here, some reticulation and traction bronchiectasis. Another patient who came in with not so severe COVID, but went into ARDS, developed this pneumomediastinum as he was on ventilator, and but he recovered actually and went home with oxygen support. This patient was again had ARDS and came in August with all this residual fibrosis, was on antifibrotic drugs. In October, we can see that this fibrosis has become slightly better, and in January, even better. And whether this fibrosis is going to be completely reversible, only time will tell. We still don't have enough literature on this. This 70-year-old male actually came in with all this peripheral reticulation, and we thought that we are dealing with some kind of ILD. He gave no history of COVID. There was no history of fever or dry cough or anything like that to suggest that he had COVID infection. But IgG antibody test done showed a titer of 10, and so this was the sequelae of asymptomatic COVID. This was all fibrosis from asymptomatic COVID. And finally, this patient who had come in March actually was on ventilator at that time, went home, came back again in September, and this time was again on ventilator. He was flown to Hyderabad for a lung transplant, was switched on to ECMO. He waited for the transplant, but he succumbed before he could be transplanted. My sincere thanks to Dr. Ashok Sengupta and Dr. Lonnie Goswami. Thank you very much.
Thank you, ma'am. Ma'am Goenka, Usha ma'am, please enlighten something.
Yeah, Somali, that was a very comprehensive talk, and thank you for that. And a couple of remarks, maybe. You did mention that X-rays have a very low sensitivity, like it's only 30 to 50%. So that is not the test to diagnose, but of course, as you said, according to the American Society, we do use it for screening, and most importantly for the follow-up of patients. Because it's very difficult to do a CT scan as a follow-up tool multiple times because of radiation issue also, and it's very inconvenient for us to get down sick patients to the CT scanner room, though we have a CT scan which we've kept just for the COVID patients. So CT is used in the follow-up of the patient only when you suspect some clinical or radiological complication, which Somali has already mentioned, like a thromboembolic phenomena or a ARDS, then you use the CT scan. And Somali, you have already mentioned that the vascular dilation kind of helps us to segregate COVID pneumonia patients from other patients. Are there any other radiological criteria which can help? Like in a pandemic, there could be other infections as well, right? So vasogenic prominence could be one. Are there other differentiating characters?
Yes, a lot of studies actually has been done on this, and they've tried to differentiate COVID from other viral pneumonias like influenza, like H1N1, and everywhere the results are more or less the same. It is actually the ground glass opacities in peripheral distribution and the vasodilation, which were the most discriminating features. And it seems pleural effusion is, like I said, is conspicuous by its absence in COVID. It is more common in other viral pneumonias, as is centrilobular nodules and consolidation, but not in a peripheral distribution. So yes, ground glass opacities and vasodilation are the two most discriminating features.
And one more thing, like the world has been facing this pandemic for a year now, and we have seen millions of patients across the world. So is there anything which we have learned over this 1 year, which we did not do previously and we can do now? Like, have we altered our algorithm because we have become experienced now? We are 1 year into our diagnosis of COVID.
Regarding algorithm, is that what you're asking?
Yeah. So has the algorithm changed over the year? Have we become wiser while we are diagnosing things? Can we make early diagnosis?
No, not. It hasn't changed significantly, except that we are probably now with the literature, with all the literature that we have gone through, we are being able to pick up the vasodilation more easily. Maybe we are being able to pick up ground glass, subtle ground glass opacities as well more easily, and that is the only way that we have learned over the year, I guess.
Thank you,
Okay,
ma'am.
so
We have to move another session. We are.
Sure. Thank you.
Thank you. Thank you very much.
Yes.
Our next topic is a panel discussion that ideal maintenance fluid and where we place 5% albumin in resuscitation or in maintenance or prevention of AKI. So for this session, moderator is Dr. Pragyan Raut. He is a senior consultant and in critical care department of Care Hospital, Bhubaneswar. And along with our eminent panelists, Dr. Rakesh Periwal is a senior consultant and in charge at Guwahati Apollo, and Sujay Shamanto is a senior consultant and in charge of Ruby General Hospital, Kolkata. And Dr. Prosenjit Sarkar is a senior consultant and in charge of ILS Hospital, Kolkata. And Dr. S. Srinathan. Srinathan sir also is a senior consultant and HOD, Department of Critical Care. And can you start the session, please?
Yeah. Thank you. I'm visible and audible, hopefully, Asif sir.
Yes.
Great. Fantastic. Very good evening to all of you. First of all, Dr. Asif sir, thank you so much. And it's a wonderful choice of topic, wonderful evening, and we'll try to stick to the timing. With me, a very eminent.
Timing is very important because we are.
Boss, you'll give me a chocolate after this session. I'll stop dot in time. I put up a timer also. Don't worry.
All panelists to concise your answer is very to the point.
Yeah. Very nice. Very good evening to all of you. So, my dear friends, so this is as we understand, fluid is very curious in its presence in our body, with extracellular water constituting 20% and hardly plasma constitute 4.3%, while rest all of them in the intercellular in form of other forms. And a lot has been told about fluid boluses, the golden hour, and how we take decisions regarding that. Say it lactate, say it dynamic parameters, say it static parameters. A lot of guidelines revolves around how do we give fluid boluses. And there have been a lot of studies regarding fluid boluses when we discuss about let us say SAFE trial, where we find that albumin and saline both are equipotent with little bit of more mortality in trauma wing. And if you come to Albias trial, when there is not much difference between when you compare albumin and normal crystalloids, and we find that there is a little bit more development of renal failure in this arm. And nonetheless, saying that chest and CXS both prove that starch are equipotent to crystalloids in terms of mortality, but there are more chance of somebody developing renal failure when you give starch, more chance of somebody requiring renal replacement therapy. Taking this into mind, when we talk about maintenance fluid.
Hello, sir. Sorry
Yeah.
to disturb you. We can't see your presentation.
You can see my presentation? Okay.
No.
Okay.
Please
Is it
share it
okay?
again.
I'll share it again. Okay. Resume share. Is it okay?
No,
No.
we can see your face. I like
Yeah.
that more.
So is
Just
it
stop
okay?
your sharing and share it again, sir. Just
Okay, I'll stop and share. Okay, I'll share it again. Is it okay now?
No, no.
No, still it is not visible.
No, you can see the black screen, but we can't see your presentation.
Is it okay?
No, it is showing a started screen sharing, but
But
the
your
presentation is
Pragyan,
not there. Yeah.
I think you can continue to talk.
Yes,
we can
yes,
follow you.
yes,
That is
yes.
better.
No problem.
That's better. No problem.
Okay, is it now?
Yes, yes.
It is
No,
not.
no, no, no.
It is visible.
Go to the slideshow mode.
Yeah, it's okay?
Yes.
Yeah, great, thankfully. I had a palpitation in between. Great. So, as we're talking about the 4 trials, I was discussing few seconds back. So, coming to maintenance fluid, there are very less guidelines, which me and my panelists will go through as per our personal experience, how we can help each other find out what is the ideal maintenance fluid. So, this is the 4 golden steps of fluid management in terms of rescue, optimization, stabilization, and de-escalation. When we talk of maintenance fluid, we talk of these phases: optimization, stabilization, and de-escalation. Probably all 5 of us are going to discuss in this phase what fluid and how we are going to give. So let's start. A 59-year-old patient admitted with septic shock, and he was given fluid as per surviving sepsis guideline. We gave boluses. We tried to pick up our bundles, and after 12 hours, now patient is in a very minimal dose of noradrenaline with urine output of 50 ml per hour. And last 12 hours, we've achieved input out of 2.5 liter over 1.5 liter. So what do we do now? So I will go now to my friend, Dr. Rakesh, very well. Whether this patients need fluid, like patient is a NORAD 5, now output is maintaining good, patient is coming out of the shock, whether this patient needs any fluid or not. Rakesh, over to you.
If he is hemodynamically stable, the urine output is okay, the lactates are normal, maybe we can wait. Anyway, they do get fluids with their medications, and probably we are more bothered about restricting fluids rather than giving them.
Okay, so
that is what I think clinically generally what happens.
Okay, looks good. So patient when came to you, he was a NORAD of 10. Now NORAD requirement is 5, and you notice 50. So you think that the patient doesn't require any fluid. Let us say
Unless there are compelling reasons to give, like you're doing a nasogastric aspirate, or there is diarrhea, or there is a third space accumulation, maybe like pancreatitis, or there is overt loss somewhere, then yes, otherwise no.
Let us keep it like that. The patient output is not that good, maybe on 20-30 ml. So whether you need fluid, whether you need to give any fluid, we are seeing the patient fluid output is dropping last 3 hours.
I don't know about that, but with the leakiness in sepsis, maybe you're saying it's a septic patient. This is the IC. We'd consider it something like a complex patient.
Yeah, correct.
Where
critical can rarely get a very simple patient. So think about one of the complex ones.
Yeah, I think we can hold on for some hours and see.
Okay,
and then
fine.
maybe look at balancing out, maybe over the next 24 hours.
Fine. Okay, I am a resident. I'm pressing on that. I want to give fluid. Sir, please fluid they don't have. So what fluid will you prefer what to give? So somebody is requiring some sort of fluid. Patient is not taking orally at all. Last 3 hours you have not given anything. So you see some urine output dropping. Patient is not fit to given anything orally. So if patient, your resident is very keen on giving some sort of fluid, what fluid will you give here? Patient is not fit to take orally, and patient's urine output has started dropping little over last 3 hours. So we need to give something for the sake of hydration. What fluid will you give?
Well, we can consider a balanced solution. Ringer's lactate would do.
Okay, great. Balanced solution you would like to give. And what rate would you like to give? Somebody NORAD of 5, urine output is 20-25 ml per hour. It was 50 ml
maybe
per hour.
Maybe replace urine output every hour. That would be good. Maybe give 5 to 10 ml more hourly.
So if you chart out after 12 hours, so hour 1, 2, 3, it was 50, 50, 50. Hour 4, 5, 6, it has dropped to 25, 25, 25. So how much fluid would you like to give? 25 or a little bit more than that?
Maybe a little bit more, 30, 40, maybe 40. 50. Or so,
So as per you, if urine output is 25 ml per hour, you would like to give 40, 45 ml per hour. and see what's the output next hour. Correct?
Yeah.
Correct. So there is no definite answer to it. So some will like to give 67 1 ml per kg. Some would like to give 25 ml. So whatever it is. So we won't differ on that concept. So you would like to give 25 ml per hour. Okay, fine. Any guiding principle you decide regarding this fluid maintenance? So you came out around urine output. Is it a very feasible guide that I can give my next hour fluid seeing the last hour urine output? Is there any guideline, or it is your experience?
But I think that is the best way to work, because we keep changing our decisions every now and then, and prescriptions keep changing in the first few hours. You have infusions, drugs going on. So in this dynamic scene, you take calls accordingly. I think, and that also depends on what are the comorbidities associated, cardiac issues, renal issues, and liver issues mainly, which can cause upsets in the fluid balance, or in the leakiness, the albumin levels, or the fall of them, malnourished state. I mean, there are too many co-founders to have kind of a one kind guideline. I don't know what my other consultants would like to say, my other panelists.
Yeah, I'll come to them definitely. Okay, just before finishing, last question, I would like to ask you whether this fluid guideline, is there any role of choosing the parameters you choose during fluid boluses, like lactate or a CVP or a IVC, whether these things matter a little bit while deciding your maintenance fluid?
No, other than probably the urine output, the balance.
Balance. Okay, fine. Great. Fantastic. Now I would like to go to Dr. Sujoy. Sujoy, over to you. So, what is your Dr. Rakesh told it's a balanced fluid solution he is more keen to give. What is your preferred maintenance fluid? So, choices are like 5% albumin, the topic of discussion today, or a normal saline, or a RN, or a balanced like a plasmaline, balanced solution plasmaline. Which is your preferred maintenance fluid?
I think, are you able to hear me?
Yeah. Sujoy sir, please.
I think this answer is not a only straightforward answer. It's not there. That's everybody know that crystalloid is preferable, and among the crystalloid, the balanced solution or the buffered solution is preferable. But we have to see the other aspect as well, like the clinical setting, the organ dysfunction. All these things also matter. Clinical setting, I mean to say, if it is a traumatic brain injury, in that case, even we do not prefer the balanced solutions. In that case, we maybe prefer isotonic solution, that is normal saline. So this is the scenarios changes. Like if it is the patient with shock with the hyperchloremic metabolic alkalosis, in that case we can use the normal saline. So it differs, but in general, if you say in septic shock without the specific clinical setting, we prefer use to the evidence says that balanced crystalloid is preferable, and we can use the plasmolite and stereophandine. There are a lot of IV fluids are there. And in respect to the colloids, if you talk about the colloids, like you can use it little bit. There is no difference between this out of the natural colloids, like albumin can be used, but in septic shock, even in albumin study also, and the SAFE study, they have shown that the safe use of albumin can be used. But if we use the cost and the resource, both, in that case, we can use only if it is the requirement albumin is on the lower side. In that case, probably the patient is persistent shock is there. In that case, in the lower albumin range, usually clinically it's the bedside decision. Most of the cases we use the albumin in that case.
Great. So what I understand from your topic that you will give maintenance fluid as per the clinical situation. That is very well taken.
Definitely, it is not any general blank statement.
That's a very nice one. And your decision of giving 5% albumin colloid will be little bit hindered by the albumin level of the patient, or ongoing shock, or a persistent shock.
Two things. One is the shock state or albumin level.
Excellent. So coming to our next question, is there a difference in character of bolus fluid and maintenance fluid? Like bolus fluid should be like this, maintenance fluid like this, or both can be equal? Like same fluid you have been using for bolus can be used for maintenance, or there has to be certain definite gap? It's a very out of the way question. If you can answer,
no, it is a very good question.
Yeah.
As I answer the bolus fluid and maintenance fluid. In a case of bolus fluid, you have to use isotonic. This isotonic nature should be there, and it should be at least normal chloremic or low chloride level. Like we level around 100 to 110 milliequivalent per liter. If you use bolus fluid, large amount of chloride rich fluid will cause some problem like anion gap acidosis, normal anion gap acidosis. So in that case, what I say that it should be isotonic at least, and if it is little bit of the low chloride, that will be preferable for the bolus fluid. As regarding the maintenance, again I will say that the maintenance fluid should be more physiological. It should not hamper the acid base balance, and also should not the chloride level here also should should not be high. I mean to say it
Very
should
nice.
be less than.
Very nice. So I think you answered my third question also. The main purpose of giving maintenance fluid is to avoid acidosis, avoid dehydration, and patient needs something. So I think you just answered the third one. Very nicely answered, Sujoy sir. The main part which Rakesh was also very keen on answering on that part, when to give. So somebody out of septic shock, just now recovered, NORAD is stable for last 2 to 3 hours. You do not put just holding around 40-50 ml hour, whether this patient needs maintenance fluid or not. That is the question.
Can I answer? Can I answer?
Yeah, sure.
See, you have to just not jump on the fluid. So we give fluid for hypovolemia. If the patient is having relatively hypovolemia is there, so your balance, the ultimate balance is the improvement in the macro circulation. That is the blood pressure and the target, and we expect any change in the microcirculation like lactate and the other parameter, base excess and all these things. But here you have to see one important thing is there, that giving fluid, if additionally you have to balance the whether the fluid side effect is there, like any overload, like any tissue edema is occurring or not. So here fluid is improving the cardiac output any way. So here fluid responsiveness you can check, and also the final marker like the lactate is raised or not, that is already normalized or not. So in that balance, like with the fluid challenge, little bit of fluid challenge, if you see the macro and microcirculation changes there or not, in that case you give little bit of fluid. But in case of if it is already the patient, you are saying the patient is already in shock, persistent shock, in that case you have to rule out the other cases like the relative hypercortisolism is there or not, patient required any blood transfusion or not. So that part you have to be taken. And sometimes in these cases I will say rather giving more crystalloid, maybe the colloid like the albumin maybe preferable. In albio study also they have used to maintain the hypoalbuminemia, as well as we have seen the outcome parameter, that the vital parameter like blood pressure and the vasoactive agents requirement has gone down and the BP has improved.
Great. So yes, I will just interrupt.
That is the point to be taken.
I totally agree. Very nicely answered, sir. So as you have suggested this scenario, we can give albumin in some scenario. So I will go. Cases. Yeah, I will go next to Dr. Prasanjit sir. Prasanjit sir, you are there. So the balls thrown up by Sujoy sir, is collared as maintenance fluid better than crystalloid? Prasanjit sir, question is to you.
Perhaps all of us come to know that there is no role of colloid as such in case of maintenance fluid in comparison to crystalloid. We all believe that crystalloid is probably the best maintenance fluid. As per British Journal of Anesthesia, it is elusive term. What is the ideal maintenance fluid? There is practically no ideal fluid. As of now, we have come to know that among crystalloid, rather than normal saline, perhaps other plasmolite and all these things and lactated ringers are perhaps taking the better place. But obviously, colloid is not a good choice. Yeah, but in very rare cases where post-cardiac surgery, even after the 3 liters of crystalloid resuscitations, if it is required, then we can use some albumin, not even our 25%, is a 5% albumin. But we all know that according to SET trial, there is no difference of albumin and normal saline as such. So perhaps extra or all other synthetic starches all have been out of dated, even in as per US FDA. In critically ill patient with renal dysfunction, they have taken the recommendations of extra starch and etc. And even UK, they have withdrawn entirely. But yes, European emergency medicine, they have still given the permission to use in trauma situation as a maintenance fluid. But perhaps in comparison all the scenarios as per the concrete trial and everything, we can say that concurrent liability says the crystalloid is preferred as over the colloid as a maintenance fluid.
Excellent. Thank you, sir. So I think you answered why colloid should not be given. And is there an ideal colloid? You also said like that. So my next question is, out of the colloid what is available, starches, 5% albumin and 20% albumin, if you are given a choice in all the scenario you just now told that crystalloid is the preferable fit, on some rare exception where it's a refractory shock or a post-cardiac arrest or post-cardiac surgery, you would like to give colloid, out of the three, which one will you choose? Starches, 5% albumin, 20% albumin.
As per the available data, Stanford Healthcare, the policy of colloid use and albumin use, they have specific recommendation in a large volume plasma synthesis or parasynthesis, or in case of the post-cardiac surgery, the 5% albumin is recommended. But to be very honest, in a particular scenario, particularly in sepsis and all, where we feel there is a low oncotic pressure, we usually use 20% albumin. Don't go by the trial, but we have to always fix our gauge on the clinical context. So even with crystalloid, if we say there is a extra volume fluid overload, so usually use 20% albumin to maintain the oncotic pressure as well. But particularly post-cardiac surgery, I would rather to go for 5% albumin, otherwise 20%.
Okay, great. So thank you, President sir. I'll come back to you again.
Then we're running shortage of time.
Yeah, I'm coming down. So I would come to Dr. Srinath now actually, who uses 5% albumin quite often. So how do you give 5% albumin, Srinath sir?
Good evening, Dr. Asif and the panelists. Thank you so much for kind invitation. 5% albumin, as this is the case scenario you have put, Dr. Pragyan, I usually use albumin 5% in the initial phases of the sepsis and septic shock. I don't use as a bolus dose what other trials have done, like 200, 300 ml to maintain the albumin level. The goal is not maintain the albumin level in fact, but it has got a oncotic as well as non-oncotic properties. The non-oncotic properties definitely overpowers the other colloids available. So I use albumin for the purpose of its non-oncotic properties as well as few of the oncotic properties which helps the crystalloid to bind together and allow the intravascular volume, effective circulatory volume to be maintained for a little longer time. So usually I use 5% albumin as a continuous infusion, low dose, say 10 ml per hour or 20 ml per hour, and that comes around 12.5 to 25 grams per day. So that is sufficient. If it is affordable, patients are affordable, definitely I use it, but not longer for more than 24 hours, not more than that, or maybe 48 hours in some cases.
Okay, thank you. So whether you prepare albumin on your own or you market available 5% albumin preparation you use, like a lot of sites we have seen they prepare albumin on their own.
It's easily available for me, and 5% albumin is easily available.
Okay, great. So when fluid in the de-escalation stage, when we come out of, we have to draw fluid out of the body, whether you give diuretics along with albumin or you prefer albumin alone only?
I usually don't use a diuretic in the long term, say after 4 or 5 days of resuscitation and stabilization, hemodynamic stabilization is achieved. We have worked hard to achieve that stabilization. Now I don't want to give diuretics to reduce the intravascular volume as such. So usually I don't commonly use diuretic as such. But if patient is having some other comorbidities, as other panelists have also mentioned, definitely some cardiac issues are there, low cardiac output status is there, and pulmonary edema is there, or developing pulmonary edema, because even after the resuscitation, patients are at the verge of septic cardiomyopathy or something is there. That definitely I have to use diuretic as a bolus dose. Yes.
Thank you, Srinath sir. So next, I would like to go to Dr. Anirban Chattopadhyay sir. With this question we have discussed. So, what is your idea that when we should change from fluid boluses to maintenance fluid? Like that, now that don't give 500 ml bolus, start 50 ml per hour. So, what is your take on that, Dr. Anirban sir? Hello, is he there? Hello, am I audible?
Yeah, you are audible.
Dr. Anirban, I think he is not there. Rakesh, you can take up this question. When do you decide that this fluid bolus is enough, we can come to maintenance fluid?
It's just when you get your figures right, unless your PP
Yeah.
settles or urine output comes, you generally don't settle. They can put it at 1 hour or 2 hour, but we go long. That depends on how the patient is responding. But once they are done with, we are done with fluids. That's
okay, great. So that answers the last question also, when to stop maintenance fluid. So we do stop when we see clinically the fluid is good enough, urine output is good enough, patient is somewhat taking riles enterally or orally, then we can stop maintenance fluid. Okay. So is the fluid volume, whether euvolumic, hypervolumic, or hypovolumic, that decides the type of fluid would you like to give? Dr. Sujay, would you like to take that? Whether
Yes,
patient
yes. We have to conclude again.
yeah, conclude.
Yes.
Okay, fine.
The
So,
last question, okay?
last slide. Okay, sir, I'll go to the last slide then. So to conclude, the choice of maintenance fluid or the amount of maintenance fluid or when to stop, a lot of panelists have more or less we agreed on few very keen points and we decided on few points, but more or less the conclusion is that it has to be decided only clinically, I think. The guidelines are not yet made because it is to be a majorly a clinical decision. Thank you, Asif sir, and thank you to all my panelists.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you. Thank you.
Thank you all panelists, and I will move to next topic. The next topic is our benefit and pitfall of point of care echo in ICU, and we have an eminent speaker, Dr. Lonnie Goswami, is a senior consultant critical care medicine in Apollo Gleneagles Hospital, and the chairperson is Dr. Sarbari Soika. He is a HOD, SSKM Hospital, Department of Anesthesia and Critical Care, and also chairperson.
Hello.
Sudipto Mukherjee is a consultant critical care specialist in Tata Medical Center, Kolkata. So I will request Dr. Lonnie to please start the session. Dr. Lonnie. Dr. Lonnie, please start the session. Dr. Lonnie, is there any technical problem? Hello. Dr. Lonnie? Yes. Ma'am, it's not audible. Your voice is not audible. Technical person, can you help? Can you help her? Support team?
Yes, sir. No, ma'am, we can't hear you. You have any headphone? Just plug in and can you check that? No, ma'am. No audio. We can't hear you, ma'am. Asif sir, you're on mute. Just unmute yourself.
Lonnie ma'am, can we go for next? Then we'll come to you. Okay, Dr. Parthajit, are you online? Yes, Dr. Parthajit.
Yeah.
Okay, so our next session is current therapeutic CTD ILD scleroderma, and the eminent lecturer is Dr. Parthajit Das. He's a senior consultant rheumatologist in Apollo Clinicals Hospital, and the chairperson is Dr. A.G. Ghosal. He's a senior professor pulmonology. Yes. Dr. Parthajit, you start. We'll come back to Dr. Lonnie after this session.
Okay. Can you see my slides? Is it okay?
Yes, sir. We can see your slide. Please go ahead.
Okay. Thank you very much for asking me to present on a very interesting topic. Current therapeutics in the management of CTD, especially scleroderma. I'm extremely scared to present this topic in presence of full of chest physicians. So please excuse me if I have said anything seriously wrong. So this is the overview of my talk. So just a few background data about what is scleroderma lung, when we need to start treatment, and what are the therapeutics we have on board with we can start treatment. And anti-fibrotic agents are coming in a big way. So what are the evidence for that? So amongst all the autoimmune diseases, what we normally deal with, there's several of them can present as an interstitial lung disease, like rheumatoid arthritis, systemic sclerosis, SLE, inflammatory myositis, Sjogren's disease. Most of the disease can present, they have HRCT findings of non-specific interstitial pneumonia. But I just want to point that, is my arrow visible? Probably not, is it? Just a sec. No, I mean, in that case, so even rheumatoid patients, around 30% of the patients can present with UIP findings on HRCT. So that means there's not all UIP are IPF, like rheumatoid arthritis, sarcoid, scleroderma, they can present as UIP findings in HRCT. So just a few data on scleroderma lung. Lung can be involved in various ways, including ILDs. It could be just pulmonary hypertension by itself or in combination. Can affect the airways as well. Sometimes pleural disease like serositis, inflammations, massive pleural effusions can be a presentation. Indirect pulmonary complications are gastric reflux disease. So we know presence of reflux can exacerbate ILDs. Infection is a strong concern, especially when patients are on steroids or different kinds of drugs which suppress the immune system. Again, drug toxicity. Malignancy, I'm not exactly sure. There's a mild, higher risk of malignancy as well. Respiratory muscle weakness, especially in overlap syndrome when you have inflammatory myositis. Restrictive lung disease, secondary to skin tightening, skin thickness, and secondary to cardiac involvement. It could be just different lung conditions like COPD, asthma, pulmonary nodules, etc. The specific interstitial lung disease entities which are associated with scleroderma are pulmonary fibrosis, fibrosing alveolitis, diffuse alveolar damage, and cryptogenic organizing pneumonia. So again, as I've said earlier, ILD and PH is the main manifestations, and together they can account for around 60% of SC-related deaths. Most of the patients can have either HRCT or PFT findings across all the ethnicity. Around 90% of patients can have CT scan findings of fibrosis. Pulmonary involvement could be fairly early. Up to 25% of patients can develop significant lung disease very early on, within first 3 years of onset of symptoms. Up to 2/3 of patients can have ground glass changes, but they can progress to fibrosis irrespective of the treatment which you offer. And reversibility is quite rare, so you can restrict the disease. Probably you can slow the progression of disease, but cure is probably not there. I have mentioned this, so you need to be aware of scleroderma, scleroderma, which is a pulmonary disease with no skin manifestations at all, which is often misclassified as idiopathic ILD. So probably take some time to take history like Raynaud's disease, joint symptoms, skin tightening, reflux symptoms, or if they have any antibodies positive like ANA or Rho or kind of anti-centromere. So think of something else as well. So death, so survival is reasonable. So estimated survival is around 85% over the next few years. And unlike idiopathic interstitial pneumonia, survival is not much different between NSIP and UIP. So what makes you think you need to start treatment? So this is all very well known to you. So when HRCT involvement is less than 20%, it's limited disease. When it's more than 20%, it's extensive disease. And when it's in between somewhere, if FVC is less than 70, so that means quite a severe disease. And the reason we need to start treatment as early as possible, and we need to try to halt or reduce the progression of disease, because the survival rate of extensive disease is much poorer compared to limited disease. So these are the poor prognostic factors, including very low baseline FVC, very low transfer factor, extensive ILD on HRCT, anti-topoisomerase antibody positivity, and if someone has very diffuse, extensive skin involvement. But having said that, if someone is anti-centromere positive or anti-RNA polymerase 3, that's probably beneficial. They don't manifest as severe ILD. Then how do we treat? If you look at the trends before 2012, most of these ILDs were treated with steroid and azathioprine. But with the better understanding of the disease, since 2012, we are trying to categorize. If patients are more having fibrosis, then we are using antifibrotics. If patients have active inflammation, ground glass changes, then probably we use more immunosuppressive agents like DMARDs, rituximab, cyclophosphamide, etc. Now, these are the factors which guide us to decide which is more predominant, which is inflammation or fibrosis. Factors which prefer inflammation are ground glass changes without any evidence of fibrosis. When you do the BAL examination, high lymphocyte favors active inflammation. I haven't done this test by myself. This is just a pure theoretical. So high interleukin 2 receptor versus KL6 is a big term. So if it's high, then probably it favors inflammation, and if you have active inflammation on skin biopsy. And another thing, if you haven't done any of this, if patient responds very well to immunosuppressive agents, that's also an indicator of inflammatory disease. Now, what are the treatments available? Various DMARDs has been tried. Methotrexate has been tried in the past, but it shows moderate involvement or improvement of the skin tightening, but there is no beneficial effect on the ILD. Mycophenolate azathioprine has a beneficial effect. I'll probably discuss a few of the studies later on. But azathioprine appears less efficacious as an initial therapy in the management of SSc-ILD when it compares to cyclophosphamide, although there is no head-to-head trial between azathioprine and MMF, just to know which is better. When we talk about cyclophosphamide, although there are few trials like retrospective studies around in 1993 and 2000, this was a very robust study in 2006-7 area. It's a scleroderma lung study, which is studied around 158 patients. They compared oral cyclophosphamide between 1 to 2 milligrams per kg for 12 months versus placebo. And they have noticed significant improvement in the transient dyspnea index, FVC, and HRCT scores. And the interesting is, you have, after even stopping cyclophosphamide for 12 months, the beneficial effect continued up to 18 months before it started to wane off. So this is the study. I mean, this is the graph which showed the FVC decline is more favorable in the cyclophosphamide group compared to the placebo. So, but when you use cyclophosphamide, you have to be very careful about the side effects, which includes bone marrow toxicity, pancytopenias, various forms of infections, bacterial infections, virals, PCP infections, especially in young females, which commonly present in this sort of diseases. Infertility is a major issue. So I think urolupus trial dose is probably better than oral cyclophosphamide. And if you use it long-term, carcinogenicity is a concern as well, especially bladder cancer. Then following on, there was a randomized control looking at intravenous cyclophosphamide followed by azathioprine maintenance, and they have also found a favorable outcome when used in patients with SSc-ILD. I'm not going into details because of the times. In sclerodermal 2 lung study, which is also a very interesting study, and they have included 142 patients for a long 6-7 years period of time. They have assigned patients on MMF for 2 years and oral cyclophosphamide, again 2 milligrams per kg for 1 year. If you look at the curve, I'm not having the cursor with me, but there has been a very significant improvement of FVC, transitional dyspnea index, and skin thickness score in both the groups, MMF and cyclophosphamide. But having said that, if you see when you stop cyclophosphamide after 12 months, the beneficial effect or the favorable outcome still maintains up to next 6 or 9 months. This means 18 months or 12 months before they start to wane off. But having said that, because of the toxicity profile, MMF is much better tolerated. If you look at the study who has compared oral cyclophosphamide versus azathioprine, it's also a randomized unblinded study. There has been a significant decline in FVC among the AZA group, but they haven't been very effective in terms of the skin score changes, Raynaud's phenomena, or a decrease in the ESR. So probably cyclophosphamide is much better as an initial therapy, and azathioprine could be maintained, as a maintenance of remission. This is a meta-analysis looking at the cyclophosphamide. They have, again, this is a European study, has included many patients, but they haven't found significant improvement in lung scores when using cyclophosphamide. So we have a mixed response. A few studies have shown really good response, and a few studies has shown not a very favorable response, to be honest. If we come to rituximab, there are various case studies, case reports. There's one randomized study. They have showed that rituximab has a favorable role in patients with ILD. This is again a Euster Networks patient data analysis. They include 254 patients, and they have looked at the skin fibrosis, lung fibrosis worsening, and the adverse event. But they have said and they have showed that although the skin fibrosis is better, lung scores are probably not as favorable as is showed in different studies. But we have also a study from SSKM in Calcutta. They have also looked at the beneficial role of rituximab, and they were quite pleased to know that rituximab patients have done really well. So rituximab do have a favorable role for patients with systemic sclerosis. This is the ongoing study. It's a multi-center, double-blind study. It's happening in UK at the moment. They'll probably come up with the results in 2021-22. And they have compared rituximab versus cyclophosphamide. So we are waiting to hear from them, just to know which is probably better. We have to wait for another few times. So in terms of other biological therapies, anti-TNF drugs, tocilizumab, which is an IL-6 blocker, abatacept, which is a co-stimulation blocker, these medications, although have shown initial good response, but later on, when they're studied in a randomized study, they were not very favorable. JAK inhibitors like tofacitinib, filgotinib, they are undergoing trials now, and they have a very promising result. So probably in a few years down the line, we'll be discussing more promising results in patients with SSc-ILD. Now let's come to the role of antifibrotics. Scleroderma lung study is still going on. We haven't got the results yet. So they have combined pirfenidone with mycophenolate. Few abstracts have been published in ACR last year, and they have showed good response when you combine pirfenidone with mycophenolate. This is a LOTUS trial. This is not the efficacy trial, but this is an open-label phase 2 study. They looked at the safety and tolerability of pirfenidone, and they have found that when you combine pirfenidone with MMF, there is not much significantly better toxicity, and pirfenidone is quite acceptable as well. If you look at the Census trial, this is quite a good number of patients, more than 576 patients. They looked at effect of nintedanib, They included systemic sclerosis patient with more than 10% fibrosis on HRCT. Most of the patients has been treated with MMF. Around 7% of them had methotrexate as well. And they have randomized patient on the DMARDs with around 50% receiving nintedanib 150 milligrams and placebo. And the primary endpoint was annual decline of FVC rate. So again, you can see the decline in FVC is definitely lesser in nintedanib group compared to the placebo. If you look at the mode breakup, if in the placebo arm, patients who has not received MMF, and their decline is significantly worse compared to patients who has received MMF in the placebo arm. Whereas in the nintedanib arm, patient who hasn't received MMF, their decline of FVC is comparable to the MMF monotherapy group. But when they combined MMF and nintedanib, the decline was much more favorable, so much more lesser. So there are quite a few studies that lung transplant who patients who haven't responded, who have refractory to various drugs, and who are quite symptomatic NYHA class 3-4, needing regular oxygens, they are good candidates for lung transplant. And the study has showed survival rates for lung transplantation after 1, 3, and 5 years around, it's quite significant, around 81%, 68, and 61% respectively. There are also some studies about autologous stem cell transplant, but the data is not very robust, so I haven't put it in my slides. But having said that, it's not just the lungs. We have to treat the disease. It's the joints, it's the skin, it's the cardiac conditions, it's the reflux disease, pulmonary hypertension. Patient can have congestive heart failures. So it is a various things which needs to be taken into consideration when you're treating a patient with systemic sclerosis with ILD. So just to conclude, ILD in CCD is a complex disease. It needs a systematic, proper diagnostic and therapeutic treatment plan. Anti-inflammatory, immunosuppressive drugs need to be used with caution. Antifibrotics is coming in a big way. Probably we are waiting to hear from a few other studies which are going on, which will definitely help us later on. And finally, it's a multidisciplinary team approach, including chest physicians, rheumatologists, immunologists, rehabilitation team like physiotherapists, etc., so that we get to know we can deliver the best practice. Thank you very much.
Thank you, sir. Thank you. We are running so late that's why I'm avoiding question. And next session is Dr. Lonnie. You are ready?
Yes, I think so.
Yeah. So next session is benefit and pitfall of point of care echo in ICU. And the eminent speaker is Dr. Lonnie Goswami, is a senior consultant, Department of Critical Care Medicine in Apollo Clinical Hospital. Ma'am, just start. Yeah.
I don't understand what keeps. Am I audible?
Yes, yes, ma'am.
Yes. Right. So, point of care ultrasound, as we know, I'm audible, right? Is
yes.
Yeah. So it has become a part of the medical exam, and we are now using more and more ultrasound because it has become an extension of the stethoscope. And we are using it not only in the emergency department and intensive care unit, but also in the perioperative arena, because it is not only highly accurate, non-invasive, portable, and rapidly performed, but it is easily repeatable and simple to learn. Point of care ultrasound gives us critical information in real time in the setting of life-threatening emergencies, increases patient safety, improves diagnostic accuracy, and reduces diagnostic uncertainty, therefore improves efficiency and saves lives. It has been used.
Sorry to interrupt, ma'am.
Yes.
Your slide is not visible. Can you stop share and share again?
Is it visible? Is it visible now?
No. Yes. Oh, now,
yeah. Yeah.
We can see it.
Right. Okay. So we have been using point of care ultrasound for various diagnostic purposes based on, say the patient comes in with a particular symptom and we do an ultrasound of the abdomen, of the thorax, or the use of ultrasound in trauma, in evaluation for DVT, and also in soft tissue and musculoskeletal ultrasounds. We are also using Okay. We have been using ultrasound in guidance for procedures, in cardiac and hemodynamic assessments, in therapeutic monitoring, and in cardiopulmonary resuscitative attempts. Let's take, for example, a case. This is a 24-year-old man who presented to the ER with right-sided unilateral chest pain that began about 6 hours ago earlier after a game of basketball. His pain was initially sharp in quality and in the back and shoulder, began abruptly and worsens with deep inspiration. He has taken a tablet of ibuprofen before coming to the hospital. He smokes a packet of cigarettes a day and denies use of any other substances. On examination, he's healthy, and his vitals are that he's a little tachycardic, about 106 per minute, blood pressure of 120 by 80, and breathing at 24 times per minute. He is not able to complete a sentence fully, and saturations is 97% on room air. This patient on examination of the lungs shows that the breath sounds on the right side is decreased, but there is no wheeze and there is no chest wall tenderness. The heart is okay and the abdomen is soft and tender. Now, if we have an ultrasound probe, we can easily do a point of care ultrasound to find out whether this patient has a life-threatening pneumothorax, which could well go ahead and have a tension and a cardiac arrest, or he just has a musculoskeletal pain. So if we have an ultrasound probe, we place it sagittally with the pointer facing upwards in the midclavicular line anteriorly, and then we look for at least two rib structures with the pleural line in between and look for what kind of pathology he has, for example, an A-line pathology, which are reverberations of the pleural line, or is it a B line? And then by placing the M mode first, placing the patient on M mode and with the marker placed at the pleura, we can find out whether he has the seashore sign along with the presence of lung sliding, which is a shimmering sign that we get, which completely rules out the presence of a pneumothorax, or the absence of lung sliding and a barcode or a stratosphere sign, which may say that the patient has a possible pneumothorax. Now, what does the international consensus say about use of focus in CPR? Say this patient, or for example, any other patient presents in a cardiac arrest situation. The goal of a focus ultrasound in cardiac arrest is to differentiate an organized cardiac rhythm from asystole, true PEA, or a pseudo PEA, to find a reversible cause of arrest. For example, a cardiac tamponade, which can be easily aspirated, giving back life to the patient. Perform an ultrasound guided procedure, that is the aspiration of a possible pericardial effusion, but in no way should the ultrasound delay chest compressions. So, as we know, ACLS has a kind of a fit-all procedure for a one size which fits all kind of a policy, where we have the same guidelines for every person. But in this hullabaloo of a code black, code blue situation, palpating for a pulse could be insensitive, it is inspecific, and there is a huge inter-rater reliability of the palpation of a pulse. So in this situation, if we could quickly place an ultrasound probe, we could bridge the gap in recognition and evaluation of the precipitant of the cardiac arrest, go to the endpoints in resuscitation, for example, to see whether a patient is in cardiac standstill or there is some amount of cardiac activity ongoing. And it also facilitates in an improved approach to resuscitation of the arrested patient. So the applied cardiac arrest ultrasound again reiterates that ultrasound should not delay chest compression at any time. Why is it saying this again and again? This is because in 2017 and 2018, there were 3 studies that demonstrated that the use of an ultrasound probe increases the duration of pulse check from 13 seconds to 21 seconds, which means a significant increase by 8.4 seconds, which could result in the patients getting less amount of chest compressions and which could be detrimental. However, it does not say that we should not use an ultrasound. during this cardiac arrest situation, only that sensible techniques and proper training in order to decrease the duration is being told to be done. So how do we acquire the image? In 2007, when when ultrasound was first used in CPR, it was first placed on the chest wall after 5 cycles of high quality CPR. But then again, we had another 3-step approach by Gardner and Plattenberg, which says that you first put the ultrasound probe either in the subcostal or the apical or the plaques view, and it's placed earlier in CPR once a high quality chest compression is achieved. This first placement of the ultrasound probe is to see whether the patient has a cardiac tamponade, which clinches the diagnosis altogether, and then we can do a therapeutic aspiration. And then thereafter, to continue the CPR and repeat an ultrasound examination to assess if the patient has a right heart strain, because this would exclude a pulmonary embolism, and thereafter to see if the cardiac activity has resulted, and to determine how long to continue the CPR without achievement of ROSC. A key role is also placed on after ROSC has been achieved, and also at the same time we can do a fast in order to look at any collections in the peritoneal compartment, or to look for hypovolemia by looking at the IVC, etc. The probe that is used is usually a phased array or the cardiac probe, or a curvilinear abdominal probe, and the windows, as I said, could be subcostal, apical, or a parasternal long axis. Now, a key point in faster image acquisition during CPR is to have at least 2 physicians, and the most experienced ones should scan, because we do not want to have any delay in cardiac compression by doing an ultrasound at this position. So where do we fit it in? In a shockable rhythm, a focus may aid in the differential diagnosis, say whether it's a fine BF or a false asystole. And in the non-shockable or the pulseless electrical activity rhythm, it is seen that when asystolia is used with cardiac contractility, which happens in about 10% of patients, the prognosis is much better when it is used when the asystolia is present with a complete cardiac standstill. Therefore, the main causes of cardiac arrest, be it a cardiac tamponade or a PE, can easily be diagnosed, and it can be treated in the cardiac arrest situation itself. So what does the 2015 American Heart Association guidelines say about use of ultrasound? It says that ultrasound during cardiac arrest may be considered during the management of cardiac arrest, and a qualified sonographer is present, and the use of ultrasound does not interfere with the standard cardiac arrest treatment protocols. This is a study which reviewed the percentage of patients in which return of spontaneous circulation was or was not achieved during resuscitation. And this shows that in a patient who has a cardiac motion, but there is no return of spontaneous circulation, the percentage is 36.4, where a person with a cardiac motion and return of circulation, it is 58. But if there is no cardiac motion at all, however, the cardiac motion has not been defined very properly, and there could be return of spontaneous circulation only in 17.6% of patients. And when there is no cardiac motion, usually, that is 82.4%, there is no ROSC achieved even after a properly done CPR. So what does the 2020 International Consensus Guidelines say about use of ultrasound? There is no standardization or uniform definition of cardiac motion visualized on point-of-care echocardiography during cardiac arrest. There are very few prognostic factor studies of point-of-care echocardiography during cardiac arrest performed with methodology that minimizes the risk of bias, and the inter-rater reliability of point-of-care echocardiography during cardiac arrest is uncertain. The relative roles and feasibility of transesophageal versus transthoracic echocardiography during CPR require research. So where does that put the recommendation? The treatment recommendation is now against the use of point-of-care echocardiography for prognostication during CPR, because it may delay the cardiac contractility, the cardiac decompressions. Now let's look at common pitfalls that can arise in point-of-care echocardiography, because because as we know, echocardiography is in the golden era. So everybody is now holding a probe, and we get a lot of reports which could not be true reports, which is probably because of inexperience, or it could be because of the hurriedly performed ultrasounds. So we should be aware about the common pitfalls, be it we are looking at the cardiac tamponades, or it is the IVC or the lung ultrasound. So following some rules and technique and interpretation, and always integrating a POCUS finding into the broader clinical context, most POCUS misdiagnosis can be avoided, and thus patient safety can be enhanced. Being aware of a list of common pitfalls may help to avoid misdiagnosis. And I think all of us should read this paper because it gives a very good account of the commonly done mistakes. For example, if there is a patient, say in this first picture, this is a clear-cutted pericardial effusion. Then it rules out a pneumothorax. But if it is absent, it does not say that there is a pneumothorax. So lung sliding is abolished in a variety of conditions other than pneumothorax, including ARDS, pulmonary fibrosis, large consolidations, pleural adhesions, atelectasis, right main stem intubations, if you're seeing it on the left side. A lot of patients who have been pluralized will also not have a lung sliding as also in phrenic nerve paralysis. So the this was a nice study which reviewed the pleural ultrasonography versus chest radiograph for the diagnosis of pneumothorax, and the result was that pleural ultrasound is superior to chest radiograph for detection of pneumothorax, but training and familiarity with bedside ultrasound techniques provides better accuracy, and a high resolution linear probe needs to be used. Ultrasound is convenient, does not cause radiation exposure, and is readily available at the bedside. And it being easy to learn, we need to do more and more in order to be accurate in our diagnosis. I don't think any talk would be complete without mentioning COVID-19 in this present state. So there is this review paper which showed about multi-organ point of care ultrasound in COVID-19. And this is a graphical representation of where we can use it, be it in the triage at admission for diagnosis of respiratory failure, for guidance of mechanical ventilation, in finding out complications of mechanical ventilation, for example, whether the patient has a pneumothorax, in facilitating even recruitment maneuvers or ventilation weaning, in finding out about secondary organ dysfunctions, for example, a patient who develops an AKI or a DVT. It also helps in tele-ultrasound, where we can do it in order to get a second opinion, or in remote training. In diagnosis of stroke and neuromonitoring, for example, we can see the transcranial Dopplers and the optic nerve sheath diameters. In deep vein thrombosis, fluid status assessment, cardiovascular assessment, and hemodynamics, and in finding out whether the COVID-19 pneumonia is of the L phenotype, which has a lower score, or the H phenotype. With that, I would like to end and say that we are going a long way in doing ultrasound as a complement to the physical examination, but proper guidance and good training and doing it again and again is what is going to achieve better outcomes. Thank you.
Thank you. Thank you, Dr. Lonnie. This is a wonderful lecture. And we have to move next lecture, that is role of antifibrotic in chronic hypersensitivity pneumonitis. And with us, the eminent speaker, Dr. Sanjeev Mehta. He's a senior pulmonologist, Department of Pulmonology in Lilavati Hospital, Mumbai. And this chair will be session by Dr. P.S. Bhattacharya, but sir has requested his connection problem, due to connection problem. Dr. Shubhasis Ghosh will chair this session. So I will request Dr. Sanjeev, please start the session.
Right. Thank you very much. It's a pleasure to be here. I'd like to thank Dr. Subhashish Ghosh for the kind invitation, and Dr. Asif Iqbal for making all of this happen. Thank you very much. I think there is a little misunderstanding in the topic. To the best of my knowledge, my topic was phenotypes and management of stable COPD and not chronic fibrosing lung disease. So I hope that's my topic, because that's the one I'm going to speak on. If you want, give me another half an hour. I'll prepare my next lecture and I'll come back to you.
Sure. You start with phenotypes and stable COPD.
Yeah,
No problem.
because that's what I heard, what I had in my record. Okay. In fact, if I remember, I had asked whether I have to do both in 15 minutes, and the reply was yes. I hope I'm not impinging on anybody else's talk, but that's the one I have with me.
No, you carry on, Sanjeev. This is nice.
So, again, congrats for this wonderful program. And let me talk about phenotypes. So, India has a huge problem. We had, at one point in time, the second highest number of patients of COPD. We now have the highest number of COPD patients, which is more than the combined population of Canada and Australia. We have more deaths than anywhere else in the world, which is a terrible, terrible landmark to achieve. And we have the most amount of disability. So what have I said? we have the most patients, the most suffering, and the most mortality in India than anywhere else in the world, and it is getting worse. It's going to get worse before it gets any better. So I think it's essential to understand how COPD develops and what are the various phenotypes of COPD. So we now know that COPD is not a late onset, but actually starts very early in life. Children who are born of smoking mothers or in very environmentally polluted areas, or who are genetically predisposed, when they are exposed to environmental pollution as they grow up, and this can happen in environment or in biomass fuel exposure, these genetically predisposed individuals, when exposed to cigarette smoke, inactivity, and other such triggers, they go on to develop disabilities, and how they manifest it depends on that particular patient's background, the genes, and the kind of exposure. Now, the way it manifests is now called as a phenotype. Now, I hope everybody understands. Phenotype is a clinical presentation of a disease. An endotype is the actual biological mechanism of the disease. So, COPD phenotype can be described in many ways. We could describe it, and any one of this could be okay. Airflow limitations, a patient who's breathless, a patient who gets rapidly downhill, a rapid decliner, a bronchodilator responsive, hypercapnic, patient who cannot walk. So there are many ways people who have low DLC or pulmonary hypertension is a functional phenotype of COPD. Or we could have a clinical phenotype. So the clinical phenotypes classically are what was originally called as the pink puffer or the blue bloater, but we now know that that's not really true. So this was the classic two ends of the spectrum which were initially defined many years ago. The emphysema phenotype, the pink puffer, the blue bloater, chronic bronchitic. But we could now it is more nuanced than that. So we have the shorter breath patient who's a very breathless, more like emphysema. Frequent exacerbator, more like the chronic bronchitic. But we have those who have very high comorbidities such as pulmonary cachexia, the innate corticosteroid responsive, patients of high depression and anxiety. Now, radiologically is another way to describe the phenotypes. Those who have a lot of emphysematous changes, and these are central lobular emphysema in the upper lobes, or you could have patients who have chronic airways disease kind of a phenotype. And you can see here direct and indirect signs of chronic airways disease, which can come up. So I think there are many ways to look at the COPD phenotypes based on functionality, clinical, radiological, and finally phenotypes based on the asthma COPD overlap, which became very popular in the past, called ACO now, and that has therapeutic implications, which I'll dwell on in the end. With this background, what are the phenotypes in India? I think the Indian phenotype is different from the rest of the world. The rest of the world, in the developed world, is mainly tobacco because pollution is not a problem. But our problem is more tobacco and environmental, because the rest of the world is essentially, or the Western world has tobacco related. It is homogeneous. That's a usual phenotype. We have more heterogeneous lung manifestations, and so our populations are younger, female, more exacerbators, and that's driven by biomass fuel exposure and because of environmental factors, as against only tobacco. In India, tobacco is probably about anywhere between 30 to 50% of the COPD, maybe even less. So non-tobacco results in a very mixed, heterogeneous kind of a phenotype, and we should be aware of this because that has therapeutic implications. Now, the goals of COPD treatment are clear. You want to prevent the disease and you want to manage it well. Well, prevention is really the key because we don't want the burden of COPD. And so, reduction in tobacco exposure, dust exposure, chemicals, pollution, and above all, the reduction in biomass fuel. Now, we know smoking cessation helps. And you can see that it preserves lung function at the time that you stopped smoking. There's no further rapid decline in lung function. So smoking cessation is the most important part of managing COPD. And if you are able to stop smoking, then there is an increase in life as well. So I think smoking cessation is the way to go. And there are many ways to do it with drugs, counseling, and everything else. Time does not permit me to go there. Vaccines prevent the exacerbations, and they are now part of the protocol. So influenza and pneumococcal vaccines should be considered in the management strategy. Now, many years ago, it was recognized that just looking at lung function did not give us a good estimate of how to manage a patient for morbidity and mortality. So, and FEV1 was not a strong player, great for diagnosis, not a strong player in terms of day-to-day management. So, a few years ago, the GOLD, the Global Initiative Against Obstructive Lung Disease, came up with this paradigm, which I'm sure many of you are familiar with. Group A would be those who are mild and not having exacerbations in terms of frequency of exacerbations. Group B is people who are very breathless, the emphysema type of people, but do not have such so many exacerbations that they come to the doctors all the time. C is people who are not that breathless, they're fine between attacks, but get at least more than two attacks every year. And the group D is the poor guys who are breathless and keep getting attacks. So that's the way it's designed. And why is this so? Because this has implications on how you use your drugs. Now, again, time does not permit me to go into all these drugs. Remember, what is key over here, if you see, versus asthma, you see that inhaled corticosteroids are missing right all the way, except in combination. And I'll talk to you about inhaled corticosteroids later. So the way we look at group A, you want to give them short-acting bronchodilators, and this could be the LAMA or the SAMA, that is antimuscarinics or the bronchodilators. The group B is the LAMA or LABA or combination. Now, increasingly, we are using the antimuscarinics and the the bronchodilators, the beta 2 agonist, either interchangeably or in combination. And most of us have switched in group B, that is a symptomatic, not very exacerbating patient of COPD, and we're giving them the LAMA-LABA combination, and that's now the dominant treatment. When we get into group C, which are the people who have exacerbations, there was a tendency to use inhaled corticosteroids, but I'll show you a slide which shows that LAMA-LABA are as helpful in reducing exacerbations. And therefore, most of us are now using the LAMA-LABA combination even to reduce exacerbations. And of course, keep them symptomatic. So LAMA-LABA has the advantage of reducing exacerbations and keeping the patient symptom-free. I'll talk about this towards the end. So we've known this now for over about 15 years that the anticholinergics really give good bronchodilation. Sustained bronchodilation results in sustained improvement of patients, including lung function. If we combine the two, that is tiotropium and formoterol, we get even better result in terms of symptoms and lung function. So that, as I told you, is now the way we go in treating our COPD patients. But what is shown, which we thought we did not understand it initially, but recognize it now, that these bronchodilators also reduce exacerbations. And so tiotropium reduces exacerbations. And if you add steroids, that is where it was used to reduce exacerbations only, not for symptom cure in COPD. When the patient gets better, we need to de-escalate. And here is a very nice study that looked at taking the steroid out of the group. And you realize that if you took the steroid out of the group, you yet were able to reduce exacerbations. So clearly, indacaterol and glycopyridine, which is a LAMA-LABA combination, is as good for symptom relief, of course,
but also to reduce exacerbations. So is the role for inhaled corticosteroids? And that is yes. In the echo group, which is more the asthma patient who was a smoker, or in a patient who has eosinophilic manifestations, and clearly anybody who has a eosinophil count of more than 300 is a person that you would consider using inhaled corticosteroids, and particularly in group D. So in group D, this is where we go. You start with the LAMA or with the ICS LABA, come to a LAMA-LABA combination. If he keeps getting persistently unwell, and then we would give a combination of inhaled corticosteroids, LAMA and LABA. And now in India, and we've had this actually the first in the world, we have lots of combinations of LAMA-LABA inhaled corticosteroids, and we are probably the country with the maximum variety. If the patient yet does not get well, then in the more bronchitic type, we can use roflumilast. Patients with frequent exacerbations, then macrolides have a role to play. Again, time does not permit me to go into great details, but this study shows that when azithromycin is added, it reduces time to exacerbation. And so does roflumilast. This is again new in gold. Patients stop using their inhalers after about 50% after 6 months. So what is important, apart from other things like education, you want to give them the right inhaler, and this is now part of the guidelines. It becomes important for the doctor to select the right inhaler. Pulmonary rehabilitation is extremely important. It's a lecture by itself. Oxygen therapy in patients whose oxygens are low on exertion. And finally, I'm going to talk to you about what is the hallmark of India. We have a huge burden of disease. It's multifactorial compared to the rest of the world. Biomass fuel pollution, poor lung development in childhood, and of course, smoking. All of these result in different manifestations. Our phenotype is more inflammatory. So maybe we have a greater need for inhaled corticosteroids. And we have to be aware of our challenges. Our infrastructure is poor. We are more taboos. So we have a greater challenging in managing. But if you do phenotype driven COPD treatment, then we'll be able to give much specific, much better treatment, more specific, less side effect, more efficacy for the patient. And maybe it's time for personalized COPD management. I haven't talked about the role of interventional pulmonology and valves. I'm unable to do that right now, again, in the paucity of time. So I hope that I've been able to, in this limited period of time, give you a brief overview as the causations, the types of COPD, and its management. I'd like to thank you again, Dr. Ghosh, Dr. Akbal, for this kind invitation, this opportunity to be with you. Thank you very much. I wish the conference all success.
Thank you, Sanjeev. Thank you very much. Wonderful talk. Can I have one question?
All yours.
Since we are in India, the COPD population is a bit different, more with a lot of it from biomass fuel and all that, inflammatory. Do you think triple therapy here is okay, and in COPD, rather than in the West, where inhaled steroids shouldn't be in the picture?
I think so. I hope that our audience will be driven to identify their patients. So now in every one of our patients, we do CBC, simple test. But most of the times you look at the WBCs and the neutrophils, please look at the eosinophils. The moment you find eosinophils, bang goes the steroids into the patient. And of course, if you're finding patient exacerbating, then steroids. So I think we have a far greater need for steroids in our patients than the rest of the world. Sure.
Thank you, Dr. Mehta. It was wonderful. Thank you.
Thank you very much.
Thank you, sir. Thank you very much. It's a wonderful talk. And we will move to our next session. This next session is cryobiopsy, a new horizon in lung tissue sampling. And our eminent lecturer is Dr. Saurabh Mittal. Is the professor in the Department of Pulmonology Medicine, All India Institute of Medicine in Delhi, and chairperson is for this session is Dr. Shushil Agarwal. He's a senior consultant pulmonologist in Apollo Gleneagles Hospital. I would request Saurabh sir to please start this session.
Thank you, Dr. Asif, for the kind introduction.
So in next 10-15 minutes, we'll be discussing about cryobiopsy, which is a new horizon in lung tissue sampling. So if we look at the biopsy of the lung, so we had the surgical biopsy as the mainstay till some time back. And if we understand, there was an old saying that surgical operations are of two types: those that benefit the patient and those that kill him. So surgical lung biopsy was considered a high risk procedure for patients with compromised lung functions. And then that's where the role of cryoTBL became. So if we look at the cryobiopsy in pulmonary medicine, cryobiopsy can be of two types. One can be the transbronchial lung cryobiopsy, which we will be discussing, and another can be the cryobiopsy of the endobronchial lesions. If we look at the TBL cryobiopsy, that is the TBLC, it can be done for the interstitial lung disease, as well as in the guidance of radial EBUS, it can be done for peripheral pulmonary lesions. The technique would be a little different for either of them. So we'll be discussing about cryo-TBLB for patients with interstitial lung disease. So what are the basic issues which we need to discuss? So one is when to do cryobiopsy, when not to do, and how to do. These are the three important questions which I'll address. So if you look at the obtaining, why do we need a biopsy in interstitial lung disease? Because the treatment and prognosis will vary depending upon the type of ILD. And for this, accurate diagnosis is the key to management. And in a lot of patients, lung biopsy adds crucial information in the diagnosis of ILD. So when do we do biopsy? So whenever a confident diagnosis cannot be achieved by clinical and radiological features, and histopathology is deemed to add to diagnosis, treatment decision, or prognosis of the disease. That's where we do the biopsy. So what are the ways to obtain a lung biopsy? This is a very simple thing. So we have TBLB, which is very small but easy to perform. Then on the other hand, we have open lung biopsies, which are the largest but have increased morbidity and cost. Then in between, we have wet lung biopsy, which is also large but requires a longer hospital stay than the cryobiopsy. And this is the horizon thing which is new for the pulmonologist, that is the cryo-TBLB or the TBLC. It's a larger tissue. It is usually performed under GA, and in a lot of patients, it's helped us to get a diagnosis. So now comes the question when not to do a biopsy. So the absolute contraindications will include when the patient is at higher risk of GA, hemodynamic instability, patient has severe pulmonary hypertension, uncontrolled bleeding diathesis, pregnancy, extensive cysts or bullae. The relative ones would include anemia, poor lung function, where the risk of exacerbations is high as compared to those who have a better lung function, or patient has obese. So these are relative contraindications, but depending upon patient's functional status, a decision to biopsy can be taken. So what is transbronchial lung cryobiopsy? That is TBLC. It's a novel technique to obtain the lung biopsy. What is actually done, that a specialized probe which has a cryogen gas. This gas can be carbon dioxide or nitrogen oxide, nitric oxide, to free the lung tissue. And once this tissue is frozen, it is taken out with the probe. So why do we do TBLC? Because it provides a tissue which is larger than the usual forceps TBLB. The size of tissue on a forceps TBLB is usually 1 millimeter, while for TBLC it is from 5 to 10 millimeters usually. But what are the concerns while we take TBLC into routine clinical practice? So there are few problems. One is the good quality head-to-head trials against the surgical and biopsy are lacking. Number two, the adverse events. Risk of pneumothorax is high. Bleeding risk is high. ILD exacerbations can happen. And obviously procedure has some degree of mortality. And the third thing, which is a major problem all around the world, is that there is no standardization of the procedure. Over the last few years, there have been multiple attempts to standardize the procedure of obtaining a transbronchial lung cryobiopsy, but there are still many variations between the countries and the centers. So this was the statement by the Indian Association of Bronchology in Lung India, published a year back. This is regarding the indication of cryobiopsy. They recommended in patients with DPLD where information obtained by clinical and radiological features is not enough to arrive at diagnosis of subtype, they should undergo a cryobiopsy. Regarding the differentiation between fibrotic NSIP and IPF, they recommended that lung cryobiopsy or surgical lung biopsy may be performed after weighing the risks and benefit of the procedures. So what we understand here is, so patients who are not able to reach a confident diagnosis even after MDD are the candidates to undergo lung cryobiopsy. So how do we do lung biopsy? That I'll be going to discuss. So the initial technique was described in 2009. So now I'll be telling that how do we do it at our center. So we do it under general anesthesia with a rigid bronchoscope. So what are the equipment required for the procedure? You need a cryo station, which has a console and a gas. Then you need a flexible cryo probe, which can be 1.9 millimeter or 2.4 millimeters. And then you need a balloon occlusion device, a rigid bronchoscope, and fluoroscopy if available. If not, it is also okay. So this is the setup you have to have. So this is the flexible bronchoscopy system. Then you have an anesthetist who provides the general anesthesia to the patient. So the equipment includes the rigid bronchoscope assembly. This is a balloon, which is the Fogarty balloon, which we use. Any occlusion balloon can be used for occluding the segment. This is the filled balloon. So this is the Fogarty balloon, which we use for occluding the segment. And this is how the rigid bronchoscope is placed for obtaining the biopsy. So now we usually have at least 3 operators for obtaining the lung biopsy. So one operator holds the rigid bronchoscope in place. Another operator holds the flexible bronchoscope, which reaches into the segment to obtain the biopsy. And the third operator holds the occlusion balloon into the segment. So there are 3 operators which are required to successfully and safely obtain a cryo lung biopsy. So this is how the procedure is done. The one person is holding the scope, rigid scope, one person is holding the flexible scope, and one person is fixing the occlusion balloon. So before you put in a flexible cryo probe, you should always check that the cryo probe is working and is functional, rather than getting into the segment and if there is any malfunction. Now I'll just show you the procedure video. So you have a rigid bronchoscope in place, you have a occlusion balloon in place, and now the flexible cryo probe is being inserted into the segment. So once you insert the flexible cryo probe into the segment, before that you should check that the occlusion balloon is in the correct segment. So here we have placed the occlusion balloon into the right lobe basal segment. We have checked the position and filled the balloon initially. Now balloon is deflated and I will be obtaining the cryobiopsy. So now the flexible cryo probe is being passed into the flexible bronchoscope and it will get into the segment of the lung, whichever is to be biopsied. After reaching there, you have to activate the cryo from the pedal for 3 to 5 seconds and then take it out with the third so that the lung is kind of broken from its place and comes out. So here you can see that the probe is being immersed in saline to thaw it so that biopsy tissue can be taken. So as soon as the biopsy is taken, the occlusion balloon is inflated. So now we are entering again to see whether there is any bleeding. So now you can see that the occlusion balloon is in correct place, occluding the lower lobe segments. So this should be kept in place for around 40 to 45 seconds so that whatever amount of bleeding has happened, so there is some degree of tamponade effect and bleeding does not spill into the other segments. So after the 45 seconds, you can deflate the balloon and look for the bleeding or there are any clots, and then you can proceed for next biopsy. We usually tend to take biopsies from different segments. So this is the biopsy which is obtained. The biopsy size may vary from 5 to 10 mm usually, and we usually take 2 to 4 biopsies for patients with interstitial lung disease. What are the complications? The complications in obtaining cryobiopsy, the mortality rate is usually 0.1%. The risk of severe bleeding is 0.3%, and risk of pneumothorax is 6 to 7%. Although some of the series have shown a pneumothorax rate as high as 25%, the risks of all these complications will vary depending upon the site of biopsy and the condition of the underlying lung. Whether you have a very cystic lung or a UIP pattern or a honeycombing, so you'll have a problem of pneumothorax in those patients. We also reported an uncommon complication recently where one of our patients, we had put in a balloon, but the balloon had ruptured during the biopsy, and then we had a spill of a lot of blood into the lung. So this was the way a rigid cryo-TBLB is to be done. There are other ways of obtaining cryobiopsy.
We are running late, sir.
Under the flexible, yes, sir, I'll just finish in a minute. Under the flexible also, so there are various techniques which have been described. And there are biopsies which can be taken up for the peripheral lung lesions also under the radial. So just to conclude, what I can say that TBLC is a promising modality, and correct patient selection is critical for the clinical utility. And before you take up this procedure, a training is essential so that the technique can be used safely. Thank you.
Thank you, sir. So Dr. Shushil, do you want to?
Yes. Thanks, Saurabh. Thanks for lovely and comprehensive talk on the lung cryobiopsy, because this is very increasingly going to be useful in our interstitial lung disease patients, where the risk of surgical lung biopsy is very high. And I'm looking forward for using it more and more in Indian perspective. So thanks for your comprehensive talk.
Thank you, sir. We will move on to our next panel discussion, that is recent update on use of positive devices in sleep disorder. And with us, the moderator said Dr. Arup Haldar. Dr. Arup is a senior pulmonologist, and along with Dr. Saurabh, Dr. Suresh Ramasubban, Dr. Dipankar Datta, sir will introduce them in the session. Sir, please start your panel, and this is a 20-minute session. Please be on time, sir.
Yes, thank you, Dr. Asif Iqbal. It's now 7:21, so we have to finish by 7:40. So thanks to Dr. Ashok Sengupta and Dr. Devraj Josh for this invitation. And our topic of panel discussion is recent update on use of positive airway pressure therapy in sleep disorder. Here in sleep disorder means we will stick to obstructive sleep apnea only. So American Academy of Sleep Medicine first published their practice parameter guideline to positive airway pressure therapy in obstructive sleep apnea in 2006, then further modification in 2007 and 2008. But since then, the scientific literature has continued to expand, and PAP adherence and advancement in device technology have continued to evolve. So American Academy of Sleep Medicine, or ASM, commissioned a task force of content experts and experts in the field to update and consolidate the previous ASM PAP practice guideline, which was due for long. And this was published in Clinical Practice of in Sleep Medicine in 2019. So this panel discussion is all about those recommendations. They recommended on 9 areas, and our panelists will update you about those things. So we have a beautiful panel today. We have Dr. Suresh Ramasubban with us, and he needs no introduction. We have Dr. Dipankar Datta. He's an ENT surgeon attached to Bellevue Clinic, and he's also a sleep surgeon and well known in the sleep field. And we have Dr. Saurabh Dash. He's a consultant psychiatrist attached to Medica, and he is also a renowned sleep specialist working in Kolkata. So my first question will go to Dr. Suresh Ramasubban. that the recent recommendation states that the positive airway pressure therapy should be given to treat obstructive sleep apnea patients with excessive daytime sleepiness. Why do you think that this parameter or the parameter with which we measure this excessive daytime sleepiness, that means the Epworth sleepiness scale, is given so important rather than the apnea hypopnea index or the desaturation index?
There are many reasons. I think thanks, Dr. Arupalda, for organizing this wonderful panel. It is, I think, one of the things that we have noticed a lot of times, and I think all of us in our practice notice that if you try to convince somebody to take positive airway pressure therapy when they are not sleepy, it is a humongous task. The compliance rates goes down tremendously. So that is one has always been noted. But what has been really noted recently with the Mosaic study and the other study, which has looked at cardiovascular consequences of sleep apnea in a non-sleepy sleep apneics. That's what they said. Non-EDS OSAs. The terminology that this American Academy of Sleep Medicine uses is a non-EDS OSA category of patients. So in the non-OSA category of patients, with non-EDS category of OSA patients, the benefits in cardiovascular outcomes which we expect or diabetes outcome which we expect are not seen. So there have been multinational studies. The Mosaic study is one of them which has not shown any benefit. So I think the only subgroup of sleep apnea, so as we've been hearing a lot of lectures on phenotypes of COPD, phenotypes of asthma, I think that we really need to look at this phenotype of sleep apnea who are sleepy and phenotype of sleep apneics who are not sleepy. So I think this is the phenotype in which the effectiveness is the most, the compliance is the most, and therefore the benefits are the most, and therefore the recommendation from a group of experts sitting across the board is that we should use it only in this group. It doesn't mean that you have to use it only in this group. It is just that this group is probably will derive the maximum benefit when you spend 50, 60, 70 days to start this thing.
So that means it is more of symptoms driven than the objective driven criteria like AHI. So my second question is to Dr. Dipankar Datta. The second recommendation states that the positive airway pressure therapy should be prescribed also in obstructive sleep apnea patient with impaired sleep related quality of life. So what is meant by actually this impaired sleep related quality of life?
We are aware of the term the quality of life, QOL. In case of sleep apnea, in the discipline of sleep disorders, the sleep-related quality of life includes few quality of life symptoms like snoring, choking coupled with arousals, then nocturia, then breath holding choking spells, bed partners problem because of the patient's snoring, then early morning headache, followed by impairment of the social life and performance inability, along with daytime fatiguability, that is the sleepiness and tiredness. And of late, AHI, that is our what I can say is panacea term in the treatment of obstructive sleep apnea. What is the AHI? What is the pre-treatment AHI? What is the post-treatment AHI? Even in from being an ENT surgeon or sleep surgeon surgical point of view, the AHI reduction has not been recommended as the only single criteria. Quality of life, whether after treatment, these symptoms are being improved or not, if the patient is happy, if the patient's sleep-related quality of life is improved, be it after positive pressure therapy or be it after myofunctional therapy will come later on or surgery, whether the quality of life parameters, the symptoms are improved or not, that is the paramount importance nowadays, rather more important rather than the objective AHI.
Yes, well taken. So that means the sleepiness score, the AHI, along with the sleep-related quality of life, all are important in evaluating the response to PAP therapy. Now, my third question goes to Dr. Saurabh Das.
Yes.
The third recommendation tells that positive airway pressure therapy should be given to OSA patients with hypertension. So what is your opinion about that? Does non-sleepy hypertensive patient will accept this therapy?
Okay, thank you, Arupda, first of all, for inviting me here. So let me just give you a very simple example. Say from times immemorial, we see that when a patient has gone to a medical specialist or a physician or a cardiologist with hypertension, the standard practice had always been like antihypertensives, and in many cases we see commonly that as like mild sedative like alprazolam or clonazepam is added also, so that the importance of good sleep in a patient with hypertension is very well noted throughout ages. Now ASM with their task force, and they also have done some randomized control study had been done, a few number, and they have concluded that those patients who have these hypertension along with obstructive sleep apnea, basically they seem to respond well and better with APAP therapy or as a treatment of the OSA, because OSA if left untreated, it causes multiple disruptions in the sleep cycle, sleep process. So if we can correct that sleep process by treating the OSA, the response to hypertension will be better, and that's why it has been given as a conditional recommendation in this particular paragraph. That will be my solution. Thank you.
Okay, but other studies have failed to show there is no cardiovascular benefit. That means it does not decrease the cardiovascular event or mortality. The result was inconclusive. So, what is your take on that?
See,
so
like
can it prevent?
No, see,
what is the practical experience?
Basically, what I feel is that hypertension is a very dynamic domain. No two hypertensive patient is very similar, and the same goes for OSA as well. So now, if you take two very heterogeneous conditions together, it is very difficult to always come up with a one-liner that this will always be helpful or this will not be helpful at all. So the idea is to choose on a case-by-case basis.
Okay.
But those patients who have resistant
hypertension. Your point. So the next question goes to you again, Dr. Shourab.
Yes.
The fourth recommendation tells that the positive airway pressure therapy can be given based on either automatic positive airway pressure titration or continuous positive airway pressure titration, which is done in lab.
Right.
So we have been given much more liberty of titration in regard to titration of the patient.
Yes.
So how do you actually start your PAP therapy in your patient?
Okay, so
how do you titrate the patient at present?
Thank you for the question. It's a very nice question, Rodha. Actually, I'd come straight to the point. Basically, this particular liberty was very much needed, I feel. Like, we have come a long way in the treatment and management of obstructive sleep apnea since a couple of decades. Like when I started my training and everything, we used to manually titrate each and every patient and give a fixed pressure recommendation to that particular patient. But gradually what we saw is that, and the same had been worldwide, is that a lot of the patients were more uncompliant to a continuous pressure at a fixed pressure level. So the reason being, every day the person is not sleeping equally tired. They can, some days the REM sleep can be a bit more, some days REM sleep can be a bit less. There can be, the person may have a couple of drinks at night before going to bed. So all these things make this process, or this dynamic process of OSA, like very in terms of the upper airway resistance that is being, like that the patient receives or faces. So that's why auto CPAP helps much better in that sense. That is one part. Regarding how we treat, basically, earlier I used to do the manual titration for almost all the patients. But for the last few years, what we do usually is that we do it only for selected patients who do not, who are not able to tolerate the auto CPAP well. And also, but basically for most cases, particularly uncomplicated OSA patients, we go for an auto CPAP trial at patient's home, where we give the device for 2 nights or 3 nights to use after proper demonstration, and then find out how the report has been and how the average pressure has been and everything. And based upon that, we sometimes set a pressure, sometimes we run it on auto mode only, depending upon the patient compliance. And I personally feel that this is, this is logistically much simpler, because to get a patient for a sleep lab in a level 1 study for 2 consecutive nights and 1 night doing the entire study, and the other night doing the titration only, is a huge wastage of resources. I think the ASM has moved in the very right direction in this regard, and I do support usage of APAP, of course, in the general cases. However, in certain cases like COPD and cardiac complications, we do still need to manually titrate each and every patient.
Yes, and that is a very important point. These recommendations actually excluded certain patients who are having central sleep apnea or obesity, hyperventilation syndrome, or post-sleep surgery. So those patients are not candidate for APAP titration. Otherwise, we use APAP titration. And during COVID era, it has become almost a mandatory case. We are not doing a in-lab CPAP titration.
Right.
So my next question goes to Dr. Suresh. For OSA, we use either APAP or CPAP. According to the 5th recommendation. So we have been given liberty to APAP or CPAP for selected patients, barring some patients like central sleep apnea or obesity hyperventilation syndrome, or COPD patients, or patients having other neurovascular problems. So what is more convenient for you? APAP or CPAP, and why?
As I said, as previously said, I think automatic CPAP. We used to do this. Problems we faced in a split night study was that we would never get adequate 8 hours to get a fixed amount of 4 hours. And to get a patient back for the second night has always been a challenge from the cost-effective perspective of a private practice. So it has always been that okay, if we are able to get a decent pressure, and if you're not getting adequate REM sleep during that adequate titration, so then the CPAP pressure that you're doing is not adequate. And most of our technicians, to be honest with you, have and don't have that are not that conversant in which they are able to titrate apneas and hypopneas separately. So we are able to titrate the apneas to some extent, but not the hypopneas to some extent. So what will happen is that the quality of the titration and the pressure is generally about 2 to 4 centimeters less than what is required, or it just varies a little bit. So I think automatic CPAP in the barn door sleep apnea is no doubt the way to go. The question is, we get people who are continue to be somnolent on CPAP, or the people whose pressures are on the automatic. When you download the data and you see the pressures are much higher, these are the kind of group of patients we say, okay, let's now get you back and let's look at your leg movements. Let's look back at you have any other PLMD or any other central sleep apnea or anything coming through which is preventing us from having you're sleepy with the CPAP. So those are the people on whom we say, okay, let me do a manual titration in a person who already has SSA. So persistent sleepiness in an auto CPAP is the only indication when I would say, okay, let me look at a fixed pressure. And anybody above 15 centimeter of pressures, again, I'm a little bit careful. Let me see if I can.
Yes. So the next question goes to you. Yeah. So next question goes to you again, from taking clue from this answer. The sixth recommendation states that either APAP or CPAP should be preferred over BPAP in OSA. So what are the situations when you prefer BPAP in OSA, or what type of interface do you prefer in those cases?
So as I said, I started off the last, I left it's almost like leaving a queue for myself. So anybody who requires more than 15 centimeters of pressure, it is difficult to breathe against it. So for the people who are listening to this, BiPAP, the term BPAP is better than BIPAP, which is proprietary. So bi-level positive airway pressure means that you're having two pressures. You're having an inspiratory pressure and an expiratory pressure. So what we generally do when we do a BiPAP is, when people find it much easier to breathe in from a, say, an IPAP of 16 to an EPAP of 14, even a drop of 2 centimeters is sometimes adequate for them to breathe out, and they feel that they can breathe out. While a CPAP of even 10 in a lot of people make them very claustrophobic because you can't breathe out against a pressure. So a lot of non-compliance, about almost 20 to 25% of our non-compliance with CPAP happens in this group of patients who are not saying that I cannot tolerate a CPAP. And this is a kind of group, before we say, okay, and his AHI is 60, 70, this is not a kind of people who are going to be amenable to any other treatment also. So this is one group of patients where we kind of drop the pressure and to may be able to do it. Once we do that, because there's a double level pressure, and if you keep your mouth open, there might be a significant drop in pressure and the cycling might be a problem. So whenever we use a BPAP, though it is not necessarily, you can still get away with a nasal, but an oronasal mask may be a better option when we do a BPAP. Obviously, other people like CSAs, central sleep apnea, complex sleep apneas, and or COPD are the other group of patients in whom we would prefer a BiPAP rather than a BPAP rather than a CPAP is what is the recommendation, and that's what we do. We do in practice.
So for BPAP, we always go for this oronasal mask. But the task force has also pointed that if you use APAP or CPAP, the nasal mask should be preferred. And there is no difference between nasal mask and nasal pillow, and there was no, the randomized controls trial has shown that. So for normal APAP or CPAP, we have to start with the nasal mask if the patient does not have an oral leak, or for BPAP, we have to start with the oronasal mask. So that was a take-home message for that. So my next question will go to Dr. Saurabh Dash. What educational intervention you give to your patient before starting positive airway pressure therapy? So would you like to add a cognitive behavioral therapy program before prescription of PAP therapy?
Okay, thank you, Rupda. So actually, my background in psychiatry helps me a lot in this particular aspect, I feel. Basically, what I do is that I give a thorough psychoeducation in the beginning, like as to what OSA is and how it does cause problem to the patient. And once the problem is well established in the patient's mind, they try to find a solution for that. So now I usually tell that how the CPAP helps and how it forms a pneumatic splint and all those stuff. And also I mentioned that it's like I try to bring a lot of commonalities with wearing a spectacle and using a CPAP. Like a lot of patients ask that, doctor, will I get dependent on this? Will I need to use it lifelong? Will I have a habit of using this? So these questions, unless solved then and there in a very proper, decent fashion, the patient will not be comfortable or compliant in CPAP. I do not have adequate data to support this statement at present point of time, but I have seen that those patients who have these nagging questions in their mind, they ultimately fail CPAP and they stop the treatment. So I try to explain to them in very simple terms as to what it is and how it will help you, and how much side effect free the device is if it suits you, and how it will help you to lead a normal and productive life. And of course, definitely I do not give CBTI or CBT components routinely to all the patients, but I think the very first step of psychoeducation is very important, at least in the initial 2 or 3 or 4 sessions when I have with my patients before starting, immediately after starting, and the first 2 or 3 follow-ups. By that time, people mostly get the gist, and those who are failures in that, for them, we have to go for a proper CBT thing.
Sir, we have to conclude.
Points will, yeah. So the last question will go to Dr. Dipankar Sarkar. So what are the troubleshooting you have observed for your patients? Okay, what are the troubleshooting? Just be very brief in answer. You have to conclude.
First of all, Arup, I am Dipankar Dotto. You missed my titles, so not Sarkar. I am Dotto.
Okay. Sorry. Sorry.
So, in extrapolation of Dr. Suresh and Dr. Saurabh's statements, in spite of the best possible effort to manage the interface, to enhance from the CPAP to BiPAP, and in spite of the best possible cognitive behavioral therapy or counseling to how to use the CPAP machine, many patients found CPAP intrusive, and they are non-compliant and non-adherent. The reason being fixed structural huge blockade at the level of the upper airway, like gross DNS or turbinate hypertrophy, or huge grade 4 kind of tonsil or retrognathia. For in this kind of fixed static structural upper airway obstruction, when the patient is CPAP non-compliant, definitely being an ENT surgeon, as a sleep surgeon, it is actually our prerogative to offer some fixed surgical correction like septoplasty or tonsillectomy or even maxillomandibular advancement to increase the box. That means our main target is to either reduce the content or to enhance the container. So sleep surgery has a big role to play in improvement of the CPAP compliance, number 1. Number 2, of late, myofunctional therapy is coming up in a big way all across the globe to enhance the tone of the upper airway structure, that is the palate, tongue, cheek, and the neck muscle. There are different sets of exercises, judicious, diligent exercises, enhance the tone of the upper airway pharyngeal muscles that helps in CPAP non-compliant patients, and for mild snoring patients, those who are actually not very good candidate of CPAP. And having said that, there are few other recommendations to enhance the CPAP compliance. Most important is telemonitoring and tracking the patient by cloud-based. Different kinds of industry are coming up. The constant tracking and telemonitoring is of utmost importance to make the patient adhere to CPAP. So surgery, myofunctional therapy, and tracking. These are my recommendations.
The points are well taken. So we have discussed all the 8 points, and the 9th point was about telemonitoring, and that's all. And thank you.
Thank you, sir.
Over to the organizers.
Thank you for a wonderful session, and thank you to all. We will move to next session. Our next session is Bongo with the moderator is Dr. Professor.
Sound went off.
Hello.
Hello.
Is my screen?
Yes.
Hello.
Yes, sir. Sir, you start.
Okay. This is Dr. Dhiman Ganguly.
how delayed is the program? You know, Dr. Sujit Rajan was supposed to speak at 7:35.
Hello. For 45 minutes, Nivanda. Delay.
Okay, in that case, leave me alone. You see,
Hello, can you hear me?
5 minutes
Yes, yes, sir.
is too much. I mean, it was supposed to be that it will start before 8:15.
Okay, all right.
Okay, sir. Okay. Sir, Dr. Joydeep Dev sir, start. Please start.
আমার যে একটা কোশ্চেন আছে, আমি ডক্টর পাল বলছি, ওই যেটা অপরচুনিস্টিক ইনফেকশন, ওটা কত দেরি আছে?
স্যার আমরা 40 মিনিট লেটে চলছি।
হ্যালো,
Can you hear me? Hello.
বলছি এটার পরে কি সেশন আছে? অ্যাকচুয়ালি ফুল প্রোগ্রাম পাইনি তো। হ্যালো, এটার পরে কি সেশন আছে?
এটার পরে হচ্ছে যে সেপসিস এন্ড এআরডিএস ফেনোটাইপ।
ও বাবা, তা তো অনেক 41 মিনিটের বেশি লেট আছে। ঠিক আছে,
প্লিজ স্টার্ট স্যার।
ডক্টর জয়দীপ দেব।
BPF.
Joydeep Dev, please.
Joydeep, Dr. Dev. Hello. Yes, can you hear me?
Yes,
we can hear.
Please start. You start. এটা গান মারছে করতে গেলে। Please start.
Please start, sir.
Shubhranu, where is Shubhranu?
Shubhranu, unmute yourself.
Yes.
You take the permission of Dr. Professor Dev and start the slides.
Sir, can I start the case, sir? Hello.
Professor Dev.
Sir.
Professor Dev may be muted.
Dr. Dev, are you with us? Joydeep Dev.
Hello, can you hear me?
Hello.
Dr. Joydeep Dev, we cannot hear you, neither we can see you.
Sir.
Can you hear me? Hello. Can you hear me?
Shivshodeep Dev. Is that you, Dr. Joydeep Dev?
Yes.
Yeah, please carry on. Here is Dr. Shubhranu Ghosh who will be presenting the slide. Shall we start the slides?
Yes, you start the slide. I think while presenting the slide, there will be some problems will be presented in between, and I will request Dr. Ashok Sengupta, Dr. Suranjan Mukherjee, and Dr. Amitabh Chakraborty to have their brief comments so that we can finish it in schedule. Dr. Shubhranu, you start.
Shubhranu,
Yes, sir. Thank you, sir, for the opportunity. I welcome you all to this panel, which is on the persistent diarrheal leak management. And Professor Joydeep sir will be moderating the session. And we have on the panel we have Dr. Ashok Sengupta, Suranjan Mukherjee sir, Amitabh sir, and myself. So this is a case. The next slide, please. This is a 35-year-old housewife who, with no previous comorbidities, presented with complaints of fever for 5 days, sore throat for 5 days, cough with expectoration for 5 days, and shortness of breath for 3 days, which is an acute presentation. Next. So the fever was of high grade and it was associated with chills and rigor. Generalized body ache and sore throat was also present, and 2 to 3 episodes of loose stool was also complained by the patient.
Dr. Parthojit Das, Dr. Shotis.
The next slide. And the cough was acute in onset, and it was dry to begin with, and it was which turned yellowish at the end. But no hemoptysis, wheezing, or postnasal drip was reported by the patient. Next. The breathlessness was acute in onset, which was progressive and was not associated with any postural diurnal variation, and which increased on exertion but was also present at rest. Next. The patient, however, also has a recent history of an outstation trip 5 days prior to the symptoms. She has no other comorbidities as said. She is a mother to a single child. And with these complaints and with this background and this acute history, she was admitted. And next. On admission, she was found to have an H1N1 ARDS, which didn't require an intubation, but she was on NIV and O2 support, and was given broad spectrum antibiotics and other supportive measures. Next. The high-grade fever was persistent. 5 days post-admission, she started having some right-sided chest pain. X-ray was done at that point of time, and which showed a right-sided hydropneumothorax and a mild diffusion, and for which the right ICD pigtail was inserted and pus was drained. The pus grew, the pus and the sputum both grew MRSA, methicillin-resistant Staphylococcus aureus. Antibiotics were continued as per sensitivity. Next. This was the complete pleural fluid analysis, which is a grossly exudative, highly polycellular and neutrophilic effusion, and which on routine culture grew Staphylococcus aureus. Next. This was the X-ray. After putting the ICD, we can still figure out that this is on the 5th day of her admission. On after the ICD, a big bore ICD was placed, but still there is a good amount of rim of pneumothorax which is still persisting, and the patient continued to have a stormy hospital stay, and she was continuing to be dyspneic. She was still having fever. Next. Yes, as I said, this expiratory air leak was persistent. Continue next. 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 Yes, and this was the CT scan. We can easily see there was a some amount of subcutaneous emphysema as well. In spite of a big bore ICD, there is a large amount of pneumothorax that was still persisting within the right side of the chest. She also though have a left-sided effusion as well, which later turned out to be, it was also an exudative effusion. It was drained by a pigtail catheter. Now at this next. Now she has been on now day 10 of his her ICD treatment, and the air leak is still persisting, which is grade 4, and is grade 4 according to the Serfolio's grading, and continuous air leak was persistent. The patient continued to be symptomatic. Now at this point of time, our think we should observe or we aggressively treat. Jaideep sir.
Now I will request our panelists to comment about it.
Okay.
Can you,
Shuranjan, I am giving my opinion regarding whether to aggressively treat or observe. There is persistent air leak now down the line 10 days, and this is the time usually we are worried about the possible outcome, whether we need to intervene surgically or whether to continue conservative management. And we, at this juncture of time, we usually take the opinion of our surgical colleague. Now, our surgeon, Dr. Amitabh Chakraborty, he couldn't come, but I was told that he has left his reply. Can we see that, please? Do we have anything like that? Otherwise, we will continue ourselves.
The organizers, there is a audio clip with you. Can you please?
Support team.
Support team. Can you please play
I think, sir, you continue.
Okay.
I think we should continue with our opinion. Then at last we will see the audio. We will hear the audio.
There is no hard and fast rule here. It depends upon the condition of the patient. If there is persistent air leak, there are several ways of measuring air leaks, quantifying the air leaks, and the most commonly what we do on the bedside, if we can grade it from 1 to 4. Grade 1 is if the patient has air leak even after a forceful expiration. Grade 2 is a ordinary expiration. Grade 3 is inspiration only, and grade 4, that is the highest grade. The worst scenario is the air leak is persistent both inspiration and expiration. That's a common bedside thing.
20 মিনিটের পরেই আপনার লেকচার আছে।
Asif, please stop the mic. And so this is the, if this is the scenario, and if that and as there is no hard and fast rule regarding when to intervene, I think this is the time we should take a surgical opinion. Now, regarding the most common cause in our setting, it could be actually this persistent air leak could be surgical or could be medical. In broader terms, surgically it is, for example, a pneumonectomy or any thoracic operation, mostly resection of lung that can give rise to the stump leak, etc. There are other possibilities for example, sharp injury to the chest, necrotizing pneumonia as we are dealing in this particular case, other kinds of trauma, for example, barotrauma. especially when the patient has to have prolonged ventilation with high PEEP, etc. So these are the basic scenarios where, and also radiation in the case of event of cancer, there could be radiation necrosis of the that particular segment of the bronchus. So these are the common causes in our setting. So next question.
I think Shubhranshu should continue. Then we'll come to the next questions.
Okay.
Yeah. Next slide, please. Yeah, according to as already enumerated by
These are the etiologies,
etiologies, we have already spoken about that.
Empyema, lung neoplasm, blunt and penetrating lung injury, and complication such as lung biopsy. Just in the previous occasion, we have seen that for cryo lung biopsy, that can be the possible cause. Yeah. Next.
Yeah. Next slide. Yeah. Also, we have taken in account of the ventilated patient requiring high PEEPs.
We have already mentioned it. Yeah.
Yes. Yeah. Next slide, please. Yeah, this is a general algorithm which we generally follow. First, we have to deal with the life-threatening complications such as the tension pneumothorax, aspiration, or the respiratory failure has to be taken care of. A good nutrition should be given. The pleural space infection has to be really well controlled. A drainage should be done, and proper antibiotics should be instituted as per the antibiogram. And there is also some guideline which says that there's a gray area though. The size of the according to the size of the fistula, if it is less than 5. We can try bronchoscopic management. If it is from greater than 5 to 8, a surgical management is generally needed. Next slide. Yeah. Now there are various kind of suction devices which has been made available in the markets and also in our hospitals. Some is electronic, some is driven by the suction by the bedside. What are the different various suction devices, or the role is controversial or they are beneficial? Sunil sir.
Suranjan, can you take up this question?
I think Dr. Suranjan, if you comment in here.
Sir, you have to unmute. Suranjan sir, you have to unmute. Yeah, it is.
Yes,
Right.
now we can hear.
As we can see, I mean, there are 3 suction devices shown. The first one on the top, that's the sort of classic, the 3-bottle way of where one end goes to the patient, another one to the suction device. The second one, which is sort of more easy to use, is this also a suction, but it has got 2 ports only. One goes to the suction and one goes to the patient chest tube. Now, it is very easy to handle, and the instructions are very clear. Now, the first 2 are actually analog devices, whereas the third one, that's the Topaz one, by Medela, that's a digital one. Now, it has got an advantage that it has got only 1 port, and it connects to the patient's chest tube, and it's actually a portable system. So the second and the third one are actually dry suction wet seal devices. Previously, we would go with the bottle one, and then the this Plurivac, the second one, and currently the digital system is in place. Now, regarding the evidence about using suction in persistent air leak or bronchopleural fistula, previous studies have failed to come at any consensus about whether they should be used. There had been about 10 RCTs, but they were using the analog system. And the endpoints were actually the duration of the chest tube that's kept in the patient, and the length of the stay, the hospital stay. Now, many RCTs failed to meet those criteria. Some of them showed some benefits. Now, why is the discrepancy? Probably difference in the methodology of the trials, difference in adequately monitoring or quantifying the air leak, and also if it is an alveolar-pleural leak, then suction probably might not be of much help. However, there has been a meta-analysis which incorporated about 10 RCTs, was published, I think, in 2018, which compared the analog system with the digital one. And they found some evidence in favor for the digital one. The endpoints were, of course, the duration of the chest drain,
the length of the hospital stay, and also attempts at clamping the drain. 7 trials met both these criterias. 1 trial met only 1 criteria, and 2 RCTs did not meet any of the criteria. We are yet to see any trial which has compared no suction versus a suction by a digital system, not to my knowledge. So till now, I mean, no consensus, but yes, the digital system shows some promise.
Okay, next.
Next slide. So proceeding with our case, actually we attached the digital system to our patient, and we see that the rim of the pneumothorax has subsided, and also she got somewhat clinically better. And however, the air leak was huge in the digital system. What we observed for last again for 3 to 4 days. Now next what? The next slide, please. Yeah. Now the thing comes, our localization of the leak. How to localize the leak actually from where she is leaking.
It is not that easy. If we are lucky, for example, if it is a post-operative case, for example, a pneumonectomy or a lobectomy, then it can be assumed that it is from the that operative site. It is easier. But in the medical conditions, for example, a pneumothorax, where the localization could be difficult because it is more distally placed airways, which are difficult to image and difficult to reach even by the thinnest bronchoscope. So there are several options, and the to how to localize the leak. And the popular option is to put a balloon inside individual bronchus and keep it inflated for about 2 minutes and see whether that drops down the air leak. And in this way, proceed from the proximal to the distal airways until you find out the actual leak. There are several other methods. For example, methylene blue. You can inject methylene blue, or you can inject the methylene blue and observe the appearance of the dye in the ICD, and then ventilation, scintigraphy, and all these things. So this is how you localize the leak.
Right.
Just next.
Next slide, please. Next slide, please. Yeah. Now localizing the seat, as sir already said, in postoperative is usually the stump.
Carry on. Next slide.
Next. Yeah, for this patient, we could look on the below CT. We can see there's in the middle lobe probably there is a leak. We could understand from the CT. Next slide. And we went for a sequential balloon obstruction, bronchus by bronchus, subsegment by subsegment, and we localized the leak in the medial segment of the middle lobe. Next. Now, what will be the various bronchoscopic methods to occlude that part? Sir, Jaideep sir, please.
Dr. Jaideep Dev.
Yes. So if we go for endobronchial route, so various bronchoscopic methods can be used. So I will request Dr. Sengupta to comment about it.
Ranjan, you better take this up.
Now, the various bronchoscopic methods are usually, I mean, it can be done by either the glues, the sealants, or the sometimes stents can be used. I mean, both has got its pros and cons, but this is the standard practice. Myself, I haven't done any sealing of persistent air leak myself. So I would request any of
Dr. Sengupta, have you any experience of using glue or something?
No, I don't have any experience with glue or something like that, but we have been told, and I have seen my colleagues using glue. For example, in this particular case, there has been success in localizing the fistula in the middle lobe, and as it was a small volume air leak, it has been successfully sealed with glue, and the patient's lung expanded.
Okay, then
next
the next slide. We should continue with the next slide.
Yeah, next slide.
As we have seen, there are several options. For example, glue, and there are some valves which can be placed, and the autologous blood patch fluorosis, or a combination of different kind of approaches. Next.
Next slide. Next slide.
Next slide, please.
Next slide, please. Next slide. Next slide. It is taking. Next slide. Yeah, now in this particular case, a spigot, Watanabe spigot was used, followed by an installation of the glue to seal the right middle lobe. Next slide. No, so there are various kind of spigots. These are customized. People has been using various studies at their customized spigots they have made, and this is the classical Watanabe spigot on the right hand side, which was used in our case. Next slide. Yeah, there were various kinds of valves which are used in as they're found in the Western literature, Zephyr valves and spiration valves. This is a one-way valves which collapses the distal segments by blocking the particular desired segment. Next slide, please. These are emplacer devices which were actually used for septal closure devices, but also been used embolized in the bronchus to stop the fistulous tract or the PPF. Next slide. The modified stents such as Dumont stents, which has a one limb closed and the other limb open, has also been used for various purposes and sealing the desired site. Next slide. Now, who are the surgical candidates and when and what are the outcomes? Dr. Amitabh is not here.
We are running shortage of time.
Yeah.
We are running shortage of time.
Yeah. Next slide, please. So management in ventilated versus non-ventilated patients and the scenario in current COVID pandemic, sir.
So this is always a challenge in ventilated patients. We are left with two big things. Number one, to stop the fistula somehow, and at the same time to keep the patient ventilated, and that involves a lot of positive pressure generation. So this is a difficult scenario. However,
sorry, Ashok, একটু জোরে slight একটু শুননা
and it's a difficult scenario because we have to generate the positive pressure to keep the patient ventilated. At the same time, we prevent the air leak. And here again, there are several options. For example, balloon occlusion or the occlusion devices, what we have used so far. And in the patients who fail all these conditions, then we have to take the surgical opinion. In the current COVID pandemic area, we have seen a lot of cases who come with air leak, persistent air leak, pneumomediastinum, pneumothoraces, and that is related to barotrauma. COVID can give rise to multiple cysts in the peripheral lung fields, and we have been we have to deal with a lot of these kind of cases. So that was another problem, and we have learned a lot how to manage this persistent air leaks, this bronchopleural fistula in the COVID pandemic. Thank you.
Next, I think it's and this was the patient.
Now I will invite Dr. Joydeep Dev to conclude the session. Dr. Dev, are you with us?
Most of the time, we treat fistulas conservatively by the proper maintenance of the antibiotic and ventilator setting, so that it comes out without any event. But it takes a longer time to cure, and very few cases we have to refer to surgical site to have an intervention. And even if we are the most problematic is the ventilated patients and the tubercular patients. And in both the cases, surgical intervention, we have to put your finger first about success. So ultimately, our patients and the combination of medical and surgical team gives the treatment of the bronchopleural fistula a success. Thank you all.
Thank you, sir.
Thank you, sir. Thank you,
Thank you, all panelists. It's a wonderful session. Now we will move to our next session, that is sepsis and ARDS phenotype and how we decide management protocol. We have learned a lot about sepsis, and we know is a genetic factor also, and that's why with us, the eminent faculty, this session will moderate by Dr. Shoren Paja. He's a director in the Department of Medicine and Critical Care Medicine in R.N. Tagore Hospital, Kolkata, along with other panelists, Dr. Sumit Roy, Dr. Deepak Govil, Dr. Vijay Mishra, and Dr. Yasis Paliwal. I will request Dr. Shoren Paja, please introduce other panelists and start the session, please.
Okay, good evening, Dr. Asif. and all the organizers for organizing and requesting me for this nice conference, as well as to moderate this session. And I think already we are going late, so I will not show much of the slide. Rather, what I want to first introduce my panelist, Dr. Sumit Ray. He was earlier my colleague in Delhi, and he is a big name in critical care society, not only society nationally as well as internationally in the critical care field. And earlier he was in Gangaram Hospital as a vice chairperson. Then there was Artemis Hospital, and right now he is working with the Holy Family Hospital. He is the director of critical care and allied services. Not only that, he has a big responsibility in the managing the hospital as well. And my second speaker, he will not be here, Dr. Deepak Gobil. He just intimated me he had another meeting in the ISSM for this critical care conference, so he has left. So he is also director of the critical care gastro critical care services in the Medanto Medicity Hospital, and also he is the current president of our ISSM Mumbai ISSM branch. ISSM chapter. And there are Dr. Bijay Misro. He is head of critical care as well as neuro anesthesia in Medica Ranchi Hospital. And with me, Dr. Yasis is there. Dr. Yasis is head of the department in the critical care in the our Fortis Hospital in Kolkata. So without wasting just time, brief introduction about as we know, almost 50 to 60% of our patients in the typical medical critical care unit are basically suffering from ARDS as well as the sepsis. These are you can say sometimes bread and butter, as well as our challenge, as well as you can say a lot of discussion, because since our interest in critical care as well as all the your whatever discussion, there will be sepsis. ARDS is one of the prime area. And in spite of that, we know that there are so many areas till day we could not explore. And if you find that sepsis patient in the defined area, they behave differently. And not only that, in spite of the other demographic profiles are okay, their ultimate outcome is also defined, as well as same thing is true for the ARDS also. So I will start from Dr. Sumit, because we have three panelists. Dr. Sumit, I will ask about what do you mean by phenotypic variant in sepsis and ARDS?
Thank you for the kind introduction, Dr. Paja. What we mean by phenotypic variance in sepsis and ARDS is based on the clinical response. That is how it has been differentiated of individual patients, different patients in different subgroups, correlated with their outcomes. And also, though it's called a phenotypic variant, a lot of work has been done related to the cytokine response also of these patients, and the different kind of inflammatory response that these patients show, the different variants showing different kind of cytokine response, and also different organ levels and different severity of different organ dysfunctions and outcomes in terms of mortality. That is the broad kind of definition that I could say. You have to unmute yourself, Paja.
So basically phenotypic variant, we are trying to find out how they are differing in terms of, sometimes we think that there should be some personal difference, individual difference between the patients as well as their outcome and behavior. So my next question with Dr. Yasis will be, Dr. Yasis?
Yes.
Dr. Yeah, okay. So what is the basic principles of this phenotypic classification in the sepsis patient?
Well, I guess if I were to look at basic types, is basically like Dr. Sumit said, whether how much immune response they are having. If we look at sepsis patients phenotypically in one of the recent study, they classify as simplest when they do not have much of organ dysfunction, but they are having sepsis as per sepsis 3 or sepsis 2 guidelines, and they are on antibiotic and cultures have been sent. And second group is one where they have chronic patients with renal issues. And thirdly, when there is an immune response and there is significant lung dysfunction and respiratory failure. And lastly, where they have shock, and liver dysfunctions. Of course, the mortality increases depending on how much individual patient is responding. Similarly, each patient responds differently based on their genotype and their immune response. As far as ARDS is concerned, therein we are looking at different sorts of phenotyping. If we are looking at whether it's a direct lung injury or indirect lung injury, or we are looking at whether the relation of the respiratory dysfunction based on physiology, which is based on PF ratio, driving pressures, or there is a dead space fraction or ventilatory ratio. So we are looking at different things. And lastly, we also have to look at what sort of whether they are hyperimmune response or hypoimmune response based on their clinical parameters, whether it's IL-6 or CRPs or procalcitonins or lactate in some of the study that is shown. So based on that, that is what we are looking at, and probably one size does not fit all. So we need to individualize the therapy, and that is probably one aspect of it that we have to look at. And probably that is the reason why we were not successful in demonstrating benefit in many of the RCTs which have been done for ARDS and sepsis.
Okay, so it has been, Dr. Yasis, it was nice explanation. So if you look simply, their behavior in terms of the clinical behavior as well as sometimes some of the genetics. So genetic we don't practice too much, as well as some of the biomarkers that we can see. So from different angle, so if we dissect all these cases, so there may be a difference in their behavior. So that is the way. So there may be different approach, different your type of the clinical dissection, as well as their what I can say biochemical or the neuromediator or the cytokine dissection. So after that we can divide them. And Dr. Bijay Mishra is you will have one question. So according to that principle, so what are the defined phenotypic variants in patients of sepsis we normally, or whatever evidence we have got, we have divided?
Good evening, Dr. Panja. First of all, thank you very much for asking me to be here. And good evening, my co-panelists. This topic that we are discussing today, the phenotypic classification or phenotyping in ARDS and sepsis, is essentially because of the fact that the population is such heterogeneous. The patients who come to us with these conditions are such heterogeneous. And the idea behind is to find some homogeneity among this heterogeneous population. And on the basis of that, so to create that homogeneous small populations, there was this, that Seneca project done in Pittsburgh, where they looked at the electronic medical records of around 20,000 patients to try and look for some similarity, some homogeneity of patients who did this way or that way, those who had good outcomes, bad outcomes, and other outcomes. So as Dr. Yashish Paliwal already said, that eventually they found that there were 4 different types of phenotypes, and they named it as alpha, beta, gamma, and delta. So I will not repeat all of them, but yes, what they found was that the alpha group, which is like the biggest population, approximately 33% of people having satisfying the criteria of sepsis definition, were in the alpha group, where the inflammatory markers were low, where the outcomes were good, they had the least of organ dysfunction. And there was this beta group, which was almost equal number of patients coming among these 20,000 patients that they looked at. But these people were the beta groups, were the people, those who were older and had.
Just don't mind. Make it short because of the time we will finish it.
Okay, so I'll just kind of I understand.
No, please carry on. But
I'll just enumerate the groups that they created: the alpha, beta, gamma, delta. The delta, fortunately, is the smallest number of people presenting to ER. only 10 to 15% of people were in the Delta group. That was the fortunate part of it, but unfortunately, they had the worst outcomes. They had the highest mortality. So this was one of the biggest project taken over, which again they replicated or rather validated in another 40,000 patients later on.
Basically, if you, Dr. Vijay is absolutely true. If you dissect this, even for the reverse et al., that early goal-directed therapy, then POISE trial, ARISE trial, okay. So in this trial, they had found that why there is difference in also outcome, that may be because of some of the phenotypic differences. So that may be the reason. So after that, there is my question to Dr. Sumit is, what is the basic principle of the phenotypic classification in ARDS patient, and how does it determine the outcome of the ARDS patient?
Right. So adding on to what was said, the phenotypic differentiation in ARDS is what has been done is most of the work has been done by Dr. Caroline Calfee's group in California. And what they determined is the severity of the inflammatory response and the parenchymal insult. Okay, so they differentiated into two types, phenotype 1 and 2. Phenotype 1 being with the less inflammatory one, where the the less shock, less parenchymal disease, requirement of PEEP was less in this, and these are the subset of patients, interestingly, who did better with lower PEEP, phenotype 1, lower PEEP, more fluids, more resuscitation with fluids, and lower PEEP, while those of the phenotype 2 who had a more severe inflammatory response, more acidosis, more shock, did better with less fluids and higher PEEP. And actually that same difference, and continuing with this, is the same difference has been found in L and the H type in COVID. If you say the terminology for L type is similar to the phenotype 1 with Caroline Calfee's group has given, and Gattiganoni calls it L type, and the H type is phenotype 2, Caroline Calfee's phenotype 2 is H type for Gattinoni. But just adding to that a little more to the sepsis response, sepsis phenotype, just a little bit. Actually, the phenotypes, this is just one study which has shown the alpha, beta, gamma, delta. But the phenotype differentiation for sepsis there has been a historical context to it. From 1990s onwards, Dr. Roger Bone, who was the defining author for the sepsis surge inflammatory response, etc., also talks about, and later Hotchkiss talks about, the different patterns of immune response. One subset has a very pro-inflammatory response cytokines, a younger patients, more shock initially. Then there is a CARS, or the compensated anti-inflammatory response syndrome, who have are elderly, which is the beta group in the new classification, with a more anti-inflammatory response. And then there is a mixed immune response, which is called the MARS, or in a dysregulated balance between pro and anti-inflammatory response. So this is a continuity. This new definition of the Seneca trial is a continuity of what was being studied from the 1990s.
Again, my question to Dr. Sumit, in spite of the so much of lung protective ventilation, so why these ARDS patient, the outcome, actually how these ARDS patients behave differently with the same lung protective strategy what normally we practice at the bedside?
Right. And that probably the phenotypic differentiation will help us differentiate why the same strategy does not work for everybody. And as we said in the phenotype 1, even with a lung protective strategy, phenotype 1, actually having small tidal volumes was not of benefit. Trying to use higher PEEPs or recruitment maneuvers were actually counterproductive. While in phenotype 2, the more pro-inflammatory one, there, lower tidal volumes, higher PEEPs, and using recruitment maneuvers would be beneficial. So that's why the different subset would have different outcomes in spite of the same, even if you use the same strategies. And that is why it is important in some ways to differentiate between that. Particularly, we saw that in the COVID pandemic also, if you remember, if you realize, Dr. Panda. Yeah.
Okay. So absolutely. So we have to find out that what is the heterogeneity. Not only that, the same disease as the time passes, their spectrum may change from one type to another type. They may change. So that type of dynamics we should keep it in our mind. My next question to the Dr. Yasis will be: is there any optimum time when we should actually try to find out this phenotypic assessment or the variants of sepsis or ARDS patient? because we used to find the get our defined patient at defined time frame. Some are coming to us at 24 hours, 48 hours. So is there any, I think that is the ideal time you think that can be used in our bedside for this phenotypic variant?
Yes, Dr. Paja. I think we can use either classical, the people who developed ARDS after 48 hours of ICU admission, or after, say, 48 hours of mechanical ventilation. I think a late development of ARDS is probably they will do worse as compared to the one who is straight away come and in ARDS gotten ventilated and get prone and other things. So they usually do better. The one who develops after staying in hospital or in ICUs and then develop ARDS, generally those patients fare worse. So I think that is where I would differentiate them, apart from the fact that if you have only focal lung issues as compared to you have more evenly distributed lung shadows and consolidation areas of consolidation. So of course, the one with the focal areas of consolidation will do better as compared to where you have more evenly distributed consolidation or patchy consolidation all over.
Okay. Dr. Bijay, can you just, if you can give some of the differences in phenotypic variants of the COVID ARDS versus non-COVID ARDS, because till now the pandemic is not over. So what is the basic difference of these phenotypic variants of ARDS because of other reason as well as the COVID patient ARDS?
Yes, sir. If we talk of the ARDS, of the multiple ways of phenotyping that they did in ARDS, one of them that they did was the hyperinflammatory phenotype of, I'm talking about the normal ARDS, non-COVID ARDS. So they classified it into a hyperinflammatory variant and a hypoinflammatory. And in a non-COVID ARDS, the hyperinflammatory was the bad one, where the inflammatory markers, IL-6, 8, they're all very high. People had longer ventilator days and higher mortality. Whereby the hypoinflammatory patients did better. But in COVID, they tried working on the same formula about the hyperinflammatories and hypoinflammatories. And what they find that even hypoinflammatory phenotype group had actually very high mortality rate. So it was, hyperinflammatory had high mortality, but even the hypoinflammatory, which did good in non-COVID, even they had a very bad outcome in COVID, meaning thereby that it was not just the inflammation, or it is not just the systemic inflammation which is killing. It's probably related directly to the lung in this case, which is killing the patients in COVID.
Okay. So in what we have seen actually gradually, even if you see the COVID ARDS, that is also changing day by day. And not only that, there are maybe some regional variation, but what it has, COVID has taught us that our understanding about the viral pneumonia, I think the characteristic to me gradually it is, I am coming to the conclusion that it is something that is basically in the broad category of viral pneumonia, and that is causing a defined type of problem, defined type of spectrum with the bacterial or other causes of the ARDS. So because some of the things initially they thought about that, okay, there may be some thrombus and and I think Dr. Saurabh is there. We did performed almost 8 cases of the histopathology post-mortem in the COVID patient, and none of the patients shown any kind of thrombus active infection. Rather, there is type 2 pneumocyte hyperplasia. So that may be a defined story. So my next, I will just discuss 2 questions and then I will just close this session. My question to Dr. Sumit will be, how can we stratify the treatment according to the phenotype nature of the sepsis patient?
Right. So probably what the evidence of that study, Seneca's trials, showed is that, and also our personal experience shows that the alpha group, which is the subset of patients with the lowest requirement of vasopressors, actually will do better with higher fluids, with the EGDT, goal directed therapy, with more fluids, more fluid resuscitation, while the delta group, which has actually more septic shock and has more liver dysfunction, and the subset with more kidney dysfunction, actually, or pulmonary dysfunction, the group with the pulmonary dysfunction, they do better with less fluids and early vasopressors. So EGDT, early goal-directed therapy in the group, Delta group, which has more liver dysfunction, more septic shock, and those patients with more pulmonary involvement actually do worse with more fluids. Probably they are the subset where vasopressors should be started early, and restricting fluids without being, too liberal with the fluids could be harmful. So this is how we kind of, those with more pulmonary insult, more liver insult, we tend to give less fluids, early vasopressors. Those with less of these organ dysfunctions, we can actually give. The subset of patients are also different. These patients which do worse with fluids are also more elderly and have also cardiac disorders, while the younger patients do better with higher volumes of fluid and they require less vasopressors. That would how I would be differentiating.
And next question, I will request Dr. Yasis to discuss. Excuse me.
Yes. Surendra, we are really shortage of time.
Okay, this is the last question. So just a question to Dr. Yasis as well as open. If anyone any comments on how often do we manage our sepsis and ARDS patient according to this phenotypic nature of the character disease? Dr. Yasis.
Well, I think
this is my last question.
Yes. So if we are looking at the cause of ARDS is primarily lung, then like we said, we want to give less fluids. Okay, we try to use PEEP judiciously, try to give less amount of the volume, limiting the pressures, and of course there's an interplay of that. Where is how much of the lung is baby lung, and what are your driving pressures, and what sort of
just I want to mention this is very techy here. How open means how many times you follow this type of phenotypic characteristics?
Oh yes, true. Means like I will say in the COVID patients, we generally give them very gentle ventilation without much PEEP, minimal PEEP and minimal pressures, and most of them did well. Majority of the time, I did not have to go to the H type unless they got a superadded bacterial infection. So yes, we do practice that. Unless you are in trouble, you won't go higher PEEP, isn't it? So I think it does dictate our the way we treat them.
Okay, Dr. Sumit, any comment about your practice with these phenotypes?
Just a quick comment on COVID. It was very interesting that the COVIDs where we used where it was required to use higher PEEP, where higher PEEP improved oxygenation, actually those patients did better, which is unlike what we used to get with bacterial ARDS, where we had to use low PEEPs and high FiO2. Those patients did worse actually in COVID. It's very interesting. Where we had to actually use higher PEEP to get better oxygenation, they did better. It was very opposite of what we had seen in bacterial sepsis leading to ARDS.
Okay. So I think I have finished my all the questions what I was intended to, and with this I thanks all my panelists for nicely explaining the whatever questions was there, and with this I want to close my session and thank you all to be here, and thank you, all my panelists.
Thank you, Asif.
Thank you. Thank you, sir.
Okay,
thank you.
Thank you, Shalanda.
For our next session, that is psychological distress after COVID-19 perspective of patient, and the eminent speaker is Dr. Joy Ranjan Ram. He is a senior consultant neuropsychiatrist in Apollo Clinicals Hospital, and the session will be moderated by Dr. Ashok Sengupta. He is a senior consultant pulmonologist and head of the Department of Pulmonology and Respiratory Critical Care in Apollo Clinicals Hospital. Sir,
yes, let me introduce Dr. Dayaran. As you have already seen, I can see Dr. Ram. Dr. Ram, can you please start the session? We are running short of time.
So thank you for inviting me. Without wasting much words, I think all of you are pretty tired throughout a long day. I will just share my screen.
Yes, we can see you. See the slides.
Can you see my screen?
Yes, sir.
Yeah. So basically, I will be very brief about the whole thing, psychological distress post-COVID. I think there's a lot written about when people are admitted with COVID, when people are worried about getting COVID. But my slides are very specific, and I'm thankful to Asif for specifying this, that it is this post-COVID, how do people respond? So, we know from past earlier lessons from the past pandemic that there is an increase in neuropsychiatric symptoms in the context of post-viral infection. And why I have put symptoms in red, it's because, in psychiatry, most of the symptoms are vague and non-specific. We diagnose a syndrome through pattern recognition. So in post-viral cases, there is a clustering of symptoms which looks like depression, but it may be anxiety, depression, malaise, fatigue, panic symptoms. So there are clustering of symptoms without any specific categorical diagnosis, often which we are unable to kind of make. And reports from the 18th and 19th century suggested that the influenza pandemics in particular have been marked by increased incidences of various late neuropsychiatric symptoms. So the pandemic is over, the people have got infected, 6 or 8 months down the road, there has been a variety of symptoms. So late neuropsychiatric symptoms after going through a viral infection is a known phenomena in medical history. Now, what is interesting is, what are the mechanisms? So I have gone through COVID and I have come to the post-COVID recovery OPD. I'm talking to my pulmonologist. I'm talking to my critical care specialist. What could be the reasons that now that I'm well, 3 months down the road, 4 months down the road, I'm having psychological problems? One is very obvious, my entire experience of going through COVID, the environmental stresses, which I will enumerate. But what is more interesting is the biology of the disease directly affecting the brain. So the infection, the virus, makes some changes in my brain biochemistry, which can have a late manifestation. The environmental factors are very, very obvious. There's a lot written about long COVID. I would worry about what has it done to my system. I'm Googling up a lot of information. I'm reading up about brain fog, depression, all those things, and I might be worried about it. I have also been worried that what would happen if I'm going to be reinfected. There is lack of effective treatment. Then obviously there is this whole information epidemic on what happens due to COVID. So therefore, even I'm out of COVID, I'm worried about my family members. If what happens to them, I might worry what could have happened to me, my brush with breath. So all these are causing, syndromal depression, anxiety, panic attack, even after I have recovered and come back home. Or even if I have been in quarantine, I'm suffering from those symptoms. Now, isolation is again a major environmental factor which can precipitate psychological problems later. I'm worried about my employment, that I'm no longer as effective in work. I might be laid off. What has happened to my business? When will it reopen? And obviously worries about future infection of my close, loved, and people whom I care about. Data from previous studies on SARS about 1 year on after 1 year on psychological distress indicated that survivors may develop more persistent psychological disorders with time after recovering from the infectious diseases, which I have just said. So, what is causing it? What is causing it? I think this is the interesting part. What we know now is that coronaviruses may induce cognitive, emotional, neurovegetative, and behavioral dysregulation through biological mechanisms, including direct neuroinvasion. That is one part. So it might affect my brain directly. The effects of it will be obvious for many months. Or, more importantly, it might be triggering of immune activation. What we know that there is significant scientific evidence of increased immune activity with depression and suicidal behavior. Many infections involving hospital contacts are predictively associated with suicide, and maximum behavioral effects can take more than 6 months post-infection to fully develop. So I have an infection and the neuropsychiatric symptoms emerge after 6 months due to immune activation. This is known as priming of cellular immune substrates rather than immediate effects. So what is priming? Priming is, if you just read through the slide, it will explain what is priming. Essentially, priming by immune activation that is triggered by infection may not necessarily induce persistent psychiatric syndromes in itself. So what happens is it makes us more susceptible to later stimulus which can cause depression. So my brain, because of immune activation, is more primed for the second hit, which can include other mild infections, concussions, airborne allergen, pollutant exposure, and psychological stressor. So my brain is already, due to priming, is more susceptible to neuropsychiatric disorders. And this can actually explain why in some situations the late manifestations can happen. And this slide again is, just reiterates that point. So the late psychiatric symptoms can be explained by self-perpetuated immune mechanism, or very importantly, persistence of the virus inside the CNS. Might be endothelial cells, resident macrophages, or monocytes. Now, when someone comes to the clinic 2, 3 months, 4 months after the episode and is presenting with neuropsychiatric symptoms, we don't know yet, science hasn't advanced as such, to which mechanism is working. Whether it is purely the environmental factors, whether it is due to priming, or whether it is the persistence of the virus inside the brain. So therefore, teasing apart these mechanisms is an important research goal for years to come. But I think we are not there yet. Now, just one simple point regarding many of us, when in these recovery clinics, come and we doubt whether it is depression or it is just a post-viral fatigue. This slide just kind of tries to differentiate between simple post-viral fatigue, anxiety, and syndromal depression. In syndromal depression, you also have what we know as a decreased hedonic tone, which means that I'm not responsive to my environment. I don't enjoy things as much. Suppose I used to go out and have a drink with my friends, I will not feel the energy to do it. Suppose I used to go out and watch a movie, I will not enjoy that anymore. So my hedonic tone is decreased. Then there is a negative appraisal of one's past, present, and future, and a low self-esteem that I am not good enough. Usually, these indicate that the person coming to you has a more serious syndromal depression rather than just a post-viral fatigue syndrome. So I think what is important, what is important for all those who are involved in looking after patients who are coming to the recovery clinic is to have a long-term view and keep in mind that psychological symptoms, neuropsychiatric symptoms can emerge 6 months or even later for a patient who has recovered from COVID. So, I will not kind of prolong my presentation because it's already quite late. But if there are questions, I would be happy to answer them. But I think the key point is, I think we need to be mindful about the mechanism and why this is happening. And that might help us to figure out why we need to keep a person who has recovered from COVID, in long-term follow-up with respect to the neuropsychiatric symptoms. Thank you.
I will request
Dr. Ram.
Chairperson.
Yeah, thank you, Dr. Ram, for your wonderful presentation, short but quite crisp. I can just add one thing, not only patients, but many doctors, many of whom have recovered from COVID. COVID and non-COVID doctors have as a whole, we also suffer from the same, more or less same symptoms, that is anxiety, feeling dissociated, as you said, away from this hedonic tone, etc., etc. So this is a global phenomenon, doctors and patients alike. Thank you very much.
Thank you, sir. We will move to our next session, that is newer frontiers in interventional bronchoscopy case-based approach. And with us, the eminent faculty speaker is Dr. Amit Dhameja. Sir is a senior consultant, Department of Respiratory Medicine and Interventional Pulmonology, Sir Gangaram Hospital, Delhi. And this session will be chaired by Dr. Debra Joss, is an interventional pulmonologist in in Apollo Clinicals Hospital, Kolkata. So I will request Dr. Dhameja, please start the session. Yes, sir.
Yeah. Am I audible and all of us are able to see the screen now?
Sir. Yes,
yeah.
Sir.
Good evening, Dr. Asif and Dr. Ghosh and the team. Wonderful sessions in the evening. I've been watching you throughout. And thanks again for the opportunity to be amongst you. Today, I will be talking about interventional pulmonology. Traditionally, pulmonology has been a predominantly medical field, from TB specialists to TB asthma specialists. I think what has really led us to become a super specialty has been our incorporation of, I think, most importantly, oncology, critical care, and then interventional pulmonology. So IP basically involves performing complex airway procedures, complex pleural procedures. They can be diagnostic, they can be therapeutic in nature. And of course, basically, we are doing traditionally what has been done earlier by only thoracic surgeons. And now all the facets of pulmonology coming from emphysema, effusions, asthma, COPD, infectious diseases like tuberculosis, lung cancer, and ILD. And interventional pulmonologists will have some role to play in either diagnosing these particular conditions or maybe helping in palliation or cure of these conditions as well. So what my talk, I will be basically focusing on 3 very difficult cases that posed very big challenge to our team at Gangaram Hospital, and luckily all the 3 cases we were able to deal with very efficiently. But let me begin with the disclaimer. What you are going to see now in the next 10 odd minutes or so, please, it is not for beginners. Be very sure that you are able to understand the anatomy, you understand the procedure that you do, you have the team with you. Team would comprise, your critical care people, your anesthetists, as well as your surgical team. You have to work in tandem to perform these procedures. And most importantly, the infrastructure in the hospital available to deal with these technically challenging cases. And most importantly, the patient and you as a doctor need to understand what you are going to do, The patient needs to understand all the options which are available to him before we embark on any of these procedures, and you need to have a proper informed consent before you start any of these procedures at your hospital. So just to start with the first case, we have a lady who is about 47 years old. She came to us a couple of months back with fever, chest pain, non-specific joint pains, weight loss. CT scan had shown symmetrical, non-necrotic mediastinal lymphadenopathy, looking classically like sarcoid. But she belonged to Rajasthan. She had a first FNAC at her native place in Rajasthan. I think it was Jaipur itself. And the FNAC slides were inconclusive for any kind of comment by the pathologist. They were, scanty material in that. Since the patient was very much afraid of, we normally would leave these cases because we think it occurred classically sarcoid, but of course lymphoma is one thing which is always in the back of your mind when you're dealing with these cases. This patient was referred to a center in Mumbai, and rightly so. They did an FNAC, EBUS FNAC, they did transbronchial lung biopsy. EBUS FNAC sample again turned out to be inconclusive because of scanty material, but unluckily even transbronchial lung biopsy revealed normal lung tissue. That's how the suspicion of a lymphoma in this particular patient grew, because even TBLB was negative in Mumbai. And this patient was referred to our center, Gangaram Hospital, for a thoracoscopic lymph node biopsy. After detailed counseling of the patient by our team and our surgical team, in fact, we all were convinced that since she has had 2 negative EBUS reports, we would rather go in for a thoracoscopic lymph node biopsy rather than trying EBUS again. But somehow the patient was just not convinced about the idea of undergoing a surgical procedure just to make a diagnosis. So that's when we came into the picture, and the patient was planned for a procedure in which we not only do an FNAC from the lymph node, we also do an EBUS biopsy from the lymph node. So the procedure of taking a biopsy from the lymph node with the help of EBUS is technically called EBUS intranodal forceps biopsy. Now, traditionally, it has been done by 2 or 3 means. We have a dedicated biopsy needle available, needle which is there in research, but it is still not available for commercial use. Of course, that needle had shown very good results, maybe invented a couple of years back, but it has not seen the market yet. Another, technically difficult procedure is when you drill a hole into the lymph node using a cautery knife, and through that cautery knife hole, you pass in with difficulty a biopsy forceps, a very thin biopsy forceps, and take a bite of the lymph node. And of course, the only issue is that when you are passing the passing the cautery, you are burning the lymph node. The tissue that you got was mostly charry, and it was not representative of the lymph node material that you really wanted to see. So with the availability of a 19-gauge needle, this is what we used in this particular patient. This was one of the first cases that we did at our hospital using this particular technique. The 19-gauge needle, if people are using, you would realize that it leaves a very big tract, and that tract is good enough to kind of accommodate a very thin bronchoscopic forceps, which you normally would get with the radial probe kit, the guide sheath, and of course, even couple of biliary forceps and a couple of choledochal forceps will be easily accommodated in the hole that you dig into the lymph node with the help of a 19-gauge needle. So this is a small video to depict what we did. We in fact went inside the lymph node. You would see first the needle going in, doing a couple of jabs. You do the needling 2 to 3 times and make sure that you puncture the same site in each attempt, so that the tract is ready for the biopsy forceps to be accommodated. And of course, you'll see a choledochal forceps or a biliary forceps, I think in this particular case, which we use to take a biopsy from the lymph node. So let us begin the video. You see a 19-gauge needle, FNAC, EBUS FNAC, all of you are familiar with the technique. The needle that you see is much larger than a 21 and 22 that we are using conventionally. You do take about 2 to 4 digs unless you are able to see the mouth of entry of the needle, and make sure that each and every pass is done at the same site. Now you are able to see this particular point where the mouth of entry of the needle has left an indentation mark. You know that you have to pass the forceps into this tract which is formed by the needle. In the first attempt, it can be very difficult because the forceps tends to slip out. The forceps is not as rigid as the needle. It tends to bend. And of course, if you have a cartilage there, it can be very difficult to penetrate. So make sure that you have good 2 or 3 jabs of the 19G needle and the tract is well formed, and you are able to see the tract sometimes in the ultrasound before you attempt passing the bronchoscopic forceps. So this is what the forceps would do. We were able to see the dimple where we had entered. We tried to pass the forceps in the same direction as the needle was going. It is a tedious job. You would be struggling a little bit initially, but in case the tract is wide enough, you should be able to pass the forceps directly into the lymph node, as you would see with the ultrasound screen coming up a couple of seconds. Now you are able to see the ultrasound. You see the forceps going in from here, just in the tract of the needle. The forceps you will see beautifully opening and closing inside the lymph node as well. You can see the jabbing process, and of course, you take a bite and come out. So when forceps is very small, so you would normally need about 5 to 6 jabs at least for you to give a decent specimen to the pathologist in case you are thinking of a lymphoma, because that would require a bigger tissue. You can see the opening and closing of the forceps very clearly. And of course, we were lucky to get a couple of jabs out of this particular lymph node. This particular lymph node, we were able to sample well. And this is how the specimen will look to you. The size of the biopsy is very small, but we were able to give them a cumulative size of about 0.2 into 0.2 centimeters, which was good enough for them to diagnose this particular case as a granulomatous lymphadenitis. We were surprised. We were expecting lymphoma throughout, but this patient was lucky. She was diagnosed with the granulomatous lymphadenitis with scant focal necrosis and is now under follow-up for sarcoidosis. So this is how we do an intranodal forceps biopsy, and this tell you it is a little difficult technique, preferably to be done under general anesthesia, because the patient is breathing constantly, the patient is coughing, and you need to have the puncture with the needle and puncture with the forceps at the right same point again and again. So better to be done under general anesthesia. In most of the cases, you will be able to give an answer. Next case, again, we are venturing into the surgeon's domain. We escaped a mediastinoscopy or a thoracoscopy in the earlier case. In this particular case also, we escaped surgery. Now, this is a case which came to us last year. This viral pneumonia is not COVID. We have done this particular procedure in COVID as well, but this particular patient which I'm showing you, which was also discussed by Dr. Ghosh in the preceding session on BPFs, it's the same case that we did at our hospital. This lady had a viral pneumonia, most likely H1N1 or influenza, I'm not remembering. She developed a right hydropneumothorax and she had MRSA in sputum, which was treated adequately. She had 10 days of ICD, despite which air leak persisted. And of course, thoracic surgery opinion was taken at that hospital. Lobectomy was contemplated, and therefore the patient was referred to our hospital. With this X-ray, you can see about 2 to 3 centimeters of rim of pneumothorax left, the ICD in situ, and patchy consolidation, maybe some breakdown of areas in the right middle lobe and right lower lobe. Patient was carrying a CT which had still a good enough rim of pneumothorax. She had subcutaneous emphysema. Despite the ICD being there, this particular lung was not infected. And of course, she had patchy consolidations in the right lower lobe. I'm not sure whether you're able to appreciate, there are small cavitary consolidations in the right upper lobe and a small cavitary nodules in the left upper lobe, of course, supporting the diagnosis of Staph aureus in the sputum that the patient had got. This patient was subsequently transferred to our hospital and, of course, continued on IV antibiotics. She was given bronchodilators. She was given other supportive treatment. We, of course, are not using any other negative suction. We are very happy using digital medulla negative suction in many of these cases with BPF, with a good 50% success rate at 15 days. This particular patient, also, we applied digital medulla negative suction attached to the right ICD. The medulla suction helped her a little bit. The antibiotics helped. The pneumonia is clear. The subcutaneous was gone. The patient was breathing better. But despite the presence of ICD and a negative suction device for about 7 odd days in a hospital, the lung did not seem to expand. And the subsequent X-rays clearly showed that there was a lesion in the right middle lobe. The right middle lobe had caseous necrosis. And there was this cavity which was seen to be opening into the pleural cavity, which was the cause of this persistent pneumothorax. And this patient was draining almost 1.5 to 2 liters of air in the medulla suction device as far as the digital scale is concerned. And we were quite sure that 7 to 10 days later, this patient would go for a lobectomy. We would not be able to save this patient without surgery. So rightly so, our surgeons were called and this patient was offered the surgery. But somehow, again, this patient was very, very reluctant. She was a young lady. She no contraindication of surgery, but somehow she refused the option of surgery, and we were left to think of bronchoscopic methods. Now, bronchoscopic methods in this particular patient can be difficult and, of course, can be risky because we are dealing with an infection. In case you block that area, the lung underlying necrosis, the cavity breaks out, we can have catastrophic seedling of the pleura. This disease can spread into the bloodstream, but of course, this patient was just not willing for surgery. So we resorted to bronchoscopic methods to close this particular air leak. Now, how do we localize the leak? We had used methylene blue in the past. We use blockers, of course, routinely, but the device which we found has, to be most effective and most helpful for us is again the digital medulla device, because by sequential blocking, if you see that the air leak is consistently reducing in one particular segment or maybe one particular subsegment, you are very sure that this is the site of leak in this particular patient. In this patient, of course, there was no doubt. You had the middle lobe, medial segment, and the lateral segment. You saw bubbling. You blocked each of them. And after blocking the middle lobe completely, the patient's leak suddenly dropped from 1.5 to 2 liters to less than 100 ml per minute. And that's how you recognize that the major source of leak was mainly from the middle lobe, and we are dealing with the rest of the lung, which was practically healthy, and all the consolidations going down. Again, I would substantiate this with the video. This is how the procedure is done. You see the biopsy forceps, which we have already passed through the working channel of the bronchoscope. And of course, 3 kind of spigots are available, 5, 6, and 7 millimeters in size. We have all the sizes available with us all the time to see, because each segment and each patient will behave differently. They would need different sizes of devices to fit in. And this is how the spigot is applied. This is again under general anesthesia. We are going into the middle lobe. We are trying to cannulate the medial segment of the right middle lobe. The spigot fits in beautifully. It has gone a little far. We are trying to pull it back, and now it is very snugly fit. So next, we will be blocking the lateral segment of the right middle lobe. The second spigot is going in with the help of the forceps, and we are able to plug the lateral segment of the right middle lobe. After you have a medulla device, within a couple of seconds of blockage, you start seeing a significant reduction. And of course, you know that you have done the job. It will take a couple of days even after this for the patient to get rid of the ICD. Of course, this is the glue being kind of sprayed over that to completely seal off this particular segment and reduce the air leak and chances of any extravasation of air through these pores or through the side of the spigot. Within a couple of days, this patient's leak reduced. 5 to 7 days later, she was observed for 5 to 7 days, followed up with a serial X-ray. This is the X-ray with which the patient was sent back home. She still had a little bit of leak. The ICD was still in situ, but now you see that after the performance of the procedure, the right lower lobe, the right middle lobe is opening. You can see the atelectatic band. I'm not sure whether you're able to appreciate, but you can see the spigots also. The pneumothorax rim has lessened, and you are seeing some kind of little thickening happening with the healing. If you just compare it with the X-ray of the patient with which the patient was admitted to us, you see a significant resolution. The patient was followed up. I think about 2 weeks later, the lung had completely expanded. We were able to remove the ICD. And this is the X-ray, this is the CT scan picture of the patient about a month after removal of the ICD, where you see complete healing of the lesions of Staph aureus, complete, apposition of the right lung to the chest wall. And of course, the patient was breathing very well with no residual defect at all in the functional capacity.
Sir, we are running late.
I'll finish it off in 2 minutes. So this is a very young girl from Nepal who had come to us with tuberculosis of the left main bronchus. She had this X-ray with her. We see herniation of the right lung into the left, complete collapse of the left lung with volume loss. We thought that the left lung would be bronchiectatic, but somehow this is the earlier scan when the ATT was started, where you see some opening in the left upper lobe. But this is the scan with the patient came to us with. You can see bronchoseals, but you do not see fibrosis yet. You do not see bronchiectasis yet. We still hope that we should be able to help this patient bronchoscopically. I'll just share a small video and we would end my talk there. So this particular patient had complete cutoff of the left main bronchus about 0.5 centimeter after the left opening. You can see 2 punctate lesions over there, one on the left, one on the right. If you have done bronchoscopies in these patients, all the segmental collapses would look like this. Normally, you would see some bubbling of air, some pus coming out, but in this particular patient, even after instilling fluid, we were not able to see anything, but we were very confident that the bronchus is beyond this. So we punctured this particular dead end with a biopsy forceps with a cautery knife to see that whether we are able to cannulate the airway, and we were able to puncture this. You can see some bubbles coming, you can see some pus coming. We were very sure that we have entered the left main bronchus. We just dilated the opening a little bit more and passed the whole catheter into the left main bronchus, and we were sure that we were not negotiating anything but the left main bronchus. Sequentially, this particular bronchus was dilated from 4 to 6 to 10 millimeters in diameter, and this is what the end result was. Let me just finish off the video. This is what the end result was. We were able to see the distal end of the left main bronchus. You can see the upper lobe, you can see the lower lobe. We cleared off the pus. The upper lobe again was opened up with a smaller balloon this time, and we were left with a very patent left main bronchus throughout. You can see this is the left main bronchus going in full 3 to 4 centimeters length. We were able to expose the left main bronchus, left upper lobe, and the left lower lobe completely. The stent was placed in the left main bronchus, and the patient went back home with this X-ray with left upper lobe completely open. Left lower lobe, you do see some atelectasis, some bronchiectasis, which is likely to remain. But of course, this patient, we were able to send back home this patient with an open lung.
Thank you, sir.
Thank you so much. Thank you so much.
Thank you, sir. And thank you, Chairperson. Dr. Devraj is here. We will move to on.
I'm here. Thank you, Dr. Dhamija, for excellent case presentation. And in future, we will want to hear more, and we will like to see more and more cases from you. All the 3 cases have been. And regarding the last case, it has been absolutely very much innovative. I haven't heard such a case which has been done regarding the last case, because in everyone's eye it will look as a destroyed lung, or it will look as a bronchiectatic, or probably an agenesis of the lung.
Thank you, Devraj.
Excellent.
We will move to the next session.
This was the pick of the whole lot.
Yeah.
Thank you, Dr.
Our next session is opportunistic pneumonia in immunocompromised host, and our for this session the moderator is Dr. Jyotirmoy Pal. Is a senior professor in Arjikar Medical College, and along with the eminent other panelist is Dr. Seli Samin, associate professor in Calcutta National Medical College. This is my college. I'm the ex-student of Calcutta National Medical College. And Dr. A. Ramani, and he's a long way from the California. I'm sorry, sir. This is an odd time. I have make you very late. And he's a ID specialist there. And Dr. Shomodip Chatterjee is a consultant ID specialist in Tata Medical Center, Kolkata. So I will request Dr. Jyotirmoy Pal sir to start the session, and we are already late. So please, sir, start.
Yes. Thank you. The session is very interesting and very important, and that is the pneumonia in a immunocompromised host. Immunocompromised host infection is not a new entity, but in the recent era, in the era of transplant, when the lot of immunosuppressed drug has been used, the entity or understanding of the infection or what type of infection, because we Indian we give more empirical management. So that is very important. When and how we suspect what type of organism may be the causative agent of a particular type of infection, immunocompromised host. So first I will request Dr. Shomodip Chatterjee, first you present your case, then we will go for the discussion.
Thank you, sir. Good evening, everyone. I'd like to begin by thanking the organizers for inviting me to this panel discussion.
So I was given an impression that I would have to present a case, opportunistic pneumonia in non-HIV immunocompromised host. Following this, there will be discussion. So I have prepared in such a way, and I'll try to be very compact so that we don't run out of time. So these are my declarations, and this is the outline. We would define what we want to, the topic. Then we would have some data from my hospital, case minute, and then some related updates. So, who are the immunocompromised hosts? Now, CDC defines immunocompromised hosts as those who have neutropenia, who are suffering from leukemia, lymphoma, HIV patients, generally, mostly those who are have CD4 count less than 200, post-plenectomy patients, solid organ transplants who are on lifelong immunosuppressants, or HSCT patients who up to 1 year, if they are not on any like suffering from GVH or any other immunosuppression therapy, they're having cytotoxic chemotherapy, post chemotherapy 6 months, and steroid dosing. The various papers have the various dose duration defined. So generally it is more than 16 milligram equivalent of prednisolone for more than equal to 4 weeks. So opportunistic infections, as we all know, are infections which occur more often and more severely in patients with weakened immune systems. So opportunistic pneumonia are generally caused by the most common organisms that cause opportunistic pneumonia in this group of patients include, as we all know, TB, NTM, pneumocystis pneumoniae, Girovesi is a common organism that causes pneumonia in immunocompromised hosts. Aspergillus, mucor, there's often the endemic fungi like Histoplasma, Coccidioides, viruses like CMV, DZV also causes pneumonitis in these patients. Influenza causes a good lot of mortality, and of late is coronaviruses. Parasites like Toxoplasma and Strongyloid should also be kept in mind. So this is the data from our hospital. As we said all about these organisms, being in India, we have to remember that the gram-negative drug-resistant bugs really kill. So we can all see that the carbapenem-resistant organisms, like Acinetobacter pseudomonas, they have a mortality of 30 to 60%. A gram-negative sepsis in our center had a mortality of 44%. So in comparison to that, a CMV in allogenic HSCT had a mortality of 2.3%. The data is 2 years old. So coming to the case. So this is all about a female patient who presented to the Tata Medical Center in 2018 with Hodgkin's lymphoma. She was taken up for auto transplant in September 2018, following which she relapsed in the April 2020 when an allo HSCT was planned for her. Mother was donor with 5/10 match, and it was the end of the year. The transplant was done with an engraftment of around on day 21 for WBC and day 26 for platelet. Now, the patient was improving when she started developing graft-versus-host disease, which was grade 3 on day 4 with involvement of skin, liver, and gut. She was managed with immunosuppressants. She was on appropriate prophylaxis, and things were looking brighter when around day D plus 77, he started having some PV spotting with hematuria that worsened gradually. And the ANC had by that time again dropped to 1000 with a low platelet count of 9000. So what could be the possibilities? So one possibility was that whether she was having a graft failure. A possibility was on the backdrop. It went to backdrop because the patient was on a lot of immunosuppressants at that point of time. The hematuria might have been due to thrombocytopenia or some cystitis due to common bacterial infections, or there was a possibility of BK virus. So the hematologist at that point of time had sent urine BK virus, and which came out to be quite high, around 10 to the power 11 IU per ml, and also had a BK viremia of 8,390 copies. The patient underwent multiple cystoscopic clot removals, and there was no, the immunosuppression was tapered off gradually, with no flare of GVH luckily. Hematologists at that point of time had started ciprofloxacin by themselves. Around day plus 84, hypoxia, tachypnea, tachycardia, all of these things worsened in an afebrile patient with no other localizing sign. The patient was shifted to the CCU and put on NIV, and a CT test was done. So what could be these possibilities? Now we have to remember that a CT like this in a post hematopoietic stem cell transplant patient can be due to infectious etiologies as well as non-infectious causes. So most commonly what went into their minds were PJP, and it can be CMV, it could be like COVID. So the CT reporting was made on CODAD scoring, but the patient turned out to be COVID negative. In fact, the 22 respiratory panel that includes all the common viruses and atypical bacteria came out to be negative. The patient was empirically started on meropenem teicoplanin with polymyxin B. Clindamycin primaquine was given for treatment of suspected PCP, and since the patient was already on posaconazole prophylaxis, she was put on liposomal amphotericin B along with nebulized colistin to combine with polymyxin B. Serum galactomannan, aspergillus PCR, blood cultures, procalcitonin, urine, everyone was sent, and a BAL was. So the revealed that the LFT was essentially normal. Counts hovered somewhere around ANC of around 850 to 970, with a platelet count of around 8,000 to 15,000. It was hovering around that. Urea creatinine were normal. The BAL revealed that the PCP PCR was negative. Cultures were all negative by that time. Aspergillus PCR was negative, but the BAL galactomannan was 0.81. Serum galactomannan came out to be 0.79 with a procal of 0.23. So it was taken that is probably an aspergillus, invasive pulmonary aspergillosis that we were dealing with. And at that point of time, the critical care consultants had stopped the PCP prophylaxis, de-escalated the antibiotics by stopping poly B and nebulized colistin, continued the patient on liposomal amphotericin B. But around 93rd day, there was further worsening of her respiratory parameters, and the patient was intubated and put on mechanical ventilation. There was no improvement of count, but other parameters did not reveal anything that could lead us to somewhere at this point either. So there was reinitiation of empirical polymyxin B with nebulized colistin by the ICU team. Repeat urine BK virus, which was hovered around 10 to the power 11 IU per ml as it was 2 weeks back. So was the viremia with BK virus. So CT was done again on next day, which showed further worsening with patchy consolidation, ground glassing, nodules, and left lower lobe consolidation and pleural effusion. So again, what could it be? So at that point of time, they were even thinking the rare entity of BK virus pneumonia. Now, at this point of time, the CMV viral load was undetectable, but on day plus 98, the repeat CMV was 13,335. So at that point of time, I was consulted, and we decided to put the patient on cidofovir, which would cover both for BK and CMV. So on 114 days, CMV viral load had reduced. I mean, around 2 weeks later, when we repeat the viral load, urine BK virus load had also reduced. So did the viremia. ANC was not still at a good level, but it was around 1200 with a platelet count of 25,000, which was giving us some sort of relief because the hematuria was resolving. Patient was still on mechanical ventilation, and some way she was holding on with no further improvement. So this was the update of yesterday. So what now dealing with this case, I was preparing, I found this is a recent paper in which we have come up with quite good phase 3 evidence that shows that posaconazole was non-inferior to voriconazole in treatment of invasive pulmonary aspergillosis with less chance of adverse events. So this is very important development. Letermovir in cytomegalovirus, this is in trial mode, not available in India, but it has shown to reduce the clinically significant CMV infection at week 24 with reduced all-cause mortality at 24 weeks with less toxicity essentially, and the cross resistance is not there with cidofovir or ganciclovir. So ciprofloxacin was tried in hemorrhagic cystitis with BK virus, and this paper was of 2011, which had showed that there was significant reduction of severe hemorrhagic cystitis in those patients who were initiated on ciprofloxacin prophylaxis early, and there was no increased Clostridium difficile that was found in this cohort. But later in 2014, this study revealed that in kidney transplant patients who were put on levofloxacin, there was really no difference between the levofloxacin group and the placebo as far as BK viruria or viremia was concerned, but there was increased chance of levofloxacin resistance. So IVIG in BK viremia has been tried, and it shows that the IVIG had some beneficial effect. It was not tried in this patient. Cidofovir, as we all know, works in BK virus, has evidence of efficacy ranging from around 47% to, in some paper, it shows 100% efficacy as well. Intravesical cidofovir is a new concept. Europeans have come up with this concept of using first line in intravesical cidofovir, which they say have a response rate of around 75%, symptomatic response rate obviously, and if it fails, then the escalation approach to IV cidofovir can be considered. Thank you. The panel is now, I think, open for discussion.
Thank you, Dr. Somajit, for your nice presentation, and you have opened a eyes to all the audience that how after hematopoietic stem cell transplantation, lung infection occurs, and what you have the BK virus, what you have presented, CMV lung infection is not uncommon in the post engraftment period, but the BK virus infection, BK virus usually is a latent virus, an immunocompromised state. It flare up. So I know time is short, but I have one question to our two panelists. First question to Dr. Shelly Shamim. Dr. Shamim, am I audible?
Yeah.
Yes. See, pulmonary infection after hematopoietic stem cell transplantation is not a uncommon entity. So, first question, why infection is common? And second, according to the engraftment period, what will be the usual organism in the different engraftment period after stem cell transplantation?
Timeline is important, definitely.
Yes.
Stem cell transplant, usually the first, before engraftment, there is neutropenia. So whatever infections we have are related to neutropenia, usual bacterial organisms along with resistant organisms, because these group of patients are often admitted for prolonged period. So hospital acquired infections of different gram-negative organisms, including the ESBL producers or maybe carbapenem resistant organisms. These are common in the first 3 weeks or before engraftment. And also might have some fungal infection also, like in lung, we are more concerned on Aspergillus, which is the most common fungal infection in lung. So that should be kept in mind even in first month or first 3 weeks before engraftment. And after engraftment, the things are different, where we have immunity, but there is a bit of lack of cell-mediated immunity, and the organisms that predominant thereafter are mainly the opportunistic one, like say CMV, obviously a possibility among the viral infection, along with other opportunistic virus like herpes simplex or herpes zoster. These are also can be seen. So that's why we use prophylaxis for them in our routine practice in transplant patients. And also we may have the pneumocystis in this time period that we should keep in mind. We may have again the fungal infections, not only the Aspergillus. Candida may be there, but Candida lung infection per se is not that common. Most of the time it is bloodstream infections from catheters or maybe urinary tract, or maybe abdomen also. But per se lungs it is not that common. So these are the these are the organisms that we see commonly in, and also other opportunistic rare infections may be there, as we have seen, maybe like nocardia, maybe like you see histoplasma in endemic areas where histoplasma is common. So these things need to be kept in mind.
So if I summarize, first 3 weeks or 30 days, basically due to neutropenia. So more a gram-negative bacilli or fungal infection. In a next 3 months, there is a defect in the cell-mediated immunity. So as cell-mediated immunity is important for the viral immunity, so more a viral infection, and then late it is basically the community-acquired infection. So more a bacterial infection.
Right.
So if we summarize the possible community different organism of different period, it should be like this. Very interesting. So now I am asking two question to Dr. Rahmani. Hello.
Yes.
Sir.
Yes, I'm here.
Yes. Question is regarding the BK virus. BK virus usually is a latent virus to human body. So that is why it is less discussed. But BK virus become important in a immunocompromised host, particularly after any transplant, whether stem cell
you have immunosuppressed population, especially post-transplant with high extent of anti-rejection medications and immunosuppressants, BK virus can be a problem. So one of the first things that can be done is to reduce the immunosuppressive agents so that the natural immunity will improve. And then there are only few medications that are really shown to be effective. We recently had a patient with BK virus viremia and bladder infection post-transplant, and whatever we gave didn't work, and ultimately reduction in the immunosuppressive agents worked. So BK virus is going to be more and more an issue. I predict that apart from transplant, we're going to be seeing increasingly more use of immunosuppressive agents for people are living longer with cancers, so we're going to be using more immunosuppressive agents for longer period of time. And also for these new non-malignant diseases, we are using immunomodulating agents. For example, rheumatoid arthritis. When I was in training, the only thing we had high dose aspirin. I don't know if you remember, we were using high dose aspirin. Then came up with the one that's being used for now COVID, hydroxychloroquine. We were using those agents as an immunostimulant, Plaquenil. And now we have a host of agents which are immunosuppressants and which can cause not only BK virus disease but also other viruses, fungi, and tuberculosis. See, in America, we don't see too much tuberculosis except in those where you're going to go as a Humira or Enbrel or something for non